Reproductive biology functions as a series of evolutionary engineering problems. Every cellular structure, temporal delay, and molecular interaction exists to solve a specific physical challenge. To build a new generation, a complex multicellular organism must securely transmit a diploid genetic code, evade total immune destruction by the mother's allogeneic environment, and establish a shared hemodynamic interface. We can track the solutions to these problems through a logical deduction model. It begins with the sequestration of the germline and concludes with the precise molecular quality control of a pre-implantation embryo. Every timeline and hormone we observe in the clinic serves to prevent the collapse of this delicate biophysical machine. Developing an embryo requires massive waves of paracrine signaling and epigenetic silencing to build somatic organs. If germ cells developed inside this rapidly differentiating tissue, their unmutated genetic blueprints would be exposed to constant physical and chemical wear and tear. To prevent this, the embryo utilizes a developmental cold storage strategy. In week 2, primordial germ cells are specified in the epiblast. They migrate out through the primitive streak to park in the yolk sac, returning in weeks 5 and 6 to colonize the primitive gonads. This follows precise chemical trails. If a PGC arrests in an extragonadal site, lacking gonadal signals, it attempts spontaneous development, producing uncoordinated masses of bone, hair, and teeth, known as teratomas. Cellular potential is governed by a landscape of epigenetic decay. The zygote is totopotent, capable of generating the complete embryo and the placental life support system. As cells progress, their options become mathematically restricted. PGCs are pluripotent, while the cells in the genital ridge are bipotent, restricted to becoming either male spermatogonia or female oogogonia. The early genital ridge is structurally ambiguous. The decision to differentiate into a testis or an ovary is governed by a genetic logic gate on the short arm of the Y chromosome, the SRY gene. If SRY is absent, the primitive medullary cords degenerate, and the cortical rind expands into oogogonia. If SRY is present, it acts as a transcription factor for the SOX9 gene. This suppresses cortical development and forces the medullary cords to organize into solid seminiferous cords, trapping the PGCs inside as spermatogonia. Spatial sequestration protects the pure genetic code from the chaotic signaling required for organ building. Evolution solved the problem of gamete fusion by splitting production into 2 radically different structural optimizations. The male strategy relies on numerical probability to overcome the sheer distance and chemical hostility of the female reproductive tract. This requires an automated, continuous cellular factory triggered at puberty by pulsatile GnRH. The factory operates on a 90-day maturation timeline. Driving a single spermatogonium through mitosis and meiosis takes 74 days, followed by 2 weeks of streamlining and transit to achieve biochemical mastery. A toxic insult like a chemical spill today will not show up in a semen analysis instantly because it kills the dividing cells at the start of the assembly line. It manifests as oligospermia roughly 2 to 3 months later. To prevent raw material depletion, the factory uses a stem cell renewal model. Symmetrical division ensures that one primary spermatocyte yields 4 spermatids. A round, heavy cell cannot swim, so the spermatid undergoes extreme bioengineering. The Golgi apparatus condenses into the acrosomal cap. Mitochondria migrate to the neck, twisting into a tight spiral. The distal centriole extends an axial filament, and excess cytoplasm is discarded. This streamlined vector, the spermatozoon, is physically released. It carries the paternal proximal centriole, required to organize the first mitotic spindle of the zygote. These haploid cells express foreign surface antigens that never existed during fetal development. Left unprotected, they would trigger immediate destruction by the male's own immune system. Sertoli cells establish dense, tight junctions to form the blood-custis barrier. This segregates the diploid spermatogonia in the basal compartment from the immunologically privileged adluminal compartment, where the maturing sperm are housed. The male strategy solves the distance and hostile chemistry of the female tract through sheer continuous volume. The female strategy trades numerical yield for extreme energetic payloads. Unlike the male factory, oogenesis relies on a depreciating inventory. All mitotic proliferation shuts down permanently by 24 weeks of intrauterine life. This creates a brutal attrition economy. Follicle counts peak at 7 million in the 5th month of gestation, dropping to 2 million at birth and 400,000 at puberty. Every cycle, 1,000 follicles are recruited, but 999 undergo atresia to allow a single dominant follicle to ovulate. The oocyte arrests meiotic progression twice to balance transcription and stability. The first arrest in prophase 1 is maintained for decades by oocyte maturation inhibitor secreted through gap junctions. This arrest can last over 50 years. Over time, structural tension on the meiotic cohesin rings degrade their integrity, driving the exponential increase in non-disjunction aneuploidies like trisomy 21 in advanced maternal age. The second arrest occurs at metaphase 2. Triggered by the LH surge, the oocyte refuses to complete division until fertilization is guaranteed, preventing the waste of its finite viability window. To preserve its resources, the oocyte executes asymmetric cytokinesis. It shifts its meiotic spindle to the periphery, yielding one massive mature ovum and discarding the extra chromosomes into tiny, non-functional polar bodies. This results in a cell 120 micrometers in diameter, the largest in the body, inside an 18 to 20 millimeter Graafian follicle. This massive target remains fertile for only 12 to 24 hours post-ovulation. The egg hoards mRNA and organelles because it must act as a self-contained life support pod for the embryo's first week of life. Fertilization occurs in the ampulla of the fallopian tube. It begins with capacitation, a 6-hour process where tubal fluids leach cholesterol from the sperm membrane. This triggers a massive calcium influx and hypermotility, turning the tail into a high-powered whiplash. The hypermotile sperm waves through the corona radiata and makes contact with the zona pellucida. It binds to ZP3 receptors, a strict species-specific molecular verification. This binding triggers the acrosome reaction. The sperm exocytoses hyaluronidase and acrosin to burn a microtunnel through the zona pellucida, allowing its equatorial segment to fuse with the oocyte plasma membrane and drop the male pronucleus inside. This physical breach opens mechanical ion channels, driving a calcium wave across the entire egg. This ionic shock wave wakes the oocyte from its metaphase 2 arrest, forcing the ejection of the second polar body. Within milliseconds, the egg engages a security lockdown to prevent a triploid zygote. First, electrical depolarization creates an electrostatic barrier. Then, the permanent slow block. The calcium wave causes cortical granules to dump enzymes that cleave ZP receptors, cross-linking the zona pellucida into an impenetrable wall. Fertilization is a secure, one-way biochemical gateway that prevents catastrophic polyploidy. Pre-implantation cleavage presents a unique physical paradox. Because the embryo is trapped inside the rigid zona pellucida, the cell number doubles but the overall volume cannot grow. The individual blastomeres simply get smaller with each division. On day 3, the embryo reaches the 12 to 16 cell morula stage, and the embryonic genome fires for the first time. On day 4, the morula drops into the uterine cavity. On day 5, sodium-potassium ATPases pump fluid into the center of the embryo to create a blastocele. This structurally segregates the outer trophoblast from the inner embryoblast. The embryo then secretes proteases to burn a hole in the shell, squeezing its body out through the rupture site. Movement of the heavy morula through the fallopian tube requires a balance between estrogen-driven ciliary beating and progesterone-regulated peristaltic smooth muscle. If this transite is delayed, the blastocyst will hatch inside the Merrick tube and invade the thin tubal wall, leading to an ectopic pregnancy. We see this in Carter syndrome, where immodal cilia fail. It occurs after pelvic inflammatory disease, when scar tissue traps the embryo, and with progesterone-only contraceptives that damp down peristaltic waves. Tubal transit is a perfectly timed conveyor belt. Any mechanical delay forces the invasive embryo to deploy its tissue-destroying mechanisms in the wrong anatomical location. Implantation is a controlled physiological invasion. It is restricted to the window between days 20 and 24, when peak progesterone suppresses uterine smooth muscle excitability. Human implantation is interstitial. The blastocyst burrows completely beneath the endometrial lining, allowing the luminal epithelium to seal over it like a healed wound. This invasion causes superficial capillary bleeding, known as Hartmann sign, and localized uterine bulging called Piskacek sign. Clinical verification relies on specific ultrasonographic landmarks. The gestational sac must be seen buried eccentrically deep within the endometrial stripe to rule out ectopic pseudogestational sacs. At 5.5 weeks, we look for the double decidual sac sign, 2 distinct concentric rings, proving the embryo is securely buried. Implantation proceeds through 3 molecular checkpoints: apposition via selectins, adhesion via integrins binding to maternal ligands like fibronectin, and invasion via matrix metalloproteinases that chew through the basement membrane. Maternal decidualization is a structural defense against this invasion. Progesterone causes stromal cells to swell with glycogen and lipids, creating a dense buffer zone. This partitions the endometrium into the decidua basalis beneath the embryo, the decidua capsularis covering it, and the decidua parietalis on the opposite wall. As the sac expands, the decidua capsularis is pushed across the uterine cavity. Between weeks 14 and 16, it fuses with the decidua parietalis, permanently obliterating the uterine void. Implantation is an allogeneic tissue invasion, strictly managed by the mother's decidual defenses. By day 8, the trophoblast divides into the inner mitotic cytotrophoblast layer and the outer syncytiotrophoblast. The syncytiotrophoblast is a multinucleated syncytium with no internal cell borders, making it impossible for maternal immune cells to squeeze through. This provides total immune evasion, while the layer secretes HCG to rescue the corpus luteum and HPL to induce maternal insulin resistance. The villus trophoblasts organize the structural cores of the chorionic trees, but extravillus trophoblasts, or EVTs, break away to act as vascular hit squats. They migrate deep into the decidua to track down the maternal spiral arteries. Maternal spiral arteries are normally narrow, high-resistance vessels. To protect the placenta from high-pressure jets, EVTs invade these arteries and destroy the smooth muscle. They convert the vessels into wide, passive funnels that cannot respond to maternal vasoconstrictive hormones. In preeclampsia, EVTs fail to reach the myometrial segments of the spiral arteries. The vessels retain their muscular walls, starving the growing placenta. The hypoxic placenta then releases anti-angiogenic factors that shred the mother's systemic endothelium, causing hypertension and proteinuria. The embryo is wrapped in 4 membranes: the chorion shell, the tough avascular amnion, the yolk sac for early hematopoiesis, and the allantois, which collapses into the urachus. This anatomy is the basis for membrane stripping. Shearing the membranes from the decidua lyses cells and releases phospholipase A2. This triggers a burst of prostaglandin F2 alpha, which ripens the cervix and sensitizes the muscle to oxytocin. These extraembryonic tissues engineer a complete takeover of maternal vascular resistance while maintaining a perfect immunological firewall. Pre-implantation genetic testing, or PGT, allows us to intercept the cleavage sequence. We use PGT-M for monogenic diseases, PGT-SR for structural translocations, PGT-A for aneuploidy, and PGT-HLA to match the immune profile of a savior sibling. An embryologist faces a thermodynamic trade-off between diagnostic information and biological penalty. Extracting a day 0 polar body carries 0 penalty, but is mathematically blind to paternal mutations. A day 3 blastomere biopsy tests the diploid genome, but removing a cell from an 8-cell embryo vaporizes 25% of its cellular machine, often causing cleavage arrest. The day 5 trophectoderm biopsy yields massive DNA with 0 harm to the inner baby, but is susceptible to confined placental mosaicism. Genetic quality control is strictly limited by the physical constraints of early embryonic metabolic capacity. The completed model reveals human reproduction not as a mystery, but as a completely solved evolutionary engineering equation. Teratomas are missed migrations. Delayed oligospermia is assembly line physics. Polar bodies are necessary trash cans for asymmetric cytokinesis. The syncytotrophoblast is an immune shield. An amniocentesis needle hits the chorion before the amnion. The pathologies in obstetrics and endocrinology mark the exact points where these tight biophysical tolerances hit their failure limits. Pregnancy functions as an active endocrine war. A genetically distinct fetal allograft invades the maternal architecture to extract resources, forcing the maternal body to fight to maintain its own baseline homeostasis. The syncytiotrophoblast is the primary endocrine factory for this negotiation. Positioned directly in maternal blood, This outermost layer of the placenta senses the mother's metabolic state and deploys hormonal countermeasures to manipulate her physiology. Survival over these 40 weeks depends on 5 biological milestones: rescuing the pregnancy, maintaining uterine quiescence, hijacking maternal metabolism, timing the delivery, and feeding the newborn. Every hormone secreted during gestation executes a specific logical imperative. This coordination allows a foreign allograft to hijack maternal physiology without triggering a fatal systemic failure of the host. The first crisis of pregnancy begins within days of fertilization. The corpus luteum, which keeps the uterus receptive, depends on maternal luteinizing hormone, or LH. When LH levels naturally fall, the corpus luteum normally degenerates, which would end the pregnancy before it truly begins. The fetal solution is HCG, a molecular mimic of LH that rescues the corpus luteum. Structurally, it has 2 subunits. The unique beta subunit is targeted by pregnancy tests, while the shared alpha subunit causes clinical cross-reactivity with maternal LH, FSH, and TSH. In a healthy pregnancy, exponential trophoblastic division causes HCG to double every 48 hours. At the 3,000 unit zone, a gestational sac must be visible on ultrasound. A slower rise indicates a failing or ectopic pregnancy, while extreme spikes indicate molar pregnancies. HCG peaks at 10 weeks, once the placenta can produce its own hormones. After delivery, it clears from the blood following a 36-hour half-life, becoming undetectable in roughly 3 to 4 weeks. HCG serves as the initial survival mechanism, a rapid response rescue flare that buys the placenta time to build an autonomous infrastructure. To prevent the maternal body from expelling the fetus, the pregnancy requires progesterone. It is the biochemical prerequisite for maintaining gestation and enforcing uterine quiescence. At 10 weeks, the luteal placental shift occurs. The corpus luteum fades as the placenta takes over progesterone production. Removing a corpus luteum cyst before 7 weeks triggers miscarriage, but by 10 weeks, the placenta is fully autonomous. The placenta imports maternal LDL cholesterol across the barrier to convert it into progesterone. Because it relies on this external maternal supply, progesterone production remains completely independent of a fetus. Progesterone induces systemic muscle relaxation. It relaxes the esophageal sphincter and slows the GI tract. This relaxation extends to the ureters, causing dilation and urinary stasis, creating an environment for bacterial growth and UTIs. Relaxin works synergistically with progesterone. It loosens pelvic ligaments and the pubic symphysis for delivery, often causing significant pelvic girdle pain. Relaxin also dilates maternal renal blood vessels, increasing the glomerular filtration rate by 50%. Instead, the fetal adrenal gland produces DHEAS, converted by the fetal liver, and finally aromatized into estriol by the placenta. This chain makes estriol the definitive marker of fetoplacental health. A break anywhere in this chain halts production. In anencephaly, the lack of fetal ACTH prevents DHEAS production, causing maternal estriol levels to crash. Failure also occurs in placental aromatase deficiency. The placenta imports fetal androgens but cannot convert them. This massive accumulation of androgens circulates back, virilizing both the mother and the fetus until delivery. Successful estrogen production drives maternal changes, increasing hepatic protein synthesis. This creates a hypercoagulable state and raises binding globulins, increasing circulating total T4 and cortisol. While progesterone indicates the placenta is functioning, estriol proves the fetus is alive and metabolically active. The fetus also initiates a metabolic takeover via human placental lactogen, or HPL. Its concentration in maternal blood rises linearly as the placenta grows. HPL has one objective: antagonize maternal insulin signaling. By physically blocking insulin receptors on maternal cells, it induces a state of maternal insulin resistance. As maternal glucose uptake drops, a surplus remains in the maternal bloodstream. This crosses the placenta, ensuring a constant energy supply for the fetus. To compensate, HPL triggers maternal lipolysis. The mother's body is forced to burn free fatty acids and ketones for energy, sparing glucose for the fetus. This mechanism complicates pre-existing diabetes. In the third trimester, peak HPL causes insulin resistance that dramatically increases the mother's requirement for exogenous insulin. Because HPL output tracks with trophoblast volume, low levels are a direct indicator of placental insufficiency or failure. HPL enforces a division of metabolic labor. The mother runs on fat so the fetus can monopolize the glucose. The placental clock controls the timing of delivery. Placental CRH stimulates fetal cortisol. In a positive feedback loop, that cortisol stimulates even more placental CRH. This escalating cortisol also drives fetal lung maturation, ensuring the lungs are ready for life outside the womb. Labor begins when a critical ratio shift occurs. Progesterone levels fall, ending uterine quiescence, while an estrogen surge triggers mass production of oxytocin receptors across the uterine muscle. This shift leaves the uterus exquisitely sensitive to contraction. The Ferguson reflex then executes the delivery. As the fetal head presses against the cervix, mechanoreceptors trigger the release of oxytocin from the posterior pituitary, driving a self-amplifying cycle of contractions. Labor is a calculated event, initiated only when the fetus is mature and the maternal uterus is fully primed. Feeding the newborn requires prolactin. While prolactin levels rise throughout pregnancy, lactation is blocked because high levels of estrogen and progesterone prevent the hormone from acting on the breast tissue. Delivery of the placenta causes these levels to crash. This removes the inhibitory block, allowing lactation and lactational amenorrhea to begin within days. From the first weeks to delivery, the hormonal sequence follows a singular logic. HCG rescues the pregnancy. Progesterone maintains it. Estrogen and HPL fuel the growth, and CRH and oxytocin execute the birth. Every hormone we have tracked executes a specific objective to ensure fetal survival, even when those objectives override maternal homeostasis. On day 5 of development, the human embryo arrives in the uterine cavity as a blastocyst. It is a hollow ball of roughly 100 cells that has just made physical contact with the uterine wall. At this stage, it has no internal circulation, no oxygen reserve, and no nutrient source. Without an immediate supply line, this cellular mass will undergo total necrosis within 4 to 5 days. Survival requires the blastocyst to execute 3 simultaneous biological imperatives. It must anchor itself to the uterine wall, it must actively invade the maternal vascular network, and it must construct a dual circulation exchange interface before its own internal circulation even exists. The mature placenta is the engineered solution to these specific existential threats. It is an aggressive, temporary organ designed to override the host's physiology and extract the necessary resources for survival. Upon implantation, the outer layer of the blastocyst, a trophoblast, immediately differentiates into 2 distinct populations. The inner layer, the cytotrophoblast, acts as a mitotically active stem cell reserve. The outer layer, the syncytiotrophoblast, serves as the invasion force. The syncytiotrophoblast lacks individual cell membranes. It is a continuous, multinucleated mass. By operating without cell junctions, it executes a mechanically unstoppable enzymatic invasion, dissolving the maternal endometrium without encountering structural resistance. This continuous cytoplasm also allows for rapid hormone transport directly into the maternal bloodstream, while evading immune recognition by hiding surface antigens. As the syncytiotrophoblast dissolves the endometrium, irregular spaces called lacunae begin to form within its structure. The enzymes erode the surrounding maternal capillaries, allowing maternal blood to fill these empty spaces. This establishes the primitive intervillous space. This schematic traces the 3-stage construction of the actual exchange infrastructure. By day 13, the inner cytotrophoblast cells proliferate and push outward into the syncytiotrophoblast. This creates a hollow cellular trunk known as a primary villus. 3 days later, extraembryonic mesoderm from the chorionic plate flows down into the core of this cellular trunk. This converts it into a secondary villus. The invading mesoderm provides structural scaffolding and introduces fibroblasts and angioblast precursors. Day 17 is the pivot point. Through a process of in situ vasculogenesis, distinct blood vessels differentiate within the mesodermal core. This creates a tertiary villus and officially initiates fetoplacental circulation. This precise sequence, starting with a cellular shell, reinforcing it with a mesodermal scaffold, and finally installing vascular plumbing, provides the physical infrastructure required for the entire organ to function. As the villus tree proliferates, cytotrophoblast cells from the tips of the anchoring villi break completely through the syncytium. They spread laterally along the maternal decidua to form a continuous cytotrophoblastic shell, which deploys a specialized invasion force known as the extravillus trophoblast, or EVT. EVT cells migrate in two distinct directions. One population migrates interstitially to physically anchor the placenta to the uterus. The second population migrates endovascularly, moving directly down inside the maternal spiral arteries to systematically destroy their smooth muscle and endothelial lining. This data visualization compares the hemodynamics of the maternal spiral arteries before and after invasion. By stripping away the smooth muscle, the EVT widens the lumen from 200 micrometers to as much as 1,000 micrometers. This converts high-resistance, jet-like arterial flow into a low-resistance trickle, drastically increasing total blood volume entering the placenta. Destroying the smooth muscle is a necessary defensive maneuver. It permanently eliminates the artery's ability to constrict. This ensures that sudden maternal hemodynamic fluctuations, caused by stress or hypotension, do not suddenly choke off the fetal blood supply. When this process fails, it triggers preeclampsia. In a preeclamptic pregnancy, the second wave of EVT invasion fails to reach the deep myometrial segments of the spiral arteries by week 20. The smooth muscle remains intact. Because the smooth muscle is retained, vascular resistance remains high, severely restricting blood flow. The resulting placental ischemia stresses the organ, causing it to release anti-angiogenic factors like SFLT1 directly into the maternal bloodstream. The resulting maternal high blood pressure is a symptom, not the root cause. Preeclampsia is a structural placentation disorder that manifests as systemic maternal endothelial dysfunction. Zooming out to the macroscopic level, this cross-section of the mature-term placenta reveals three distinct regions. The fetal-facing chorionic plate is covered by smooth amnion and carries the large stem vessels. Opposite it is the maternal-facing basal plate. Between them lies the intervillus space. The organ is functionally modular. Placental septa project upward from the basal plate, dividing the massive intervillus space into 15 to 29 individual compartments called cotyledons. If one spiral artery is obstructed, only a single cotyledon fails, leaving the rest of the organ fully operational. To prevent the trophoblast from burrowing completely through the uterine wall, the maternal immune system deploys Nidibux layer. This band of fibrinoid material sits exactly at the junction of the cytotrophoblast and the decidua, acting as a biochemical stop signal that strictly limits the depth of invasion. If the uterus has previous scar tissue, such as from a prior cesarean section, the normal decidua basalis is missing. Nidibux layer fails to form. Without this stop signal, the trophoblast continues to invade deep into the uterine muscle, creating the life-threatening hemorrhagic condition known as placenta accreta. By full term, the intervillus space holds roughly 150 milliliters of maternal blood at any given moment. This small volume is distributed across 12 to 14 square meters of villus surface area, creating a highly efficient exchange zone where the diffusion distance between maternal and fetal blood is less than 5 micrometers. To achieve this minimal diffusion distance, the terminal villi actively remodel themselves. The nuclei of the syncytiotrophoblast physically migrate and cluster together into dense syncytial knots. This leaves vast stretches of the cell empty of cytoplasm, forming ultra-thin vasculosyncytial membranes, precisely where gas exchange occurs. As fetal metabolic demand peaks in the third trimester, the intervening cytotrophoblast layer thins out and becomes discontinuous. The placenta actively reduces its own physical barrier to maximize diffusion rates when the fetus needs it most. The intervillus space is supplied by roughly 100 to 150 maternal spiral arteries. Their coiled corkscrew structure allows them to stretch and absorb the mechanical movement of uterine contractions without tearing. Blood enters from these arteries under significant pressure, creating a fountain effect that sprays upward toward the chorionic plate. The extreme pressure drop observed here is governed by Poiseuille's law. Because the EVT invasion doubled the radius of the arteries, vascular resistance undergoes a 16-fold decrease. Venous drainage back to the mother is entirely passive. It is driven by hydrostatic pressure gradients without the use of valves. When the uterus contracts, intrauterine pressure transiently exceeds arterial pressure, and fresh blood flow into the intervillous space comes to a complete halt. During a contraction, the blood already inside the intervillous space is momentarily trapped and continues to exchange oxygen. But if a contraction becomes tetanic, meaning prolonged and without a relaxation phase, no fresh blood can enter, and the fetus experiences sustained, dangerous hypoxia. To support this system, total uterine blood flow increases 15-fold over the course of the pregnancy, rising from 50 milliliters per minute to 750 milliliters per minute. Roughly 80% of this total volume is directed exclusively into the intervillous space. This creates a unique physiological vulnerability. Unlike the brain or the kidneys, the uteroplacental circuit possesses zero vascular autoregulation. The maternal vessels are now paralyzed, passive conduits. Because the vessels cannot constrict or dilate to manage flow, perfusion is entirely pressure-dependent. Any drop in maternal blood pressure, whether from hemorrhage or from the gravid uterus compressing the inferior vena cava when lying supine, directly and immediately reduces oxygen delivery to the fetus. On the fetal side of the circuit, blood travels through the umbilical cord. Two umbilical arteries branch off the fetal internal iliacs to carry deoxygenated blood to the placenta, while a single umbilical vein returns the newly oxygenated blood to the fetal heart. These vessels are suspended in a firm gelatinous substance called Wharton's jelly. They coil around each other an average of 40 times, an adaptation designed to absorb mechanical forces and prevent acute occlusion if the fetus moves or presses against the cord. In about 1% of pregnancies, either through failed formation or early atrophy, the cord develops with only a single umbilical artery. While often benign, this structural anomaly is clinically associated with renal agenesis and chromosomal defects. Normally, the cord inserts directly into the center of the chorionic plate, where forces are distributed evenly. But in a velamentous insertion, the vessels exit the cord early and run completely unprotected through the fragile amniotic membranes before reaching the placental tissue. If these unprotected velamentous vessels happen to cross the internal opening of the cervix, it creates a condition called vasa previa. If the amniotic membranes rupture during labor, these vessels tear. Because total fetal blood volume is only 250 to 300 milliliters, this leads to rapid and universally lethal fetal exsanguination. Assuming normal architecture, healthy fetal placental blood flow reaches roughly 400 milliliters per minute at term. To maintain this pressure, the fetal heart must dedicate 50% of its total cardiac output exclusively to the placenta. Clinicians monitor this circuit using Doppler ultrasound to measure diastolic flow in the umbilical artery. Normal flow is continuous, but if downstream placental vascular resistance rises, the elastic recoil of the fetal arteries cannot push blood forward during the resting phase of the heartbeat. This produces a waveform showing reduced, absent, or reversed end diastolic flow. These physical constraints dictate the limits of fetal viability. The mechanical security of the cord insertion, combined with the measurable vascular resistance within the villus tree, determine whether the fetus can successfully pull oxygen from the maternal supply. This diagram illustrates the geometry of the terminal villi. Within these microscopic exchange sites, maternal and fetal blood flow in strictly opposite directions. This establishes a highly efficient countercurrent exchange system. Countercurrent flow is mathematically superior to parallel flow. By constantly matching the most oxygen-depleted fetal blood against the most oxygen-depleted maternal blood, it maintains a constant concentration gradient across the entire length of the exchange surface. This allows fetal oxygen saturation to climb much higher, approaching maternal arterial levels. Molecules cross this barrier using specific mechanisms. Gases and lipids utilize simple diffusion. Glucose requires facilitated diffusion using glut transporters driven by maternal hyperglycemia. Amino acids, calcium, and iron are concentrated into the fetal plasma against their gradients, demanding active transport fueled by ATP. The placenta also acts as an immunological filter. The syncytiotrophoblast utilizes specific FcRn receptors to bind maternal IgG antibodies and transport them across via pinocytosis, providing the fetus with passive immunity. Simultaneously, it physically excludes bulky inflammatory IgM molecules. Gas exchange is further amplified by the double Bohr effect. As fetal carbon dioxide diffuses into the maternal blood, it drops the local pH, chemically forcing the maternal hemoglobin to release its oxygen. Simultaneously, the loss of carbon dioxide from the fetal blood raises its pH, aggressively increasing its affinity to bind that newly available oxygen. This is immediately followed by the Haldane effect. As the fetal hemoglobin unloads its oxygen, its molecular structure alters, expanding its capacity to pick up more carbon dioxide and carry it away from fetal tissues. The convergence of opposite spatial flow, specific protein transporters, and highly coordinated hemoglobin biochemistry creates an interface capable of extracting maximum energy and oxygen from a completely passive flow of maternal blood. Despite this profound level of molecular intimacy, the most critical architectural rule of the mature organ remains absolute. The maternal and fetal circulations never physically mix. They are permanently separated by the multi-layered placental membrane. The strict directionality of both independent circulations is enforced entirely by immutable pressure differentials. Maternal arterial pressure sits at roughly 70 millimeters of mercury, easily overpowering the 10 millimeters of pressure in the intervillous space. On the other side of the membrane, fetal capillary pressure sits at 40, driving flow steadily into the low-pressure chorionic vein. From the initial enzymatic melting of the decidua to the calculated destruction of the spiral artery smooth muscle, down to the precise countercurrent alignment of the terminal capillaries, every structure serves a definitive mechanical purpose. The placenta is the biological solution to the blastocyst's avascular crisis. By systematically rewriting the host's cardiovascular physics, it constructs the infrastructure necessary to sustain a separate human life. Obstetrical pathologies are predictable mechanical failures of a single physical system. Every complication within the gravid uterus is governed by the same strict laws of hydraulics and mass balance that apply to any fluid-filled container. This is the closed hydraulic axiom. The amniotic sac is a non-compressible fluid tank securely contained within an elastic muscular boundary. The mass balance axiom dictates that the volume inside this tank is the result of a continuous dynamic equation, input minus output. These two laws of physics allow for the logical derivation of every major amniotic fluid complication. Understanding the mechanics of the container makes rote memorization of clinical lists unnecessary. In early pregnancy, fluid originates from maternal plasma filtration across the placenta and transudation through the fetus's unkeratinized skin. This circuit shifts at the 20-week mark. Skin keratinizes and placental filtration slows, leaving fetal kidneys as the dominant tap. Fetal swallowing acts as the output drain. The fluid is absorbed through the gut and returns to the kidneys. After 20 weeks, diagnosing any volume abnormality is a matter of identifying which of these two primary pipes is broken. Total input failure leads to a dry tank, or oligohydramnios. The baseline for this is bilateral renal agenesis, where the kidneys fail to develop and urine production is zero. Anatomical blockages also stall the system. In a male fetus with a posterior urethral valve, a physical fold of tissue obstructs the urethra. Urine is produced, but it cannot exit the bladder. Backward pressure from this valve distends the bladder and the proximal urethra. On ultrasound, this creates the specific keyhole silhouette that signals the level of the obstruction. Pharmacology can also collapse this tap. ACE inhibitors dilate the efferent arteriole, while indomethacin constricts the afferent arteriole. Both drugs drop the glomerular filtration pressure, effectively turning off the kidneys. In cases of placental insufficiency, the fetus enters an asymmetric brain-sparing state. It vasoconstricts the vessels to the gut and kidneys to protect the brain, sacrificing urine production as a survival trade-off. These functional failures contrast with PPROM, which is a purely mechanical puncture. The fluid drains through the cervix faster than it can be replaced by the kidneys. Whether caused by a genetic defect, by a pharmacological drug, or a physical rupture, the terminal result remains the same: a dry tank that robs the fetus of its primary protective buffer. Blocking the output drain causes the tank to flood. In duodenal atresia, the gut is blocked just past the stomach. Swallowed fluid is trapped, halting absorption and causing fluid to accumulate in the amniotic space. The double bubble sign is the radiological signature of this blockage. It shows the stomach and the proximal duodenum side by side, distended by trapped fluid, a finding frequently associated with trisomy 21. Input excess can also flood the system. In maternal diabetes, high glucose levels cross the placenta and trigger osmotic diuresis in the fetus. This results in fetal polyuria, overwhelming the swallowing drain. Polyhydramnios occurs during high-output cardiac states driven by fetal anemia. The heart pumps more blood per minute, increasing capillary hydrostatic pressure. This pressure forces fluid out of the vessel walls and into the amniotic space, contributing to the generalized fluid leak known as hydrops fetalis. Raw body wall defects like gastroschisis further increase volume. Without a covering membrane, the exposed vascular surfaces of the bowel allow for continuous plasma transudation directly into the tank. These anatomical and physiological pathologies result in polyhydramnios by overwhelming the fluid circuit with excessive osmotic or hydrostatic pressure gradients. Fundal height measurements project total uterine volume onto a linear distance. Because the fetus and placenta remain relatively stable in size, this measurement primarily tracks fluctuations in amniotic fluid levels. During labor, oligohydramnios removes the fluid cushion. Without this buffer, the contracting myometrium directly crushes the umbilical cord, causing acute hypoxia and variable heart rate decelerations. In Potter sequence, the lack of fluid leads to a purely mechanical deformation. The uterus shrink wraps the fetus, flattening the nose and ears and locking the feet into fixed clubfoot positions. This mechanical compression also arrests lung development. Without inhaled fluid to physically stretch and branch the alveoli, the lungs remain too small and immature to sustain life after birth. In polyhydramnios, the extreme volume overstretches the uterine muscle. This triggers the myometrial stretch reflex, causing irritability that often initiates preterm contractions and labor. This overpressurized tank also makes cord prolapse more likely. If the membranes rupture while the fetal head is unengaged, the sudden rush of escaping fluid can violently flush the umbilical cord past the fetus and out through the cervix. Catastrophic morbidities in labor are the predictable consequences of losing the hydrostatic cushion or violating the mechanical limits of the uterine wall. Amniotic fluid color acts as a chemical readout of the fetal state. Meconium staining occurs when hypoxia triggers a vagal surge, overriding the anal sphincter and expelling green bowel contents into the fluid. Brown tobacco juice fluid indicates intrauterine death. This color reflects the time-dependent degradation of hemoglobin and other products of cellular autolysis leaching into the tank. Yellow fluid is a common finding in post-term pregnancies. As placental function declines and fluid volume decreases, normal bilirubin output becomes increasingly concentrated. In Rh incompatibility, massive immune hemolysis dumps high concentrations of bilirubin into the tank, resulting in a golden fluid. This concentration is measured through spectrophotometry. By measuring the absorption peak at 450 nanometers, clinicians can precisely quantify the degree of fetal red cell destruction. Amniotic fluid color serves as a precise biomarker timeline, reflecting the history of the fetus's oxygenation and red blood cell integrity. Fluid measurement uses two mathematical philosophies. The amniotic fluid index averages 4 quadrants to track chronic placental health, while the single deepest pocket acts as a binary check for a functional pool of fluid. AFI is mathematically invalid in diamniotic multifetal gestations. You cannot perform scalar addition across a diagonal biological membrane, as the resulting sum fails to reflect the volume of either individual tank. Rapidly draining polyhydramnios can trigger the abruption trap. The sudden loss of pressure causes the uterine muscle to recoil, but the inelastic placenta cannot match this change. The resulting shearing force can physically tear the placenta away from the wall. To manage volume, indomethacin functions by stopping contractions while simultaneously constricting the renal afferent arteriole to crash fetal urine output. This intervention requires a hard stop at 32 weeks. At this stage, the fetal ductus arteriosus becomes hypersensitive to prostaglandin levels. Giving the drug too late can cause the valve to slam shut in utero, leading to right ventricular failure. Obstetrical interventions are strict, high-stakes negotiations with the limits of fetal rheology and tissue maturation. The diverse landscape of amniotic fluid pathologies maps cleanly to 3 physical mechanisms: input failures, output obstructions, and capillary pressure leaks. Clinical disasters, from facial deformities to catastrophic cord prolapse, follow directly from these mechanical violations of the hydrostatic cushion. Mastering the foundational biophysics of mass balance and hydraulic pressure transforms these pathologies into a single system of predictive logic. A new organism is growing, entirely dependent on the maternal circulation for oxygen, nutrients, and waste removal. To keep it alive, the maternal body must simultaneously maintain its own homeostasis and construct a massive parallel supply system for the fetus. Every anatomical and chemical shift in pregnancy traces back to this single engineering challenge. To solve it, the body relies on 4 strict operational axioms. It expands, it relaxes, it compensates, and it protects. The body expands its blood volume, cardiac output, and organ size because the fetus demands massive resources. Simultaneously, it relaxes smooth muscle tissue globally. The uterus must not contract prematurely, and relaxing smooth muscle in one system inevitably forces others to yield. Because expansion and relaxation distort normal function, the lungs, kidneys, and bone marrow must actively compensate to keep the mother alive. Finally, the body protects. It builds specific defense mechanisms against ascending infections, premature expulsion, and the severe risk of peripartum hemorrhage. Discard the concept of pregnancy side effects. Nausea, swelling, and breathlessness are the calculated outputs of these 4 processes. Before analyzing a single organ system, we have to map the hormonal architecture that drives all of this. It operates primarily on a binary, starting with progesterone. Progesterone is the maintenance hormone. Its primary mandate is to make the uterus hospitable and quiet, but it does not limit this effect to the uterus. Progesterone relaxes smooth muscle everywhere in the body. It also directly sensitizes the respiratory center in the brainstem to carbon dioxide. Opposing and complementing this is estrogen, the growth and vascular hormone. Estrogen drives vascular dilation and structural growth. It stimulates pigmentation by increasing melanocyte-stimulating hormone. It forces the liver to produce massive amounts of binding proteins. And interestingly, despite high levels of prolactin, estrogen is the exact chemical that actively blocks milk production during pregnancy. This creates a highly predictive rule. When you encounter a pregnancy change, check the mechanism. If it involves slowed transit or reduced muscle tone, progesterone is at work. If it involves structural growth, pigmentation, or vascular dilation, you are looking at estrogen. The skin provides the clearest external readout of rising estrogen levels. Estrogen stimulates increased activity of melanocyte-stimulating hormone, or MSH. This drives melanin deposition in predictable areas. The linea alba, a structural boundary on the midline of the abdomen, darkens into the linea nigra. Sun-exposed areas on the face darken into chloasma gravidarum, often called the pregnancy mask. Estrogen also directly increases vascular reactivity in superficial vessels. This dilates the highly vascularized palms, causing palmar erythema. It also produces spider nevi, dilated arterioles with radiating vessels, primarily across the face, neck, and upper chest. These are the exact same vascular lesions seen in liver disease, where the liver fails to metabolize estrogen, causing it to accumulate. Not all cutaneous changes are hormonal. Stria gravidarum, or stretch marks, are strictly mechanical. The abdominal wall stretches faster than the dermal collagen can remodel. The dermis tears microscopically, producing pink lines during an active pregnancy. Over time, these organize into scar tissue, fading to the silver-gray lines known as stria albicantes. These changes are visual proof of a system rapidly increasing its vascular capacity and stretching its structural boundaries to accommodate internal mass. The uterus starts as a small, pear-shaped pelvic organ. By term, it is an 1,100-gram structure occupying most of the abdominal cavity. Early on, this is driven by hyperplasia, actual cell division. Later, it shifts entirely to hypertrophy, as existing myometrial cells massively enlarge and fill with contractile proteins. As it grows, the uterus cannot expand symmetrically. The sigmoid colon occupies the left posterior pelvis. The path of least resistance is rightward. The uterus dextro-rotates, or twists clockwise. In doing so, this heavy mass presses directly into the right ureter. This mass demands an astonishing volume of blood. Uteroplacental flow rises to 750 milliliters per minute. The placenta functions as the fetal lung, gut, kidney, and liver all at once, requiring a massive cardiovascular expansion from the mother to supply it. At the base of this organ, the cervix must stay firmly closed for 40 weeks, then soften to allow delivery. The massive vascularity required for pregnancy engorges the cervix, turning it a congested blue, Chadwick's sign. As the cervix enlarges, its fragile red inner lining everts outward onto the visible surface. This is ectropion, and it explains why benign postcoital bleeding is common. Below the cervix, the vagina constructs a chemical fortress. Estrogen forces vaginal cells to accumulate glycogen. Commensal lactobacilli feed on this, producing lactic acid and driving the vaginal pH down to 3.5. This highly acidic environment is a deliberate defense mechanism against ascending bacterial infections, though it predisposes the mother to Candida albicans, or thrush. The breast prepares for lactation through a strict hormonal sequence. Estrogen and progesterone build the ductal and alveolar architecture. Prolactin levels rise steadily, yet no milk is produced. High circulating estrogen blocks prolactin at the tissue level. The brakes stay on until the placenta delivers, estrogen crashes, and milk production begins. Meanwhile, Montgomery's tubercles enlarge to lubricate and protect the areola. The reproductive tract expands to house the fetus, reroutes blood to feed it, and alters its microenvironment to repel pathogens from the entry point. Looking at this dual bar chart, we can see exactly how the physiological paradox of pregnancy anemia works. Plasma volume increases by up to 50%. Red cell mass increases by only 30%. The liquid expands faster than the cells. Hemoglobin concentration falls, but as the math shows, the absolute total mass of hemoglobin in the body is actually higher. This hemodilution is highly intentional. The uteroplacental circulation is a low-resistance, high-flow system. Thinner, less viscous blood flows more easily through the placental intervillous spaces and requires less work from the maternal heart to pump. The kidney sense the overall oxygen demand and increase erythropoietin, stimulating the bone marrow to produce more red cells. Because the cells themselves are healthy, the mean corpuscular hemoglobin concentration, or MCHC, remains stable. The same dilution effect lowers total serum albumin, which mathematically drags down total serum calcium measurements, even though the active, ionized calcium remains perfectly normal. Simultaneously, estrogen commands the liver to pump out thyroid and sex hormone-binding globulins. Crucially, while fluids and proteins shift, coagulation times like APTT and bleeding time remain normal. To push this expanded volume, the cardiovascular engine revs up early. Driven by relaxin, progesterone, and estrogen, cardiac output increases by 30 to 50%, starting as early as the 5th week of gestation. Yet, despite pumping drastically more blood, the mother's blood pressure, particularly diastolic, actually falls in the 1st and 2nd trimesters. Progesterone aggressively dilates peripheral vessels, causing a massive drop in systemic vascular resistance that outpaces the rise in cardiac output. By late pregnancy, this cardiovascular system faces a physical threat. Lying flat causes the heavy uterus to compress the inferior vena cava, severing venous return to the heart and causing supine hypotension. Shifting the patient to a left lateral decubitus position is a mandatory clinical maneuver to unblock this critical vessel. Even with diluted blood, the fetus never starves for oxygen. The higher cardiac output circulates blood faster, while increased levels of 2,3 dpg inside the red cells shift the maternal oxyhemoglobin dissociation curve to the right. Maternal hemoglobin loses its affinity for oxygen exactly where high-affinity fetal hemoglobin is waiting to snatch it. The cardiovascular system deliberately thins the blood, lowers resistance, and rewires the oxygen gradient so the fetus extracts exactly what it needs on every pass. The kidneys receive about 20% of cardiac output. When cardiac output spikes, renal blood flow automatically increases by 80%, and the glomerular filtration rate jumps by 50%. Because so much more blood is being filtered per minute, the normal reference ranges for waste products like serum creatinine and urea drop significantly. A creatinine level that is normal for a non-pregnant woman might signal renal impairment in a pregnant one. This massive filtration rate outpaces the renal tubule's transport maximum for glucose. Glucose spills into the urine at normal blood sugar levels, causing physiological glycosuria. Protein, however, is a large molecule. Significant proteinuria is never a physiological adaptation. It is an indicator of pathology. The urinary tract also faces mechanical failure. Progesterone relaxes the smooth muscle of the ureters, halting peristalsis. Combine this with the dextro-rotated uterus applying physical compression at the pelvic brim, and urine backs up into the kidneys. This is hydroureter, and it is far worse on the right side. Stagnant urine is a culture medium. If a woman has asymptomatic bacteriuria, this lack of downward flow allows bacteria to ascend, causing pyelonephritis. The resulting infection triggers inflammatory prostaglandins, which directly stimulate uterine contractions and cause preterm labor. Bladder capacity is a real estate problem. In the first trimester, the pelvic uterus compresses the bladder, causing frequency. In the second trimester, the uterus rises into the abdomen, offering relief. In the third trimester, the fetal head engages back down into the pelvis, restoring frequency and pushing bladder pressure so high it causes stress incontinence against a weakened pelvic floor. The renal system operates at maximum capacity, aggressively filtering an expanded blood volume while simultaneously fighting physical compression and dangerous fluid stasis. Progesterone cannot selectively relax the uterus. The entire gastrointestinal tract is built of smooth muscle, and its efficiency is sacrificed to keep the pregnancy quiet. In the upper GI tract, progesterone relaxes the lower esophageal sphincter. The expanding uterus pushes gastric contents upward against this weakened valve, causing gastroesophageal reflux. Smooth muscle hypomotility delays gastric emptying, creating a severe hazard during labor. Her stomach may still contain food hours after eating. To prevent Mendelssohn syndrome, aspiration pneumonitis, clear fluids and antacids are strict protocols in obstetric emergencies. Lower down the tract, sluggish bowel motility extracts more water, causing constipation. The gallbladder, a smooth muscle sac, fails to contract forcefully. Bile stagnates and supersaturates with cholesterol, elevating the risk for gallstones. Lab results can cause false alarms. Alkaline phosphatase, or ALP, frequently rises to 2 or 3 times normal. This is not liver disease. The placenta produces its own heat-stable isoform of ALP. Standard liver enzymes like ALT and AST remain normal. Every digestive delay, from reflux to constipation, is simply the systemic cost of ensuring the adjacent uterine muscle remains completely inert. As the uterus grows, it pushes the diaphragm up by 4 centimeters. Yet lung capacity is preserved. The thoracic cage structurally compensates by widening the subcostal angle and expanding its transverse diameter. Because of the elevated diaphragm, expiratory reserve volume, residual volume, and functional residual capacity all decrease. But because the mother breathes much deeper, tidal volume and inspiratory capacity rise, leaving overall vital capacity and respiratory rate entirely unchanged. These blood gas readouts show exactly what happens chemically. Progesterone stimulates the medullary respiratory center. The mother hyperventilates, breathing deeper, and blows off carbon dioxide. Arterial PaCO2 plummets. To prevent dangerous alkalosis, the kidneys actively dump bicarbonate. The blood pH is stabilized near 7.44. The mother exists in a permanent state of compensated respiratory alkalosis. This is a highly calculated fetal respiratory strategy. By forcing her own PaCO2 down, the mother creates a steep diffusion gradient across the placenta. Fetal carbon dioxide flows down this gradient into her blood to be exhaled. The pregnant woman alters her brainstem chemistry and hyperventilates solely to create a molecular exhaust vacuum for the fetal circulation. In preparation for lactation, the lactotroph cells of the anterior pituitary multiply, enlarging the gland by 125%. Confined in a rigid bony space, this massive gland is highly vulnerable to ischemia. A sudden drop in blood pressure from postpartum hemorrhage can cause ischemic necrosis, triggering Sheehan syndrome, complete pituitary failure. Other axes shift to support the pregnancy. Early on, high levels of HCG act like TSH, transiently stimulating the thyroid. Estrogen raises thyroid-binding globulin, inflating total T3 and T4 levels, while free active hormones remain normal. Meanwhile, high steroid levels suppress LH and FSH, blocking ovulation and enforcing amenorrhea. The fetus aggressively extracts resources. Maternal iron stores are drained, causing ferritin to fall while transferrin rises. To build the fetal skeleton, the mother synthesizes active vitamin D to increase her intestinal absorption of calcium. Because iron and calcium compete for the same transport mechanisms, supplements must be spaced 2 hours apart. Metabolically, pregnancy is split in two. The first half is an anabolic savings phase, where the mother is insulin sensitive and stores fat. The second half is a catabolic spend phase. Placental hormones induce insulin resistance to ensure glucose bypasses maternal cells and flows directly to the fetus. If the maternal pancreas cannot overcome this resistance, gestational diabetes develops. In the blood, the coagulation system arms itself. Fibrinogen spikes to levels as high as 6 grams per liter. Clotting factors 7, 8, 10, and 12 surge, while the natural anticoagulant protein S drops. This procoagulant shift guarantees that when the placenta tears away from the uterine wall at delivery, the raw vascular surface clots instantly, preventing fetal exsanguination. The trade-off is an elevated risk of deep vein thrombosis. Importantly, an isolated prolonged APTT does not fit this profile. It is not physiological and strongly implies antiphospholipid syndrome. Driven by aldosterone and estrogen, the mother retains roughly 6.5 liters of extra fluid. Dependent pitting edema in the feet is physiological. Generalized, non-dependent edema in the face or hands is pathological, indicating the endothelial capillary leak of preeclampsia. The endocrine and metabolic systems override their baseline set points to hoard fetal building materials and prepare the blood to clot instantly upon placental separation. When you view a pregnant body as a complete organism, it becomes obvious why standard medical reference ranges are useless here. The body functions as a singular chassis temporarily re-engineered to support two overlapping, high-demand circulatory systems simultaneously. Every adaptation follows a strict logic gate. Progesterone relaxes smooth muscle to keep the environment secure. Estrogen drives the structural expansion needed to house it. The utero-placental circuit demands the raw resources to build it. Through this mechanistic lens, dilutional anemia represents fluid dynamics. Respiratory alkalosis creates a chemical vacuum. Hydroureter is the geometric cost of a dextro-rotated uterus. The pregnant body does not experience a breakdown of normal physiology. It executes a perfectly calibrated parallel physiological state, designed entirely for survival. Textbooks often frame teratogens as a chaotic spreadsheet of random side effects. However, every structural defect is rooted in the specific cellular mechanics of embryogenesis. The developmental clock dictates that an external agent only damages what is actively being constructed at the exact moment of exposure. In weeks 0 to 2, cells are undifferentiated. The path diverges. Agents cause abortion, or the embryo survives unscathed. Weeks 3 to 8 bring maximum vulnerability, building organ systems from scratch. From week 9, organs grow. Exposure causes functional impairment, not structural absence. Isolating the molecular target of an agent makes the resulting clinical malformation a predictable outcome of the developmental clock. Physical disruption begins with ionizing radiation, which shatters DNA strands and generates free radicals that kill rapidly dividing cells. The fetus relies on rapid division, making it vulnerable to DNA damage. Below 5 rads, repair mechanisms cope. Crossing 5 rads overwhelms defenses, causing growth restriction and intellectual disability. At 10 rads, widespread cellular death results in abortion. This mechanism explains why an MRI is safe. It uses magnetic fields that do not break DNA, while gadolinium contrast is avoided. Gadolinium crosses the placenta and accumulates in the amniotic fluid. As the fetus swallows and recirculates that fluid, it remains trapped in a loop of prolonged exposure. Physical disruptors either directly destroy cellular architecture or become trapped within these inescapable fetal recycling loops. Constructing the midface and cardiac outflow tracts requires neural crest cells to migrate from the neural tube to their final destinations. Alcohol and its metabolite, acetaldehyde, are directly cytotoxic. They generate oxidative stress that specifically halts the migration of these neural crest cells along the midline of the face. When this migration fails, the midface simply fails to form properly. This produces the classic fetal alcohol syndrome phenotype, a smooth philtrum, a thin upper lip, and micrognathia. Phenytoin disrupts this same neural crust pathway by inhibiting folate absorption. It also interferes with the programmed cell death, or apoptosis, required to shape the fingers, resulting in underdeveloped distal digits. Valproate alters gene expression by inhibiting histone deacetylase. This molecular block prevents the neural tube from closing, leading directly to defects like spina bifida. Isotretinoin floods the embryo with retinoic acid. This scrambles signaling gradients guiding branchial arch development, leading to severe ear and palate malformations. These complex facial and cranial deformities are the physical evidence of paralyzed cellular migration. Fetal development also relies on the continuous pressure of blood and fluid. ACE inhibitors block angiotensin II, which the fetus requires for renal blood flow during the second and third trimesters. Blocking this pathway leads to renal agenesis. With no fetal urine produced, amniotic fluid volume drops, causing oligohydramniosis. Without the physical space and fluid from breathing amniotic fluid, lungs fail to develop, and limbs are crushed into contractures by the uterus. Thalidomide causes a different form of starvation by halting angiogenesis, the growth of new blood vessels, during the critical window of limb bud formation. Proximal limbs form first, so they die first when early blood supply is blocked. This leaves distal hands and feet attached directly to the trunk. Misoprostol induces severe uterine contractures that cause temporary vascular disruption. This sudden loss of blood flow starves the cranial nerve nuclei, resulting in the facial paralysis of Mobius syndrome. Without a perfect pressurized flow of blood and amniotic fluid, fetal tissues either necrose or are physically deformed by the womb. Internal signaling pathways guide the architecture of the heart. Lithium interferes with the Wnt signaling required for the formation of the right heart and the tricuspid valve. Normally, tricuspid valve leaflets delaminate from the ventricular wall. Lithium disrupts this, causing leaflets to remain attached lower down. This apical displacement defines Epstein anomaly. The valve cannot close properly, causing blood to back up and massively enlarge the right atrium. Indomethacin blocks the prostaglandins that keep the ductus arteriosus open. If given too early, it forces the ductus to close, causing the fetus to develop severe pulmonary hypertension. Tampering with these signaling pathways effectively overrides the embryo's internal architectural instructions. Skeletal development requires precise control over mineralization. Warfarin inhibits the vitamin K-dependent proteins that normally prevent calcium from depositing in cartilage. Without these proteins, calcium precipitates into fetal cartilage inappropriately. This leads to nasal hypoplasia and stippled epiphyses, small spotted calcifications visible on an X-ray. Methotrexate blocks the metabolism of folate, which is essential for rapid cell division. This arrest in cell division causes the sutures of the skull to fuse prematurely. As the brain continues to grow against these fused plates, the skull is forced into a cloverleaf shape. Tetracyclines, by contrast, physically bind to calcium in developing bones and teeth. This results in permanent yellow-brown discoloration, but does not interfere with the actual structural formation of the tissue. When a drug depletes or traps essential minerals, the resulting pathology reflects that specific chemical deficit. Congenital infections follow a specific transmission logic. In the third trimester, the placenta becomes more permeable, making transmission more common, but infections in the first trimester are more severe because they disrupt organogenesis. Torch infections share similar clinical features because these pathogens have a tropism for neuroectoderm, the highly metabolic tissue that forms the brain, eyes, and ears. Toxoplasma invades neural tissue directly, causing inflammation and necrosis. As neurons die around the ventricles, they leave behind periventricular calcifications and cause hydrocephalus by blocking fluid drainage. Rubella causes vasculitis and direct damage to dividing cells. In the eye, it kills the cells of the lens to produce cataracts. In the heart, it damages the wall of the ductus arteriosus, preventing it from closing after birth. These pathogens specifically target, inflame, and calcify sensitive neural and sensory networks. Varicella travels along sensory nerves. In the fetus, this destroys skin and motor neurons in a dermatolal pattern, leading to characteristic scarring and limb contractures. Parvovirus B19 specifically infects erythroid progenitor cells, which are the precursors for all red blood cells. By wiping out these precursors, the virus causes profound fetal anemia. The resulting heart failure leads to hydrops fetalis, a generalized accumulation of fluid throughout the body. Zika virus targets neural progenitor cells, the stem cells of the brain. Because Zika kills the very cells required to generate brain volume, the brain never grows to a normal size, resulting in microcephaly. The cellular receptor a virus utilizes dictates exactly which organ system will fail. Developmental disruption can also stem from within, the mother's own autoimmune or metabolic state. If a mother has untreated PKU, high levels of phenylalanine in her blood cross the placenta and act as a direct neurotoxin, killing developing fetal neurons. In mothers with lupus, IgG antibodies cross the placenta and attack the fetal cardiac conduction system. These antibodies cause inflammation and permanent fibrosis of the AV node, resulting in irreversible complete heart block. While the placenta filters many external threats, maternal antibodies and metabolites bypass this barrier to attack healthy fetal tissue. Clinical teratology functions as the macroscopic expression of applied developmental biology. When a molecular blockade occurs, it triggers a predictable cascade that can halt the growth of an entire tissue structure. ACE inhibitors ruin the kidneys, thalidomide starves the limbs of blood, and warfarin corrupts the skeletal cartilage. Congenital malformations are never random. When the molecular mechanism and the timing of exposure are known, the resulting defect is the only logical consequence. For decades, the placenta was categorized as an impermeable shield protecting the developing fetus. The biological truth is more porous. Molecules with specific physical properties slip through this lipid bilayer, entering fetal circulation and moving toward rapidly dividing tissue. We can approach drug safety in pregnancy as a derivable, deterministic matrix, moving away from a reliance on memorized FDA categories. If you know exactly how a drug works, you can deduce its fetal safety profile from first principles. The first variable is placental permeability. The syncytiotrophoblast is a biological filter governed by chemistry. Large molecules, heavily charged ions, and highly protein-bound drugs bounce off the barrier. Small, lipophilic, non-ionized molecules cross it freely. This chart models the second variable, temporal vulnerability. A fetus runs a precise biological sequence where the timing of exposure dictates the result. A chemical compound can be harmless in one trimester and devastating in another, based on the active developmental phase. The neural tube closes at weeks 3 and 4. Early skeletal ossification occurs between weeks 6 and 9. The third variable is mechanistic overlap. Fetal harm occurs when a drug's specific molecular target intersects with the critical biological window of the developing fetus. By combining these three variables, what crosses, when it crosses, and what the drug is targeting, we can logically derive the safety of most medications. Clinical safety becomes a calculation rather than an act of rote memorization. We apply this logic to antibiotics by looking at the structural differences between prokaryotic bacteria and eukaryotic human cells. To determine risk, we check if the drug's mechanism accidentally targets processes required by differentiating fetal tissue. Penicillins and cephalosporins inhibit bacterial cell wall synthesis by blocking transpeptidase. Because human and fetal cells lack cell walls entirely, the drug has no biological target in the fetus. This clean mechanism ensures safety across all trimesters. Metronidazole requires an anaerobic environment to accept electrons from ferredoxin, which converts the drug into a toxic radical that damages bacterial DNA. Aerobic fetal cells do not activate the drug in this way, leaving fetal DNA unaffected. The matrix becomes restrictive in the first trimester. This is the period of peak organogenesis, where rapid cell division requires a constant supply of essential metabolic materials. This split screen models trimethoprim's mechanism against the developmental timeline. Trimethoprim inhibits dihydrofolate reductase, blocking the active folate needed for DNA synthesis. This folate antagonism maps directly onto weeks 3 and 4, the specific window where the neural tube requires folate to close. Fluconazole presents a similar dose-dependent risk. High-dose exposure inhibits fungal ergosterol synthesis in a manner that disrupts mammalian craniofacial and cardiac formation, processes that occur almost exclusively during the first trimester. Antibiotics that target structures absent in human biology, such as the cell wall, provide a clear safety profile. Those that interfere with essential building blocks like folate pose risks defined strictly by the fetal timeline. Certain antibiotic mechanisms introduce the danger of oxidative stress. Without the G6PD enzyme, red blood cells cannot regenerate glutathione, leaving them defenseless against mechanism-driven hemolysis. Other antibiotics cause permanent structural damage. Because the fetus is continuously building certain structures throughout gestation, these drugs cannot be safely timed to a specific trimester. Fluoroquinolones have a high affinity for collagen-rich cartilage. They chelate magnesium ions within the cartilage matrix, irreversibly destroying actively growing fetal chondrocytes. Since fetal cartilage grows throughout pregnancy, the damage is permanent and unavoidable. Aminoglycosides accumulate in fetal tissue, specifically within the hair cells of the cochlea and the proximal tubules of the kidney. The resulting reactive oxygen species destroy these cells. Because cochlear hair cells do not regenerate, exposure leads to permanent sensory neural hearing loss. Tetracyclines chelate calcium and incorporate themselves into tissues undergoing calcification. This forms a permanent complex that stains developing teeth and weakens bone. Doxycycline is the only exception, utilized for severe diseases because it binds calcium less avidly than other tetracyclines. Fetal cartilage growth and bone calcification are continuous physiological processes. Drugs that cause irreversible cellular destruction to these tissues must be categorically avoided. Anticoagulation in pregnancy involves a balance of 3 risks. First is maternal thrombosis, second is fetal teratogenicity, and finally, maternal hemorrhage at delivery. Molecular physics dictates safety at the syncytio-trophoblast barrier. Heparin and low molecular weight heparin are massive, heavily sulfated glycosaminoglycans with a dense negative charge. They bounce off the barrier and never reach the fetus. Warfarin, however, is a tiny lipophilic molecule that diffuses through the barrier effortlessly. While heparin protects the fetus, it has maternal limitations. LMWH is less potent than warfarin, making it less reliable for preventing clots on mechanical heart valves. In the fetus, warfarin inhibits vitamin K epoxide reductase, required for both the coagulation cascade and the activation of proteins governing skeletal and brain development. This dual inhibition leads to warfarin embryopathy. Blocking bone proteins results in chondrodysplasia punctata and a depressed nasal bridge, while blocking CNS proteins causes microhemorrhages throughout the developing brain. The risk is tied to dosage and timing. The embryopathic window peaks between week 6 and 9, the exact period when fetal skeletal chondrification relies on these vitamin K-dependent proteins. Warfarin's teratogenicity is a precise overlap between its enzymatic target and the timeline of fetal bone mineralization. This timeline maps the clinical protocol for a pregnant patient with a mechanical heart valve. During weeks 0 to 12, the fetus is at peak risk. If the mother requires less than 5 milligrams of warfarin daily, it is continued for superior valve protection. Above 5 milligrams, skeletal risk necessitates a switch to low molecular weight heparin. At week 12, the skeletal vulnerability window closes. With the highest risk of embryopathy passed, the patient switches back to warfarin to prioritize maternal valve protection. At week 36, the protocol requires a switch off warfarin. The drug has a 40-hour half-life and cannot be quickly reversed. Labor while anticoagulated on warfarin leads to fatal intracranial hemorrhage. The patient transitions to low molecular weight heparin, which is then stopped 24 hours before delivery. Its 12-hour half-life ensures a clean washout, minimizing maternal bleeding risk. Immediately postpartum, the patient starts unfractionated heparin. It is highly titratable and immediately reversible with crotamine, which is critical during the high-risk bleeding period after birth. This protocol is specific to mechanical valves. Bioprosthetic valves carry such low thrombotic risk that the entire matrix is bypassed in favor of aspirin alone. This week-by-week guideline functions as a logical balancing act, aligning drug half-lives with the embryological clock. Managing maternal epilepsy involves a double threat. The drugs cause developmental defects, but stopping them risks maternal hypoxia and status epilepticus, which can be fatal to both mother and fetus. Anti-epileptics typically block ion channels or enhance GABA signaling. Fetal neurons and neural crest cells rely on these same channels and signals for early migration and development. This teratogenicity ladder places valproic acid at the top because it disrupts development through 3 pathways. It alters gene expression via histone deacetylase, depletes folic acid, and directly interferes with neural crest cell migration. Lamotidine and levetiracetam sit at the bottom of the ladder. Their mechanisms, specifically blocking sodium channels or binding synaptic vesicle proteins, avoid folate depletion and the generation of toxic metabolites. Despite this ranking, a pre-existing epileptic patient who discovers she is pregnant should not have her medication switched. Transitioning between anti-epileptics takes weeks to achieve stable drug levels. The risk of a major seizure during this transition is more dangerous than ongoing exposure to a suboptimal drug. Patients on these drugs require 4 milligrams of folic acid daily, 10 times the standard dose. This high dose is required to force metabolic repletion against drug-induced folate depletion. Because the neural tube closes by week 4, this folate dose must be started a full month before conception to protect the fetus. Managing epilepsy in pregnancy requires accepting a known teratogenic risk to prevent the catastrophic failure of maternal seizures. The complete matrix defines maternal fetal pharmacology as a predictable science of biochemical intersections. We avoid fluoroquinolones because fetal cartilage is always growing. We do not switch anti-epileptics mid-pregnancy because the mechanics of the transition risk fatal hypoxia. By tracking what crosses the placenta and identifying the precise developmental phase of the fetus, clinical prescribing transforms from memory into rigorous physiological logic. A patient arrives at your clinic. She rarely knows the exact date of ovulation and almost never knows the precise moment of fertilization. To track a pregnancy, obstetricians require a universal, clinically accessible 0 point. We rely on the patient's last menstrual period, or LMP. This animated timeline displays the consequence of that decision. Embryologists count from fertilization on the top axis. Obstetricians count from LMP on the bottom. Because ovulation happens approximately on day 14 of a 28-day cycle, we derive a clinical rule. Gestational age equals fetal age plus 2 weeks. A rigid 2-week offset locks them together. This creates an immediate paradox in practice. On the exact day a patient misses her period, the embryo itself is only 2 weeks old. Yet by the clinical timeline, the patient is classified as 4 weeks pregnant. You never need to memorize clinical developmental milestones separately. You only need to apply the +2 rule. The germinal period shifts from 0 to 4 weeks. Cardiac activity shifts from 3 weeks to 5. The embryonic period ends at 10 weeks, not 8. Obstetrical dating is a clinical necessity. It remains misaligned with true embryological age, but it provides the uniform framework required for medical practice. We divide this gestational timeline into 3 trimesters. These boundaries are derived from biological imperatives. The first trimester runs from the LMP to 13 weeks and 6 days. This is the period of organogenesis. It carries the highest teratogenic risk and the highest rate of miscarriage. The second trimester runs from 14 weeks to 27 weeks and 6 days. Organogenesis is complete, making this the primary growth phase. It permits detailed structural anatomical surveys and represents the safest period to perform necessary surgeries on the mother. The third trimester spans from 28 weeks to delivery. This phase concentrates on functional maturation, particularly lung development, establishing fetal viability, and managing late-stage obstetric complications. The clinical categorization of pregnancy is dictated by fetal developmental milestones, which in turn inform the maternal risk profile at any given week. To project the endpoint of this timeline, we calculate the expected date of delivery, or EDD. The baseline metric is straightforward. A normal pregnancy lasts exactly 280 days from the LMP. Adding 280 days directly is cumbersome. Naegele's rule is an arithmetic shortcut. We add 7 days to the LMP and then add 9 months. To prevent counting errors for short months, avoiding impossible dates like February 32nd, we reverse the order for February LMPs, adding the months first, then the days. Naegele's rule assumes a precise 28-day cycle with ovulation occurring on day 14. If the cycle varies, we must correct the EDD. The formula takes the actual cycle length and subtracts 28 days. A 25-day cycle means ovulation happened earlier, so we subtract 3 days from the EDD. A 32-day cycle means it happened later, so we add 4 days. This formula breaks down when the timeline is unpredictable. Oral contraceptive failure, lactational amenorrhea, irregular cycles, or an uncertain LMP remove our mathematical anchor. The universal fallback solution is a first trimester crown rump length ultrasound. In vitro fertilization rewrites this arithmetic. With IVF, the exact time of fertilization is known in a lab. The LMP is discarded. By eliminating the standard 14-day clinical offset, the baseline calculation drops to exactly 266 days. We then deduct days based on the age of the transferred embryo. A same-day retrieval keeps the target at 266 days. A day 3 transfer subtracts 3 days, setting the EDD 263 days out. A day 5 transfer subtracts 5 days, making it 261. All obstetric dating mathematically anchors to the true date of ovulation. You either estimate it by LMP, correct it by cycle length, or bypass the math with precision lab tracking. We classify pregnancy duration along this continuous timeline using 2 fixed points. The first is the viability threshold at 20 weeks in the US, traditionally 28 weeks elsewhere. The second is the establishment of pulmonary maturity at 37 weeks. These markers create clear diagnostic zones. A loss before 20 weeks is a pre-viable abortion. A loss at or beyond 20 weeks is a stillbirth. Deliveries between viability and 37 weeks are preterm, dictated by insufficient surfactant production. We further subdivide term pregnancies because neonatal outcomes are measurably worse between 37 and 38 weeks. This creates an early term window, distinct from the full term window starting at 39 weeks. Progression past 41 weeks enters late and post-term territory, carrying escalating risks of placental insufficiency. To document how a patient's body has moved through these timelines, we use the Gravida and Para scoring system. Gravida counts total conceptions, including the current pregnancy. Para counts deliveries at or beyond the viability threshold. In both categories, a multiple gestation counts as a single event. This is the GTPAL matrix, tracking gravida, term, preterm, abortion, and living children. Notice the warning over the P. It stands for preterm, not parity. Parity is actually distributed across the term and preterm columns combined. We apply this systematically. A patient presents with a history of a 38-week son, a 30-week stillbirth, 32-week twins, an ectopic pregnancy, and is currently pregnant. The current pregnancy adds to gravida.
The twins count as 1 preterm delivery, but 2 living children. The stillbirth counts as a preterm delivery, but 0 living children. The math resolves to G5 P1213. Obstetric scoring documents the biological history of the uterus and its demonstrated mechanical ability to carry a fetus past viability. Diagnosing a pregnancy follows an epistemological gradient. We move progressively from subjective physiological symptoms to diagnostic proof. The first tier includes presumptive signs: amenorrhea, nausea, breast tenderness, urinary frequency, and pigmentation changes. These are subjective, driven by physiological hormone shifts in HCG, progesterone, and melanocyte-stimulating hormone. The perception of fetal movement, known as quickening, is also presumptive. Primogravidas feel it later, around 18 to 20 weeks, because they mistake the early movements for bowel gas. Multigravidas recognize the sensation earlier. The second tier contains probable signs, detected objectively by the examiner. This anatomical diagram highlights Hagar's sign, a softening of the uterine isthmus, and Piscacek's sign, an asymmetrical enlargement from cornual implantation. We also look for Godel's softening of the cervix and Chadwick's cyanosis. While these are objective findings, a large fibroid can mimic them. Definitive signs provide irrefutable proof. This requires visualizing the gestational sac, identifying a fetal pole with cardiac activity, or auscultating fetal heart sounds. Finding the yolk sac inside the gestational sac is clinically critical. It proves an intrauterine pregnancy and rules out the pseudogestational sac of an ectopic pregnancy. In cases of pseudocyesis, a patient experiences presumptive signs driven by hormonal disturbances and may even present with probable anatomical signs. But without definitive sonographic proof of a fetus, there is no pregnancy. The diagnostic process filters out the subjective noise of hormonal side effects, catalogs the objective anatomical changes, and relies exclusively on sonographic proof to confirm viability. Once established, uterine growth becomes highly predictable. After 12 weeks, the fundal height rises at approximately 1 centimeter per week. This cross-section illustrates the anatomical landmarks. The uterus emerges from the pubic symphysis at 12 weeks. It reaches midway at 16 weeks, hits the umbilicus at 20 weeks, and peaks at the xiphisternum at 36 weeks. At 40 weeks, the fundal height mechanically drops. As the fetal head engages into the pelvis, the fundus lowers back down to the 32-week level. This process, called lightening, physically relieves diaphragmatic pressure on the mother. If the measured fundal height deviates from the expected dates by 3 weeks or more, we examine the mechanics. A uterus measuring larger than dates indicates added volume in the cavity. This points to polyhydramnios, macrosomia, multiple gestations, a molar pregnancy, or blood trapped by a concealed abruption. Conversely, a uterus measuring smaller than dates indicates restricted volume. This requires investigating fetal growth restriction, uteroplacental insufficiency, vasoconstriction induced by hypertension, or intrauterine fetal death. The maternal abdomen acts as a direct mechanical proxy for fetal growth. Any structural deviation from the arithmetic timeline demands immediate sonographic investigation. Intrauterine fetal death, or IUFD, is defined as fetal death occurring at 20 completed weeks or at a birth weight of 500 grams. This 20-week threshold separates viable period demise from pre-viable abortion. The cardinal clinical symptom of demise is a progressive decrease, culminating in the total absence of maternal perception of fetal movement. Objective confirmation requires medical imaging. You will see a motionless cardiotocography trace. The absolute gold standard for confirming death is the total absence of cardiac activity on an M-mode ultrasound. Post-mortem sonographic artifacts are direct mechanical derivations of tissue breakdown. Spaulding's sign appears when brain liquefaction causes the internal cranial volume to shrink, allowing the cranial bones to overlap. Robert's sign appears as gas bubbles in the heart and vessels, produced by putrefactive gut bacteria. Scalp edema separates from the skull, creating Duell's halo sign. A total loss of muscle tone causes the spine to hyperflex into ball sign, and the ribcage to compress into Tagger's sign. The amniotic fluid darkens to a tobacco juice color, saturated with past meconium and hemoglobin breakdown products from tissue maceration. These sonographic artifacts are the biomechanical results of tissue maceration and the loss of skeletal tone. The management of IUFD follows a rigid logical principle. Vaginal delivery is exclusively preferred in almost all cases. The clinical rationale is specific. A cesarean section provides zero benefit for a deceased fetus, but introduces significant maternal surgical risk, anesthetic danger, and scar morbidity for all future pregnancies. We perform a cesarean section in IUFD solely for maternal indications. These are mechanical barriers to vaginal delivery, such as placenta previa, an uncorrectable transverse lie, or obstructed labor, or a history of 2 or more previous lower segment cesareans. Every calculation and diagnostic sign in obstetrics links back to these mechanical and arithmetic relationships. When the underlying biology is understood, the clinical practice becomes derivable.
Gestation is a biologically volatile period. Months before a patient ever reports a symptom, catastrophic complications like preeclampsia or fetal compromise begin at a cellular level, silently throwing microscopic clots and damaging vascular endothelium. By the time a clinical crisis is visible, the physiological damage is already severe. The entire structure of antenatal care exists for one specific purpose: anticipatory surveillance. We monitor the physiology to preempt the pathology. Traditional medical training often reduces this process to disjointed checklists. Students are taught to memorize visit schedules, lab requirements, and supplement dosages as if they were administrative rules imposed by a hospital board. We are going to discard the checklists. Instead, we will derive the exact Government of India and World Health Organization antenatal schedules entirely from biological first principles. Every clinical intervention in obstetrics can be deduced from 3 base axioms: the timing of fetal organogenesis, the mechanics of maternal plasma expansion, and the output of placental hormones. When you understand the underlying mechanisms driving a pregnancy, you do not need to memorize the protocols. The correct clinical actions become mathematically predictable. This diagram maps a standard 40-week gestation. To build a surveillance schedule, we have to look at the exact timing of pathological risks, which divide the pregnancy into 4 distinct physiological windows. The first window covers the first trimester, up to 13 weeks. This is the baseline establishment phase. The goal is to capture a complete picture of maternal health before the extreme stress of pregnancy alters her baseline metrics. The second window, from 14 to 28 weeks, aligns with rapid fetal growth. Endocrine shifts accelerate and anatomical structures solidify, making this the strict physiological window for structural anomaly scans and genetic screening. The third window runs from 28 to 34 weeks. This is when the cumulative strain on the mother's systems peaks. Pathologies like fetal growth restriction, preeclampsia, and gestational diabetes become clinically significant here. The final window, from 36 weeks onward, shifts entirely to mechanical preparation. Surveillance focuses on confirming cephalic presentation, locating placental position, and assessing cervical readiness. The Government of India's 4-visit model maps precisely onto these 4 biological phases, 1 per window. The WHO's 8-visit model operates on the exact same logic, simply adding intermediate checkpoints within these phases for higher-risk populations. These schedules are not arbitrary administrative choices. They form a precise surveillance net, cast exclusively over the specific weeks where distinct pathological processes emerge. The absolute priority of the first visit is risk stratification. We are scanning for maternal factors that intrinsically compromise a patient's physiological reserves before the heavy demands of gestation are added. A previous cesarean section leaves a uterine scar, introducing mechanical risks of rupture or placenta accreta. Extremes of maternal age correlate with an immature pelvis in younger patients or higher chromosomal risks. Past obstetric losses predict future structural or genetic vulnerabilities. We establish blood groups immediately because of hemolytic disease mechanics. If an Rh-negative mother carries an Rh-positive fetus, her immune system may produce antibodies that destroy fetal red blood cells, requiring an indirect Coombs test at 28 weeks to track antibody levels. By checking the father's blood type first, we can optimize this protocol. If the father is also Rh-negative, it is genetically impossible for the fetus to be Rh-positive, instantly eliminating the need for maternal antibody monitoring. The remaining investigations are equally specific. A complete blood count establishes hemoglobin before pregnancy-induced hemodilution begins. A routine urine test checks glucosuria, subclinical infection, and baseline proteinuria, a critical metric for evaluating preeclampsia. Infectious disease screens dictate action at birth. HIV positivity mandates viral suppression to prevent vertical transmission. An HBsAg positive result requires administering the hepatitis B vaccine and immunoglobulin to the neonate within 12 hours of delivery. Early diabetes screening evaluates pre-existing metabolic dysfunction. As pregnancy progresses, the placenta secretes human placental lactogen. This hormone actively induces progressive insulin resistance to ensure adequate glucose remains in the maternal bloodstream to feed the fetus. Because HPL production scales with placental mass, insulin resistance peaks in the second trimester. A negative screen at 10 weeks guarantees nothing at 26 weeks. The physiology dictates a mandatory repeat screen between 24 and 28 weeks. Aneuploidy screening relies on transient anatomical landmarks. Nuchal translucency, fluid at the back of the neck, is only reliably measurable between 11 and 13 weeks and 6 days. Before this window, the fetus is simply too small. After this, the lymphatic system develops and drains the fluid, closing the diagnostic window permanently. The first visit constructs a highly individualized physiological baseline. Without this context, distinguishing normal adaptations from dangerous metabolic deviations in the third trimester is impossible. In embryogenesis, the fetal neural tube closes between days 26 and 28 of embryonic life. This happens roughly 4 weeks after conception, often before a patient even confirms her pregnancy. Folate drives the DNA synthesis required for this closure. Prophylactic folic acid supplementation must begin 1 month prior to conception and continue strictly until organogenesis completes at 12 weeks. If maternal metabolic demand is higher, the required dosage scales mechanically from 400 micrograms all the way up to 5 milligrams. Iron supplementation follows the opposite logic. In the first trimester, fetal iron demand is negligible. Maternal iron loss actually drops because menstruation ceases, and high HCG levels cause severe nausea, making oral iron intolerable.
Supplementation here is counterproductive. By the 4th month, the physiology flips. Fetal red cell mass expands rapidly. Maternal plasma volume surges by up to 50%. The biological demand on maternal iron reserves becomes massive, making the 2nd trimester the exact right moment to initiate iron therapy. Nutritional demands map directly to fetal development. The 1st trimester requires 0 additional calories. As organogenesis begins in the 2nd trimester, maternal protein requirements increase. By the 3rd trimester, rapid fetal fat and muscle accretion demands an extra 470 kilocalories daily. Weight gain limits operate on a simple inverse ratio. Underweight patients severely lack biological reserve and therefore must gain more. Obese patients possess excess adipose stores, and excessive gain simply increases macrosomia risk. This animation illustrates the intestinal lining, highlighting the divalent metal transporter 1, or DMT1 receptor. Iron and calcium rely on this exact same transport channel for absorption. If administered together, they physically block each other from entering the bloodstream. Enforcing an 8-hour gap between calcium and iron supplements allows the receptors to clear, ensuring sequential rather than competitive absorption. Maternal immunization is governed by a single immunological rule. A fetus cannot mount an immune response to live attenuated organisms. What causes a mild immune reaction in an adult will freely cross the placenta and trigger a devastating systemic infection in the fetus. Therefore, live vaccines like MMR, varicella, and yellow fever are absolutely contraindicated. Inactivated or toxoid vaccines carry no such replication risk and are safe. The Tdap vaccine targets a specific vulnerability. A newborn is too young to be vaccinated for pertussis. Administering Tdap between 27 and 37 weeks maximizes the transfer of passive maternal antibodies across the placenta, completely shielding the infant at birth. Every pill, calorie, and injection is a biological countermeasure, precisely timed against a specific developmental milestone. A full-term pregnancy applies intense internal mechanical force, aggressively displacing maternal anatomy and compressing vascular structures. By term, the gravid uterus weighs roughly 5 kilograms. Lying flat on the back causes this mass to drop directly onto the inferior vena cava, running along the right side of the vertebral column. This intense physical compression halts venous return, crashing maternal cardiac output and instantly reducing uteroplacental perfusion, causing supine hypotension syndrome. The treatment is purely biomechanical. Placing the patient in a left lateral position uses gravity to roll the 5-kilogram uterine mass off the right-sided vessel, instantly restoring blood flow. Carpal tunnel syndrome operates on similar compression physics. Pregnancy induces massive fluid retention. When soft tissue edema swells inside the carpal tunnel, a rigid structure with 0 capacity to expand, the median nerve gets crushed. Bell's palsy is triggered by edema compressing the facial nerve within the narrow bony facial canal, combined with pregnancy-induced hypercoagulability. While steroids reduce this perineural inflammation, timing dictates their use. Prescribing steroids during 1st trimester organogenesis risks cleft palate in the fetus. In the 3rd trimester, structural development is complete, making the intervention safe. Hyperemesis is driven by the endocrine system. Maternal nausea tracks directly alongside rising HCG levels, peaking exactly at 10 to 12 weeks. High estrogen levels compound the issue by relaxing smooth muscle, severely delaying gastric emptying. Management requires precise pharmacological blockade of dopamine, histamine, or 5-HT3 receptors in the brain's trigger zone. If a patient requires IV fluids for severe hyperemesis, administering glucose without thiamine is deeply dangerous. Flooding a malnourished patient with glucose rapidly depletes their remaining thiamine reserves, triggering Wernicke's encephalopathy. Obstetric danger signs are simply outward warnings of systemic failure.
A high fever signals chorioamnitis, a major trigger for preterm labor. Reduced fetal movements indicate uteroplacental insufficiency, acting as a warning that the fetus is actively conserving energy in a hypoxic environment. Generalized facial edema is the physical manifestation of glomerular endotheliosis. As severe preeclampsia violently destroys the microvasculature of the kidneys, massive amounts of protein spill into the urine, erasing oncotic pressure and forcing fluid to aggressively leak into the surrounding tissues. Minor and major pregnancy disorders are not random side effects. They are the predictable structural and systemic failures of a body pushed to its absolute physiological limits. In clinical obstetrics, the term high-risk pregnancy is not a distinct disease state. It is a statistical probability that a specific patient's pregnancy will depart from the uncomplicated physiological pathways we have established. Identifying a risk factor simply lowers the threshold for intervention within this exact same unified biological framework. It dictates closer surveillance, tighter diagnostic windows, and faster clinical responses. Obstetric protocols are a rigorous implementation of anticipation and screening. We map the biological cascade to intercept silent complications long before they devolve into surgical emergencies. There are no arbitrary dates in the GOI guidelines, and there are no random dosages in the WHO recommendations. Every single metric is deliberately calibrated to the mechanics of gestation. When the anatomical constraints, endocrine shifts, and immunological realities of a pregnant patient are fully understood, the clinical guidelines effectively write themselves. By mastering the first principles of maternal pathophysiology, the entire complex architecture of antenatal care becomes logically inevitable. The high-contrast imagery of obstetric ultrasound emerges from the collision of acoustic physics and the rigid timeline of embryonic development. Every diagnostic criterion and pathological sign seen on screen is dictated by three factors: probe physics, embryological timelines, and fetal physiology. We will build this framework from the ground up, starting with the raw acoustics of the equipment, moving through the kinetics of gestational dating, and deconstructing the mechanics of structural anomalies. Mastering this underlying logic provides the tools to deduce fetal health from first principles. Higher frequency waves provide crisp resolution, but attenuate rapidly, unable to reach deep tissue. Lower frequency waves penetrate deep, but sacrifice detail. This dictates probe choice. A transabdominal probe uses low frequencies to punch through muscle, while a transvaginal probe leverages high frequencies for high resolution. Because the transvaginal probe has higher resolution, it can detect early pregnancy structures roughly 1 week before a transabdominal probe can resolve the same echo patterns. We choose our imaging mode based on the target's behavior. B mode, or brightness mode, plots static 2D echoes for structures like the gestational sac. M mode, or motion mode, plots a single beam over time, required to detect the rapid, tiny movements of the early fetal heart. The physics of the equipment creates a temporal threshold for detection. We see structures only when they grow large enough to be resolved by the specific frequency of the probe. At 4 weeks, the gestational sac becomes visible as anechoic fluid surrounded by an echogenic trophoblastic rim, the intradecidual sign. A true blastocyst burrows eccentrically, unlike a central ectopic pseudo-gestational sac. Next, the decidua capsularis and parietalis form 2 rings, the double decidual sac sign. By week 5, the embryo sits between yolk and amniotic sacs, the double bleb sign. Development follows a strict size-based timeline. Once the mean sac diameter reaches 10 millimeters, a yolk sac must be visible on a transvaginal scan, or the pregnancy is failing. The crown rump length, or CRL, provides our most accurate dating. Adding 42 to the CRL in millimeters gives the gestational age in days, a calculation made possible by the total absence of biological size variation in early embryos. The fetal heart rate follows a physiological curve. It begins slow, driven by intrinsic sinoatrial node automaticity, peaks at 170 beats per minute by 10 weeks as the sympathetic nervous system matures, and then slows as vagal tone develops. These early sonographic signs confirm the safety of the pregnancy's location and establish a timeline derived from predictable cellular kinetics. Early structural growth is mirrored by beta-HCG, a product of the syncytiotropoblast. In a viable pregnancy, this hormone doubles every 48 to 72 hours, This creates the discriminatory zone. When beta HCG reaches 1500 milli-international units per milliliter, a gestational sac must be visible on a transvaginal scan. An empty uterus at this level strongly suggests anectopic location. Our missed abortion decision tree prevents terminating viable pregnancies. Absolute thresholds: mean sac diameter of 25 millimeters without a fetal pole, or crown rump length of 7 millimeters without a heartbeat. Wait times: 14 days for a sac without a yolk sac, or 11 days with one. These cutoffs represent the definitive boundaries of biological viability. Earlier ultrasounds are more accurate because first trimester embryos lack genetic or environmental size variation. Second trimester dating uses biparietal diameter, or BPD, measured strictly on the transthalamic plane using the thalami and third ventricle. Calipers measure from the outer table of the near skull to the inner table of the far skull, a leading edge to leading edge technique correcting for acoustic echoes. Long bones like the femur resist the soft tissue fluctuations caused by nutrition, making femur length the most reliable single metric in the high variation third trimester. Twin dating is based on the larger twin. This prevents the masking of early growth restriction that may be occurring in the smaller twin. We monitor growth by tracking the abdominal circumference. In growth-restricted fetuses, the liver depletes its glycogen stores as the body reflexively spares the brain, causing the AC to drop early. Over 40 weeks, our focus transitions from applying a universal timeline to assessing individualized metabolic growth. Scan timing is dictated by structural development. NT scans catch lymphatic fluid buildup before it drains. Anomaly scans occur after organogenesis, and growth scans identify late-stage placental insufficiency. Cervical length must be assessed via transvaginal scan with an empty bladder. As the internal os opens and the amniotic sac funnels into the canal, the length is measured strictly from the tip of the funnel down to the external os. Fetal echocardiography is used when specific maternal risks threaten early cardiac development. Maternal lithium therapy can displace the tricuspid valve leaflets downward, while maternal lupus antibodies can attack the fetal AV node, causing complete heart block. Gestational diabetes triggers fetal hyperinsulinism, leading to a thickened interventricular septum, and trisomy 21 disrupts the endocardial cushions, causing AV canal defects. Specialized ultrasound scans are targeted strikes, timed to intercept specific physiological or biochemical failures. Neural tube defects occur when the neural plate fails to zip closed. Failure at the cranial end causes anencephaly. Failure at the caudal end causes spina bifida. In anencephaly, acrania exposes the developing brain to enzymes in the amniotic fluid, which chemically destroy the tissue. This leaves prominent orbits and a disorganized mass, creating the Mickey Mouse and frog eye signs. This structural failure crashes the fetal endocrine system. Without a hypothalamus, the adrenal glands do not develop, which prevents the placenta from producing the estrogen required to trigger labor, resulting in a post-term pregnancy. Exposed neural tissue also leaks alpha-fetoprotein, or AFP, into the amniotic fluid and maternal blood, providing a biochemical flag for the defect. An open spinal defect causes a continuous leak of cerebrospinal fluid, lowering intracranial pressure. This pulls the hindbrain downward through the foramen magnum, the Chiari-2 malformation. The deformation creates the curved banana sign in the cerebellum and the flattened lemon sign in frontal bones. The cranial signs of spina bifida are the downstream mechanical consequences of a fluid leak in the lower spine. Developmental timing is critical in the abdomen. Intestinal herniation into the umbilical cord is a normal physiological process until 11 weeks. An omphalocele is a midline genetic folding failure. Organs are trapped in a smooth amniotic sac, strongly linked to aneuploidy. In contrast, gastroschisis is a random vascular accident with no sac, allowing amniotic fluid to digest and inflame the bowel into a matted mass. The presence or absence of a membrane sac determines whether the diagnosis is a systemic chromosomal failure or an isolated vascular accident. Obstetric ultrasound functions as a predictive system rather than a series of disconnected visual signs. Every sonographic marker, from transvaginal resolution limits to the brainstem compression of a CSF leak, represents a precise biological algorithm. Reconstructing these foundations from the first principles of physics and embryology makes the clinical diagnosis an inevitable conclusion.
Normal human cells contain exactly 46 chromosomes, arranged in 23 pairs. To reproduce, the body has to have that number, producing haploid eggs and sperm with exactly 23 chromosomes each. When those gametes fuse, the resulting zygote returns to 46. That is the baseline mathematical rule of human reproduction. But occasionally, this arithmetic fails. During meiosis, a pair of chromosomes will fail to separate. They stick together and travel to the same pole of the dividing cell. This is non-disjunction, and it creates an aneuploid cell, one with an abnormal number of chromosomes. Chromosomes carry the genes that produce proteins, regulate signaling cascades, and coordinate the entire symphony of embryogenesis. An extra chromosome means excess gene production, which fundamentally alters gene dosage and disrupts the delicate timing of organ development. We are going to map exactly how this meiotic failure creates highly predictable fetal malformations and how those specific anatomical markers dictate our entire prenatal screening and diagnostic cascade. The pathway rests on a specific clinical divide. Screening identifies probability through biomarkers, but diagnosis requires chromosomal certainty through invasive sampling. Down syndrome, or trisomy 21, is the most common viable autosomal trisomy for a specific biological reason. Chromosome 21 is the smallest human autosome. It carries the fewest protein-coding genes. The resulting gene dosage imbalance disrupts development, but it allows gestation to complete. Compare that to an extra chromosome 16. Because chromosome 16 is much larger, the genetic dosage disruption is massive. Fetal development simply cannot proceed past the first trimester. In 95% of trisomy 21 cases, the extra chromosome arrives via random non-disjunction. This correlates directly with advanced maternal age. A woman's oocytes are formed before she is born and remain suspended in meiosis for decades. The longer they sit in this suspended state, the higher the chance the cellular machinery will fail when division finally resumes. Roughly 4% of cases arise from a completely different mechanism, a Robertsonian translocation. Here, two acrocentric chromosomes, typically 14 and 21, physically fuse together at their centromeres. This creates a heritable structural change. Because no essential genetic material is lost in this fusion, the parent is a balanced carrier. They function normally. However, during meiosis, this fused chromosome segregates unpredictably, resulting in a 10 to 15% recurrence risk for producing a live-born child with Down syndrome in future pregnancies. The mathematical edge case occurs if a parent carries a fused 21-21 chromosome. The only possible viable gamete they can produce contains that fused double chromosome. The recurrence risk for Down syndrome in any surviving pregnancy hits exactly 100%. The final mechanism is mosaicism, accounting for the remaining 1 to 2. In the embryonic heart, fusion of the endocardial cushions relies on a perfectly timed signaling cascade. The gene dosage imbalance disrupts this timing, leaving a central hole affecting both the atrial and ventricular septa. This produces the characteristic atrioventricular septal defect, or AVSD. In the gastrointestinal tract, the duodenum normally hollows out between 8 and 10 weeks. In trisomy 21, this recanalization often fails. The resulting blockage produces the classic double bubble sign of duodenal atresia on an ultrasound. Neurologically, chromosome 21 carries the APP gene, which produces amyloid precursor protein. 3 copies of this gene guarantee lifelong excess amyloid beta production. Individuals with Down syndrome virtually universally develop Alzheimer's-type brain pathology by their 40s. Overexpression of the RUNX1 transcription factor triggers transient leukemias by disrupting early blood cell regulation. Simultaneously, 3 copies of the SOD1 gene produce excess superoxide dismutase, overwhelming the cell's downstream antioxidants and driving systemic oxidative stress. Trisomies 18 and 13 involve larger chromosomes and therefore more severe gene disruptions. Trisomy 18 produces profound anomalies, like clenched fists with overlapping fingers and rocker bottom feet. Trisomy 13 disrupts the division of the embryonic forebrain, leading to hollow prosencephaly. Autosomal monosomies are effectively lethal, yet Turner syndrome, monosomy X, is survivable.
Human physiology evolved a mechanism to cope with X chromosome imbalance through X inactivation. Even in typical XX individuals, one X chromosome is silenced, making the functional difference in 45X less catastrophic. Still, one active X chromosome is insufficient for complete vascular development. The primary structural failure in Turner syndrome is that the jugular lymph sacs form but never connect to the venous system, causing massive lymphatic engorgement in the fetal neck. Aneuploidy phenotypes are never random anomalies. They are the deterministic result of altered molecular cascades destroying specific embryological timelines. We detect these altered timelines using non-invasive tools. The key first trimester ultrasound marker is nuchal translucency, or NT. This measures the fluid-filled space at the back of the fetal neck. It must be captured in a strict developmental window between 11 weeks and 2 days and 13 weeks and 6 days. An enlarged NT occurs when fluid backs up in this tissue. This is driven either by cardiac dysfunction causing high venous pressure or an intrinsic failure of the developing lymphatic vessels. An enlarged NT is anatomically distinct from a first trimester cystic hygroma.
A cystic hygroma is a large septated mass caused when the jugular lymph sacs fail completely. An enlarged NT simply represents excess fluid pooling in a normal anatomical space. This chart shows the first trimester dual test, which shifts our focus from fetal anatomy to placental biochemistry. It measures maternal serum levels of PAP-A and free beta-HCG. Look at the trisomy 21 profile in the center. The placenta is developmentally immature, so it underproduces PAP-A, but it overcompensates for this immaturity by aggressively hypersecreting free beta-HCG. Contrast this with the trisomy 18 profile on the right. Here, the placenta is globally failing without any hormonal compensation. Both PAP-A and HCG drop drastically. Early biochemical screening works exactly because it quantifies the placenta's physiological struggle to compensate for the underlying genetic imbalance. In the second trimester, the quad test monitors a more complex biochemical network. This flowchart tracks the synthesis of unconjugated estriol, or UE3. It requires a 3-step multi-organ relay, starting at the fetal adrenal gland, moving through the fetal liver, and finally aromatizing in the placenta. The general developmental sluggishness characteristic of trisomy 21 slows this entire relay down. As a result, maternal serum levels of UE3 are noticeably depressed. Similarly, delayed fetal liver maturation results in low alpha-fetoprotein. Meanwhile, the stressed placenta continues to hypersecrete, pumping out abnormally high levels of both HCG and inhibin A. During the second trimester anatomy scan, we evaluate physical structures. Here, we must draw a clear clinical line between hard and soft sonographic markers. Hard markers are standalone pathological anomalies. Findings like duodenal atresia, an AVSD, or an omphalocele indicate something has gone clearly wrong in development. Their presence immediately mandates chromosomal investigation. Soft markers are minor anatomical variations. In isolation, they might be benign normal variants. Their value is purely statistical. The strongest single soft marker for Down syndrome is a thickened nuchal fold measuring greater than 6 millimeters. Each soft marker maps to a physiological deficit. An echogenic bowel appears bright on ultrasound because sluggish gut motility overabsorbs water, drying out the meconium. Pyelactasis, or mild kidney dilation, stems from reduced ureteral smooth muscle tone, failing to drain urine efficiently. Skeletal markers follow the same logic. An absent nasal bone, or a short femur, reflects delayed bone ossification. Sandal gaps between the toes and single palmar creases result from neuromuscular hypotonia, altering how the limbs fold and grow. We also look for an aberrant right subclavian artery, which occurs when the embryonic pharyngeal arches fail to regress properly during cardiovascular remodeling. This establishes an absolute clinical mandate. A positive NIPT is a highly accurate placental screen. It is never a diagnosis. It must be confirmed by invasive testing before any irreversible decisions are made. This map highlights our 3 invasive diagnostic tests. Each accesses a completely different biological compartment, and each operates within a strict gestational window. Between 10 and 14 weeks, we perform chorionic villus sampling, or CVS. It targets the placental villi. It carries a 1% procedural risk,
but because it samples placental tissue, it remains entirely vulnerable to the ambiguities of confined placental mosaicism. At 15 weeks, we transition to amniocentesis. It retrieves true fetal amniocytes from the amniotic fluid. This completely bypasses placental mosaicism and drops the procedural risk below 0.5%. The fluid also allows us to run PCR for fetal infections and diagnose open neural tube defects. After 18 weeks, chordocentesis can sample umbilical blood directly. However, targeting a moving vessel spikes the procedural risk to 2 or 3%. It is strictly reserved for evaluating urgent hematological conditions like fetal anemia or hemolysis. Selecting an invasive test is not a matter of preference. It is a strict calculation of gestational timing and the exact cellular compartment required. We can now unify these anatomical, biochemical, and genetic protocols into a single flowchart, the definitive clinical decision algorithm used to manage every modern pregnancy. The primary screening pathway begins with the first trimester combined test. A low-risk result routes the patient to routine care. A high-risk result mandates secondary screening via NIPT. Certain findings act as direct diagnostic triggers. A positive NIPT result, or the discovery of any hard marker during the anatomy scan, instantly bypasses further screening. Invasive testing is strictly mandated. The soft marker protocol is highly specific. A single, isolated soft marker merely prompts a risk recalculation, but the presence of 2 or more markers escalates the patient straight to advanced testing. When invasive diagnosis is triggered, gestational age dictates the final procedure. Before 14 weeks, perform CVS. At or after 15 weeks, perform amniocentesis. Prenatal genetics is ultimately an exercise in accessing biological compartments. We measure the biochemical and structural phenotype of the placenta to estimate risk, but we must sample the cellular reality of the fetus to determine the truth. A well-oxygenated fetus behaves in predictable ways. A hypoxic fetus stops behaving that way in a strictly predictable order. Every test we perform in the clinic serves as a physical measurement of the fetal brain's internal energy triage system. Clinical guidelines for fetal surveillance are precise physiological calibrations based on the development of fetal neuroanatomy and the specific ways oxygen is distributed through the body. To build a true understanding of these clinical cutoffs, we have to start at the cellular level. This 3D model breaks down fetal movement into a 4-step energy cascade: cortical decision, motor neuron firing, muscle contraction, and ATP consumption, relying directly on oxygen. Movement is highly metabolically expensive. Under hypoxic energy stress, the fetus conserves power, suppressing movement before almost anything else. This biological timeline is fixed, meaning movement begins at the exact same gestational age for everyone. A prima gravida simply recognizes it later than a multigravida because she lacks the experiential template to identify the early, subtle flutterings. Fetuses operate on sleep-wake cycles of roughly 20 to 40 minutes. The Cardiff count of 10 measures over a 12-hour window to bridge several of these cycles, ensuring that 10 movements are reliably captured in a healthy term fetus. We modify this to a 2-hour window by placing the mother in the left lateral position. This relieves gravid aortocable compression, optimizing uteroplacental blood flow and giving the fetus the required energy to hit 10 movements quickly. If optimal positioning doesn't yield 10 movements, the clinical assumption is that something is actively suppressing fetal energy output. Hypoxia must be formally excluded. The non-stress test, or NST, intentionally avoids the stress of uterine contractions to isolate and test baseline fetal neurological responsiveness. While the machine has 2 transducers, the NST strictly ignores the contraction tokodynamometer and relies solely on the fetal heart rate ultrasound. A reactive NST, driven by the cardioacceleratory reflex, proves 3 conditions are met: an intact sympathetic nervous system, oxygenated brainstem centers, and sufficient energy to move. The mother must be in the left lateral position during the test. Supine positioning compresses the inferior vena cava, which drops venous return and drastically reduces placental perfusion. Furthermore, the mother must be fed. Maternal hypoglycemia translates instantly to fetal hypoglycemia depressing the fetal central nervous system and causing false non-reactive results. A reactive result serves as evidence that the most energy-intensive autonomic neural circuits possess the oxygen surplus required to function. Here, specific beats per minute cutoffs reflect gestational autonomic maturity. Before 32 weeks, an incompletely myelinated sympathetic system reliably outputs a heart rate rise of 10 beats per minute for 10 seconds. After 32 weeks, the fully myelinated system sustains a 15-beat rise for 15 seconds. The requirement of 2 accelerations proves the existence of a reproducible neural circuit, rather than a random fluke. The 20-minute testing window directly matches a single standard fetal sleep cycle. If the initial test is non-reactive, testing extends to 40 minutes to stand 2 full sleep cycles. This definitively eliminates sleep as a false positive for fetal distress. The NST establishes a highly reliable safety profile for 1 week, though it has 0 predictive value for sudden mechanical catastrophes, like a cord prolapse.
This animated trace visual visualizes fetal heart rate variability. The red sympathetic arrow accelerates the heart, while the blue parasympathetic arrow decelerates it, creating an instantaneous 5 to 25 beat per minute oscillation. Hypoxia depletes ATP, causing metabolic acidosis and brainstem depression. This silences neuromodulation completely, causing the baseline to flatline. This chaotic variation proves there is active, constant communication between the brain's baroreceptors and the heart. True variability is chaotic. The sinusoidal pattern, in contrast, is pathologically smooth and regular, undulating precisely 3 to 5 cycles per minute. A sinusoidal pattern is a forced rhythm resulting from baroreceptor activation during severe anemia or from extensive brainstem hypoxic damage. A perfectly smooth sine wave baseline is an obstetrical emergency. It indicates the total loss of normal autonomic control over the heart. This pyramid maps the biophysical profile, combining acute neural markers with a chronic fluid marker. It uses a strict binary scoring system, 2 points or 0 points. Acute hypoxia follows an inverse hierarchy. FHR reactivity fails first. Fetal breathing movements shut down next, followed by the loss of gross body movements. Finally, fetal tone, governed by the deepest spinal circuits, is lost, signifying extreme compromise. Amniotic fluid volume tracks on a separate chronic timeline. Prolonged hypoxia forces a redistribution response, shunting blood away from the kidneys and steadily dropping urine output over days or weeks. An 8 to 10 score is reassuring. A 6 is equivocal. A 4 confirms genuine compromise, and a 0 to 2 signifies a fetus in extremis. An 8 out of 10 score paired with low fluid reveals a fetus compensating acutely today, but whose chronic markers prove prolonged renal underperfusion, placing it on a clear trajectory toward decompensation. This animation demonstrates the contraction stress test. A uterine contraction temporarily compresses the spiral arteries, briefly halting uteroplacental blood flow. A compromised placenta lacks oxygen reserve. The induced contraction drops oxygen below safety thresholds, triggering a delayed vagal reflex known as a late deceleration. The CST is largely outdated. Modern tools like the BPP provide superior physiological data without the inherent risks of inducing contractions. The contraindications for a CST are strictly logical. It is used only when contractions themselves are safe and is avoided in cases like previa bleeding or a classical scar rupture. Today, we rely on the modified BPP, which combines the NST and the amniotic fluid index. It is a highly effective triage tool, capturing acute and chronic domains simultaneously. Modern obstetric surveillance runs on progressive triage. Fast, non-invasive observation triggers comprehensive testing only when physiological red flags appear. Think of the fetus as a hospital on a backup power grid. All 5 BPP departments are functioning normally. Under mild hypoxia, power is rationed. The highest cost luxury functions, heart reactivity and practice breathing, flicker and die. During moderate hypoxia, gross movement ceases, leaving only resting tone as the final acute defense. When chronic hypoxia engages the emergency backup grid, the kidney sector is underperfused for days, leading directly to falling amniotic fluid. Total failure is marked by the loss of the deepest, most primitive resting tone.
These surveillance tests provide a real-time, unified view of human survival biology operating within a closed system. Physically, labor is a repeated hypoxic stress test. Every contraction presents a temporary mechanical challenge to the fetal oxygen supply. When the uterine muscle contracts, intrauterine pressure typically rises to 50 or 80 millimeters of mercury. The thin-walled spiral arteries are low-pressure vessels that cannot remain patent against this force. Consequently, blood flow into the intervillous space essentially stops for 30 to 60 seconds with every contraction. A healthy fetus survives these ischemic intervals by relying on an oxygen reservoir within the placenta, high-affinity fetal hemoglobin that extracts oxygen with extreme efficiency, and a high baseline tolerance for low oxygen levels. This chart maps uterine pressure against fetal oxygen levels, an oxygen account ledger. Each contraction drains the reserve. During relaxation, the account is replenished, but a compromised fetus enters labor with a depleted reserve. Even a standard contraction brings it to the threshold of acidosis. Intrapartum surveillance provides the real-time detection of the precise moment a fetus can no longer cope with these repeated hypoxic insults. The resting fetal heart rate is set between 110 and 160 beats per minute by the balance of sympathetic and parasympathetic tone. This high rate is a physiological requirement. With a small stroke volume, the fetus runs fast to maintain the cardiac output demanded by its body weight. Pathological tachycardia above 160 beats per minute suggests a sympathetic accelerant, such as maternal fever, inflammatory cytokines from infection, or an early catecholamine surge as the fetus mounts an initial stress response to hypoxia. Bradycardia occurs when the heart rate falls below 110. This is driven by sustained head compression, structural heart blocks, or the direct depression of the myocardium by late-stage acidosis. Sustained bradycardia carries more immediate danger than tachycardia. It represents either a complete vagal override of the heart or direct myocardial failure, making it a definitive Category 3 finding. Baseline variability, the jagged, chaotic microfluctuations of 6 to 25 beats per minute seen here, provides the definitive beat-by-beat marker of an intact, well-oxygenated brainstem. These fluctuations prove the autonomic nervous system is actively modulating the sinoatrial node. When this variability is reduced, it indicates that brainstem modulation has weakened. While this occurs during benign fetal sleep cycles or following maternal sedative use, it is also a primary sign of worsening oxygenation. Because reduced variability can stem from sleep, it only triggers a Category 3 emergency when paired with another abnormal feature. This combination confirms the fetus is experiencing brainstem depression rather than a temporary sleep state. Ultimately, normal variability is the most reliable, reassuring sign on a monitor. A fetus with preserved variability is effectively maintaining its oxygen account. Decelerations are highly specific reflexes, mapping to 3 neurological pathways. The first panel illustrates the early deceleration. As the head is compressed, intracranial pressure rises, triggering a reflex fatal discharge. Because pressure is maximal at the peak of the contraction, the deceleration mirrors it perfectly. Early decelerations are purely mechanical, the 9 reflexes involving no hypoxia. Late decelerations, shown in the second panel, indicate uteroplacental insufficiency. During a contraction, oxygen levels drop below the threshold for chemoreceptor activation. These decelerations are delayed because deoxygenated blood takes 10 to 30 seconds to reach chemoreceptors. The heart rate slows after the contraction peaks. Variable decelerations, in the third panel, result from cord compression. The pinched cord causes sudden spikes in fetal blood pressure. These traces are sharp and V-shaped because the baroreceptor response is instantaneous. The brief accelerations, or shoulders, before and after the dip represent the sympathetic nervous system compensating for changes in venous return and arterial resistance. Variable decelerations become concerning when they persist without recovery time, drop below 60 beats per minute, or lose their shoulders. These changes indicate the autonomic nervous system is no longer robust enough to mount a compensatory response. If a deceleration lasts between 2 and 10 minutes, it is classified as prolonged. Clinically, this often results from oxytocin hyperstimulation, where the uterus remains contracted for too long to allow placental blood flow to resume. The timing and morphology of these dips act as a diagnostic signature, revealing whether the fetus is responding to harmless pressure, cord occlusion, or a failing placenta.
When the oxygen withdrawals are too frequent for the account to replenish, the fetus shifts to anaerobic metabolism. This process is highly inefficient, producing minimal energy while allowing lactic acid to accumulate in the blood. This leads to a drop in fetal blood pH. A value below 7.25 indicates acidemia, but crossing the 7.20 threshold marks significant acidosis, where the body's buffering capacity is completely overwhelmed. Below pH 7.20, the risk of brain injury rises. The heart muscle is depressed by the acid, and cellular injury begins. A distinct morphological failure here is the sinusoidal pattern. It appears as a perfectly smooth, repeating wave, completely regular and monotonous. The sinusoidal pattern is a pathological oscillation caused by severe fetal anemia. When oxygen carrying capacity is critically low, the cardiovascular system enters a repeating compensatory rhythm that reflects profound compromise. A true sinusoidal pattern, or a pH below 7.20, indicates that the fetal oxygen account is bankrupt, necessitating an emergency delivery. While continuous heart rate monitoring is highly sensitive, meaning it catches almost every fetus in trouble, it has low specificity. Many traces that look non-reassuring actually represent a fetus that is not yet acidotic. Trials in low-risk populations have shown that universal monitoring increases the rate of cesarean sections and operative deliveries without a proportional reduction in cerebral palsy or mortality. Because of this data, the WHO recommends intermittent auscultation for low-risk labors. Checking the heart rate at 15 to 30-minute intervals ensures the baseline is stable without overreacting to the transient stresses of normal labor. In high-risk cases where the monitor trace is indeterminate, clinicians use fetal scalp stimulation as a functional neurological test. If a physical pinch elicits a heart rate acceleration, the neurological chain from skin to brainstem to heart is intact. This response is strong evidence that the fetal pH is still above the 7.20 danger threshold. If there is no response, clinicians may proceed to fetal scalp pH sampling. This requires 4 to 5 centimeters of cervical dilation, and the fetal head must be low enough in the pelvis to reach the scalp. Because heart rate traces purely measure an active stress response, definitive clinical decisions often require these functional or biochemical adjuncts to confirm true metabolic failure. The ACOG framework categorizes these traces based on the status of the fetal oxygen account. Category 1 represents a healthy credit balance, while Category 3 represents imminent bankruptcy. Category 3 criteria are particularly ominous. For example, combining late decelerations and absent variability means the fetus experiences hypoxic insults while losing the capacity to compensate. When a trace is non-reassuring, clinicians perform in utero resuscitation. The goal is to manipulate withdrawal and replenishment rates. Stopping oxytocin halts contractions, instantly removing mechanical pressure on spiral arteries. Placental blood flow resumes, rapidly replenishing the fetal oxygen reserve. Maternal positioning is also critical. Moving the mother to her left side relieves pressure on major blood vessels, maximizing cardiac output and uteroplacental blood flow. Intrapartum surveillance is the mastery of translating mechanical uterine pressure and neurological reflexes into the management of a fetal oxygen account. It is the real-time detection of when a physiological challenge has become a metabolic crisis. The ACOG framework categorizes these traces based on the status of the fetal oxygen account. Category 1 represents a healthy credit balance, while Category 3 represents imminent bankruptcy. Category 3 criteria are particularly ominous. For example, the combination of late decelerations and absent variability means the fetus is simultaneously experiencing hypoxic insults while losing the neurological capacity to compensate for them. When a trace is non-reassuring, clinicians perform in utero resuscitation. The goal is to manipulate the withdrawal and replenishment rates of the oxygen account. Stopping oxytocin to halt contractions instantly removes mechanical pressure on the spiral arteries. This allows placental blood flow to continuously replenish the fetal oxygen reserve. Maternal positioning is also critical. Moving the mother to her left side relieves pressure on major blood vessels, maximizing cardiac output and uteroplacental flow.
Intrapartum surveillance is the mastery of translating mechanical uterine pressure and neurological reflexes into the management of a fetal oxygen account. It is the real-time detection of when a physiological challenge has become a metabolic crisis. To understand anemia in pregnancy, we start with the placenta. By term, this organ demands 600 to 700 milliliters of blood every minute. It has no autoregulation. It operates as a passive, low-resistance circuit, meaning it simply accepts whatever volume and pressure the maternal heart delivers. To meet demand, maternal blood capacity expands disproportionately. Plasma increases by 50%, while red blood cells only rise by 30%. Because the liquid phase outpaces the cellular phase, hemoglobin concentration falls. This is physiological anemia, a purposeful dilution, not a true deficiency. This hemodilution acts as a buffer against the inevitable blood loss of delivery. But when a 1,000 milligram iron demand is superimposed on this system, a demand diet alone cannot meet, the buffer collapses into a pathological crisis. Treating maternal anemia requires us to abandon memorized protocols. By reconstructing fluid dynamics and iron kinetics from first principles, every diagnostic threshold, complication, and pharmacological rule becomes entirely predictable. That disproportionate plasma expansion serves specific mechanical purposes. It reduces blood viscosity to ease flow through small placental vessels, increases cardiac preload via the Frank-Starling mechanism, and dilutes the natural hypercoagulable state of pregnancy. This chart tracks hemoglobin concentration against gestational age. As plasma volume begins its rapid rise, the hemoglobin curve inevitably dips, reaching its lowest point, or nadir, between 28 and 32 weeks, when hemodilution is at its absolute peak. The World Health Organization sets a firm threshold here at 11 grams per deciliter. In a healthy woman with adequate iron stores, physiological dilution will bring hemoglobin down to this line, but no lure. If it drops below 11, we are looking at genuine pathology. Because hemodilution is maximal around 28 to 32 weeks, the CDC establishes a slightly lower threshold of 10.5 grams per deciliter, specifically for the second trimester. This dip isolates the exact window where the physiological range bottoms out before stabilizing. Below these limits, we categorize severity based strictly on remaining oxygen carrying capacity, from mild anemia at 10 to 10.9, down to moderate, severe, and the ICMR's very severe category, below 4 grams per deciliter, where tissue oxygenation is critically compromised and the heart operates at maximum compensatory output. These diagnostic cutoffs are not arbitrary policy numbers. They are rigid mathematical boundaries derived directly from the expected limits of human hemodilution. Pregnancy creates a total iron demand of approximately 1,000 milligrams. That mass is divided into 3 active compartments: 500 milligrams to expand the maternal red cell mass, 300 milligrams actively stripped away by fetal transferrin receptors, and 250 milligrams for obligatory daily losses. This demand is not evenly distributed. In the first trimester, the requirement is only 0.8 milligrams per day. By the third trimester, as fetal mass and maternal plasma volume peak, that daily requirement scales to 10.5 milligrams. Getting that iron into the bloodstream requires a precise biological sequence. Inside the duodenal enterocyte, the D-site B enzyme reduces dietary ferric iron to its ferrous state. It then crosses the cell membrane through the DMT1 transporter and exits into the blood via ferroportin. Even when low hepcidin levels upregulate this absorption efficiency to 20 or 30%, the math fails. A normal diet provides around 10 to 15 milligrams of poorly bioavailable non-heme iron. It is physiologically impossible to extract 10.5 absorbed milligrams per day from food alone. Dietary inhibitors further restrict this pathway. Calcium physically outcompetes iron at the exact same DMT1 receptor. Meanwhile, tannins in tea form insoluble complexes with iron in the gut lumen, blocking absorption entirely. Because of the strict kinetic limits of the enterocyte and the massive third trimester draw, physiological iron depletion is an inevitable outcome without targeted pharmacological intervention. When iron intake falls short, the body drains its compartments in a specific sequence: storage iron first, then transport iron, and finally functional iron. Our routine blood panels track this chronological collapse. Because intracellular storage is mobilized first, serum ferritin is the earliest and most sensitive marker of depletion. It drops below 20 micrograms per liter, while the downstream indicators remain artificially stable. This is the pre-latent phase. Once stores are exhausted, serum iron falls. The liver senses this deficit and upregulates transferrin synthesis to capture any available iron. This drives the total iron binding capacity sharply upward, which mathematically forces transferrin saturation to plummet below 10%. Eventually, red cell synthesis is restricted. Mean corpuscular hemoglobin concentration, or MCHC, is the most sensitive index here. It measures a direct drop in intracellular hemoglobin density, identifying hypochromia long before the cells overtly become microcytic. This trajectory is entirely different from anemia of chronic disease. In chronic inflammation, interleukin-6 stimulates the liver to produce high levels of hepcidin. This degrades ferroportin, trapping iron uselessly inside macrophages, even when total body stores are adequate. To definitively differentiate these states, the absolute gold standard is a bone marrow biopsy with a Prussian blue stain, which directly visualizes the presence or absence of iron in the marrow macrophages. Every value on a standard blood panel represents the end of a long chain of macrophage and enterocyte failures, a delayed reflection of an iron supply that collapsed weeks ago. Iron is only one limiting substrate. Pregnancy also increases the daily folic acid requirement to 500 micrograms, driven by the expansion of maternal red cell mass and the critical window of fetal neural tube closure between days 21 and 28. Folate is required for purine and thymidylate synthesis. Without it, DNA replication stalls.
Red blood cells continue to grow but cannot divide, resulting in large, oval macrocytes and hypersegmented neutrophils. Folate is also required to convert homocysteine to methionine. When folate is deficient, toxic homocysteine molecules accumulate in the blood. They cause oxidative stress and physical microinfarctions along the delicate placental endothelium, directly linking folate deficiency to abruptio placentae. Standard folate deficiency is treated with 1 milligram per day, but patients with sickle cell disease require 5 milligrams per day. Their hyperactive bone marrow must sustain an erythropoiesis rate 5 to 10 times normal just to compensate for chronic hemolysis, consuming massive amounts of folate. These inherited hemoglobinopathies map cleanly to geography. Both the beta thalassemia trait in Western India and the sickle cell trait in central tribal regions spread because they conferred a survival advantage against endemic malaria. Localized genetic adaptations to ancient pathogens permanently alter the baseline hematological demand, forcing us to adjust our clinical approach for specific obstetric populations today. Because anemia limits oxygen delivery, the placenta fails to properly remodel the maternal spiral arteries. This chronic placentic ischemia forces the tissue into a state of hyperplastic growth, a disorganized cellular expansion designed to maximize surface area at any cost. This ischemic placenta then sheds anti-angiogenic factors like SFLT1 into the mother's bloodstream. These molecules strip away the protective endothelial lining of the maternal vascular system, resulting in the systemic hypertension and proteinuria of preeclampsia. The chronic hypoxic stress also activates the endocrine system. Elevated cortisol and placental corticotropin-releasing hormone stimulate prostaglandin synthesis, directly triggering preterm uterine contractions and the premature rupture of membranes. Within the myometrial muscle tissue itself, severe anemia restricts oxygen delivery, halting ATP production. Without energy, the uterus loses its ability to contract. This causes uterine inertia during labor and catastrophic postpartum hemorrhage after delivery. The greatest risk to the mother's life actually occurs immediately postpartum. The delivery suddenly relieves inferior vena cava compression and squeezes up to 500 milliliters of blood back into systemic circulation. This immediate volume surge forces a chronically stressed high-output heart straight into acute left ventricular failure. We can see the evidence of this systemic hypoxia on physical exam. Nail cytochrome failure causes the concave beds of koilonychia. Mucosal turnover failure creates a smooth, painful tongue in glossitis, and hemolysis overwhelms the liver, resulting in jaundice. Ultimately, the hematological deficit triggers a total systemic failure.
an interconnected cascade where hypoxic stress results in obstetric hemorrhage and cardiovascular collapse. To prevent this cascade, public health guidelines mandate 60 milligrams of elemental iron prophylactically, doubling to 120 milligrams for active treatment. However, free ferrous irons catalyze oxidative reactions in the stomach and alter the colonic microbiome, guaranteeing the nausea and constipation that drive widespread noncompliance. Parenteral iron bypasses the gastrointestinal tract entirely, delivering iron directly to the reticuloendothelial macrophages. But it is strictly contraindicated in the first trimester. All IV iron releases transient free iron, generating reactive oxygen species that pose unacceptable risks to the rapidly dividing cells of early organogenesis. When calculating the exact intravenous dose, we use the Genzoni formula. It multiplies a constant of 2.4 by the hemoglobin deficit and the patient's pre-pregnancy weight in kilograms. We use pre-pregnancy weight because the active gestational mass does not participate in hemoglobin synthesis. The choice of formulation determines the delivery speed. Standard iron sucrose has a strict 200 mg daily limit so as not to overwhelm macrophage processing capacity. Newer ferric carboxymaltose uses a stable carbohydrate shell, allowing a rapid 1,000 mg infusion in a single session without triggering systemic oxidative stress. Pharmacotherapy must also address losses. A heavy hookworm burden causes up to 50 milligrams of continuous occult iron loss per day. Second trimester albendazole halts the strain. Additionally, delaying umbilical cord clamping transfers residual placental blood, giving the neonate a vital iron autotransfusion. Every pharmacological intervention in maternal anemia is a precise exercise in maximizing absorption and overcoming pharmacokinetic bottlenecks, all while navigating the strict limits of maternal and fetal toxicity. This brings us to the 4 mandatory antenatal screening checkpoints. We establish a baseline in the first trimester. Then we check again at 28 weeks to capture the physiological nadir of hemodilution. We check at 34 weeks, and finally at 36 weeks. These late-stage markers are dictated by the kinetic limits of erythropoiesis. 34 weeks is the final practical window to administer IV iron and allow the bone marrow enough time to produce red cells. By 36 weeks, time has run out, and we must prepare for direct blood transfusion. The rules of transfusion are strictly mathematical. 1 unit of packed red blood cells contains exactly 45 grams of hemoglobin. When distributed across the expanded maternal blood volume, it predictably forces a 1 gram per deciliter rise in circulation. Maternal anemia is the predictable consequence of a physiological system actively sacrificing its own structural integrity to sustain a parasitic fetal sink. By understanding the rigid mathematical constraints of blood volume, iron kinetics, and erythropoiesis, we remove the guesswork. Every obstetric protocol, diagnostic threshold, and treatment decision transforms from a memorized rule into pure derived logic. Pregnancy initiates a 9-month, high-stakes cardiovascular stress test. A woman's body actively diverts systemic resources to feed the developing fetus, and in doing so, rigorously unmasks any underlying maternal cardiac pathology. The physiological mandate driving this stress test is the placenta. It develops as a massive, low-resistance, high-flow organ. To keep it supplied with oxygen and nutrients, the maternal body is forced to run a secondary circulatory system in parallel with its own. To meet the intense flow requirements of this new organ, the maternal cardiovascular system must execute 3 simultaneous adaptations: obligate systemic vasodilation, massive volume expansion, and resting tachycardia. This triad, vasodilation, volume expansion, and tachycardia, governs every clinical observation in obstetric cardiology. From the soft flow murmurs of a perfectly healthy pregnancy to the acute failure of a severely diseased valve, each outcome is a direct consequence of how the heart manages this increased load. This dashboard tracks the maternal systemic circuit. The biochemical markers of pregnancy, specifically progesterone and relaxin, act as smooth muscle relaxants. They force peripheral arterioles to dilate, opening up the vascular bed to increase placental flow. This causes peripheral vascular resistance to drop, with diastolic blood pressure plummeting to its lowest point during the second trimester. A severely dilated vascular bed means pressure drops. To maintain systemic perfusion against that falling resistance, the heart compensates mathematically. It increases stroke volume by filling more completely, and it raises resting heart rate by 10 to 20 beats per minute. Together, these factors multiply to drive total maternal cardiac output up by 40 to 50%. This graph maps that cardiac demand across gestation. The output increase begins as early as 5 weeks, long before the uterus physically enlarges. It reaches its absolute maximum at 28 to 32 weeks and does not return to the pre-pregnancy baseline until roughly 10 days postpartum, as blood volume slowly normalizes. Alongside these chemical adaptations, a mechanical constraint emerges. As the graphed uterus expands, it physically compresses the inferior vena cava, obstructing the primary drainage route from the lower body back to the heart. Femoral venous pressure rises sharply. This mechanical compression traps blood in the lower extremities and pelvis. The resulting peripheral venous pooling is the direct cause of the varicose veins, vulval varicosities, and hemorrhoids routinely observed during gestation. The gravidic baseline is a state of extreme compensation. The maternal cardiovascular system is pushed to its maximum physiological limits, just to maintain resting homeostasis. This split-screen comparison charts maternal cardiac metrics. Because a healthy heart adapts proportionally to the increased volume, right heart filling pressure, measured as jugular venous pressure, remains completely unchanged. Pulmonary capillary wedge pressure and left ventricular ejection fraction also stay locked in their normal ranges. The physical expansion of the uterus pushes the diaphragm upward, lifting the heart and rotating it to the left. This shifts the apical impulse. The hyperdynamic pumping state forces louder valve closures, creating an S1 split, a physiological S3 from rapid ventricular filling, and soft ejection systolic flow murmurs across normal valves. When the myocardium lacks the capacity to adapt, true failure occurs. If the left atrium cannot process the volume load, pressure backs up into the pulmonary veins. This presents clinically as progressive dyspnea, orthopnea, paroxysmal nocturnal dyspnea, or hemoptysis. Easy fatigability, dyspnea on exertion, and dependent edema occur because maternal cardiac output is already stretched to its maximum at rest. These symptoms represent the depletion of cardiac reserve. They are the physiological boundaries of pregnancy, not indicators of a failing heart. Similarly, an elevated jugular venous pressure explicitly indicates right heart strain. The auscultation of an S4 murmur confirms that blood is being forced into a stiff, non-compliant, failing ventricle. The diagnostic rule is absolute. Any physical sign indicating unilateral pressure backup, structural non-compliance, or a diastolic flow restriction means the heart has failed its gravidic stress test. Looking at this cross-section of a narrowed mitral valve, the reason stenotic lesions become lethal is mechanical. The valve severely restricts flow from the left atrium to the left ventricle. As the mandatory pregnancy-induced tachycardia accelerates the heart rate, the diastolic filling phase is disproportionately shortened. The heart has less time per beat to push blood across the narrow opening. Left atrial pressure spikes, backing fluid into the lungs. This immediate pulmonary edema is why dyspnea on exertion is the definitive first symptom of mitral stenosis in pregnancy. Regurgitant lesions follow the inverse rule. In aortic regurgitation, an incompetent valve allows blood to leak backward into the left ventricle during diastole. However, the systemic vasodilation of pregnancy drastically lowers diastolic blood pressure. This shrinks the pressure gradient pushing against the valve. Because diastolic blood pressure is the primary driving force for the backward leak, lowering the systemic resistance physically decreases the regurgitant fraction. The body's natural vasodilation acts as an internal therapy, improving the pathology. This same mechanism explains the lethality of Eisenmenger syndrome. A patient with this condition relies on high systemic vascular resistance to counter their high pulmonary resistance. When pregnancy forces systemic resistance to drop, the fibrotic pulmonary vessels cannot adapt. The pressure gradient widens drastically, forcing deoxygenated blood through the shunt and triggering massive cyanosis. A maternal lesion's survivability is dictated by how its structural defect interacts with lowered systemic resistance and increased resting heart rate. This clinical matrix outlines WHO Class 4 conditions. These are specific cardiac pathologies carrying a prohibitive risk of maternal mortality, making pregnancy absolutely contraindicated. Fixed output lesions, including pulmonary hypertension and severe mitral or aortic stenosis, belong here.
because the heart physically cannot push more volume through rigid pipes. It is mechanically impossible to meet the 50. Subjecting that fragile tissue to gravitic volume demands creates an imminent risk of catastrophic aortic dissection. WHO Class 4 represents a rigid mathematical boundary. If a patient's anatomy cannot accommodate a 50% increase in cardiac output, structural collapse is the result. This timeline graph maps maternal volume load, identifying the exact chronological moments when the system is most vulnerable to collapse. The first critical peak occurs at 28 to 32 weeks gestation, the precise point where baseline maternal cardiac output reaches its absolute maximum. The second peak hits during the late first stage of labor. Intense uterine contractions squeeze the vascular bed, rapidly autotransfusing 300 to 500 milliliters of blood directly into central circulation with every single contraction. The third peak occurs in the second stage of labor. The maternal Valsalva effort heavily spikes intrathoracic pressure, cutting off venous return. When the patient releases the breath, a massive, sudden surge of trapped blood slams back into the heart. The fourth and most lethal peak arrives immediately postpartum. As the uterus forcefully involutes, it expels 500 milliliters of blood from the placental circuit directly into the maternal heart in an instant. Peripartum heart failure strikes at these intervals. Acute volume surges outpace the failing myocardium's capacity for compliance. Intrapartum management relies on actively manipulating these hemodynamic forces. The patient is placed in a left lateral tilt to mechanically uncompress the inferior vena cava and stabilize return flow. Operative vaginal delivery using forceps or vacuum is employed to entirely eliminate the dangerous intrathoracic pressure swings of the Valsalva effort. Epidural analgesia is mandatory. Blocking the pain response prevents sympathetic activation and avoids the severe tachycardia that destroys diastolic filling times. For uterine tone, oxytocin is utilized safely due to its mild vasodilatory properties. Conversely, methyl argometrine is strictly contraindicated. The drug triggers intense vasoconstriction, creating massive systemic afterload spikes that can immediately precipitate acute heart failure in a compromised ventricle. The immediate postpartum protocol addresses the 500 milliliter placental autotransfusion. Intravenous Lasix is pushed to rapidly offload the excess volume. The patient's legs are kept lower lung of heart to promote controlled peripheral pooling, and IV fluids are strictly restricted to 75 milliliters per hour to prevent fluid overload. Anesthetic choices follow the same logic. While uraxial anesthesia is standard, general anesthesia is strictly required for patients with intracardiac shunts, severe aortic stenosis, or HACO-CM. These patients depend on high systemic resistance. The rapid vasodilation caused by a spinal block would cause fatal blood pressure drops. Every obstetric intervention is a targeted mechanical choice executed to suppress tachycardia, blunt volume surges, and strictly control systemic afterload. Two specific pathologies require precise interventions. Peripartum cardiomyopathy is defined strictly by its timeframe. Heart failure appearing between 36 weeks gestation and 5 months postpartum, resulting in a reduced ejection fraction in a patient with no prior cardiac disease. The primary pathophysiological mechanism involves the cleavage of prolactin into a highly cardiotoxic 16 kilodalton fragment that damages cardiomyopathies. To directly counter this mechanism, bromocriptine, a dopamine agonist that suppresses prolactin, is added to standard heart failure therapies. In mitral stenosis, the therapeutic goal is entirely mechanical. Beta blockers serve as the mainstay therapy because slowing the heart rate physically lengthens diastole, granting the atrium conduit sufficient time to push blood across the narrowed valve. If the stenosis becomes critical, percutaneous mitral balloon valvotomy in the second trimester serves as the preferred rescue procedure. Traditional valve replacement is avoided, as the non-pulsatile flow of cardiopulmonary bypass causes fatal uteroplacental insufficiency. Even disease-specific therapies function as mechanical workarounds, designed to neutralize the extreme biochemical triggers of pregnancy. Looking at this preconceptional counseling matrix, clinical follow-up intervals map directly to hemodynamic risk. WHO Class 1 conditions carry low risk and require minimal checks. Class 2 patients require per-trimester screening to monitor the heart as the system progresses through its natural physiological phases. Class 3 patients face a high risk of rapid deterioration, demanding intensive screening every 1 to 2 months.
Class 4 demands definitive preconceptional counseling, advising the patient against pregnancy entirely. By anchoring clinical decisions in the physics of gravitic circulation, the shifts in maternal health become predictable, allowing for the active prevention of cardiac collapse. Building a human requires energy at a massive scale. From the moment of conception, cellular division accelerates at an exponential pace, aggressively constructing entirely new organ systems from scratch. Every critical step of this early construction, protein synthesis, organ differentiation, and the precise wiring of the fetal neural network, is strictly dependent on thyroid hormone. The maternal body immediately registers this immense metabolic demand. Logically, the system knows it requires a massive increase in total thyroid hormone production to sustain both the mother and the developing fetus. But if the maternal thyroid simply cranked up its raw active hormone output to meet this new demand, the results would be disastrous. The mother would immediately be thrown into clinical thyrotoxicosis, overwhelming her cardiovascular system. Instead, the maternal body orchestrates a highly precise euthyroid hypermetabolic state. It achieves this balance through the careful manipulation of transport proteins and molecular receptor mimicry. Understanding how to treat thyroid pathologies in pregnancy means discarding standard adult protocols. You have to map this exact physiological adaptation to know why certain drugs are mandatory and why others will cause catastrophic harm. The entire regulatory cascade begins with a single biological trigger, the skyrocketing influx of maternal estrogen the moment a pregnancy is established. This diagram models the first adaptation. An estrogen spike forces the liver to drastically upregulate thyroid-binding globulin, or TBG, dumping it into the bloodstream. This massive influx creates empty binding sites that immediately soak up existing circulating thyroid hormone. Because so much hormone is suddenly locked in transport, the fraction of biologically active free T3 and T4 briefly dips below normal levels. The maternal pituitary gland detects this drop instantly. To compensate, the pituitary spikes its release of thyroid-stimulating hormone, TSH, forcing the thyroid gland to increase its overall production of hormone. The system reaches a new, stable equilibrium. The total amount of T3 and T4 is elevated, and TBG is elevated, but the biologically active fraction, the free T3 and T4, is restored to perfectly normal levels. Because the thyroid gland is working harder to maintain this increased total output, it undergoes a slight physiological enlargement. This is an expected adaptation, distinctly different from a pathological goiter, which indicates glandular failure. This tightly controlled feedback loop allows the mother to safely warehouse the massive amounts of hormone required for pregnancy, cleanly isolating that total volume from her active metabolism. There is a secondary drive on the thyroid occurring simultaneously in the first trimester. Human chorionic gonadotropin, or HCG, is a glycoprotein hormone that hits its absolute peak concentration between 8 to 10 weeks of gestation. Look at this structural comparison of HCG and TSH. Like all glycoprotein hormones, they consist of two subunits. Notice the alpha subunit of HCG is structurally identical to the alpha subunit of TSH. This shared architecture allows peak HCG to weakly bind and hijack maternal TSH receptors. Clinically, this means the thyroid is receiving a bonus stimulation signal. Because the gland is being driven by HCG, the mother's endogenous TSH is temporarily suppressed as a normal physiological response. In extreme cases, such as hyperemesis gravidarum or a molar pregnancy, HCG levels rise exceptionally high. This massive concentration of circulating HCG can overstimulate the receptors, driving a state of gestational transient thyrotoxicosis. This is not autoimmune Graves' disease. It is an extreme physical mimicry of TSH, and it resolves entirely on its own as soon as HCG levels naturally decline after the first trimester. To sustain this elevated hormone production, the thyroid requires iodine. During pregnancy, an elevated glomerular filtration rate drastically increases the amount of iodine cleared by the kidneys, driving the mother's strict daily requirement up to 250 micrograms. The fetus depends entirely on that maternal production early on. Prior to 13 weeks of gestation, the fetal thyroid gland is anatomically present but functionally immature. It cannot produce a single drop of its own thyroxine. At this exact same time, the fetus is undergoing its most critical developmental phase. Neural tube formation and complex brain wiring are actively occurring, and these processes are strictly dependent on thyroxine. This molecular cross-section of the placental barrier shows how the fetus survives. Maternal T3 and T4 molecules are small enough to readily cross the membrane matrix, but maternal TSH, a large, bulky glycoprotein, is completely blocked and bounces off the barrier. This creates a critical vulnerability. If the mother is hypothyroid during the first trimester, she fails to supply the fetus with thyroxine.
Without that hormone, the fetal brain cannot develop, resulting in irreversible neurodevelopmental damage and cretinism. Because maternal TSH cannot cross the placenta to stimulate the fetal thyroid directly, any clinical intervention must focus exclusively on optimizing the mother's circulating free T4. The most common barrier to optimizing that free T4 is Hashimoto's thyroiditis, an autoimmune condition where the immune system destroys the maternal thyroid gland, leading to baseline hypothyroidism. For a patient managing Hashimoto's with exogenous levothyroxine, the clinical protocol is rigid. The moment pregnancy is confirmed, her baseline dose must be increased by 30 to 50% immediately. This dynamic equation illustrates why that massive dosage jump is required. Her baseline dose is suddenly being depleted by 3 aggressive physiological variables: excess TBG binding the drug, an elevated GFR clearing it through the kidneys, and the fetus extracting it across the placenta. In clinical practice, patients are instructed to take 2 extra daily doses per week to rapidly bridge this new deficit, forcing their free T4 back into the high normal range. Managing a hypothyroid pregnancy is an exercise in strict pharmacokinetics. Failing to mathematically adjust the dose for these maternal adaptations guarantees fetal neurodevelopmental failure. Hyperthyroidism in pregnancy requires an entirely different calculation. It is almost always driven by Graves' disease, where thyroid-stimulating immunoglobulins mimic TSH and force the gland into chronic overproduction. The pharmacological objective is to shut down that overproduction using antithyroid drugs. These medications inhibit the enzyme thyroid peroxidase, or TPO, directly halting hormone synthesis. During the first trimester, fetal organogenesis, methimazole is absolutely contraindicated due to severe teratogenic risks, like aplasia cutis and choanal atresia. You must use PTU instead. But once organogenesis ends, teratogenic risk drops. You must execute a pharmacological crossover back to methimazole. This shift is forced by a severe maternal danger. Prolonged use of PTU carries a high risk of fulminant maternal hepatotoxicity, potentially destroying the mother's liver. While antithyroid drugs are rotated based on the trimester, radioactive iodine is absolutely contraindicated at every stage of pregnancy. Radioactive iodine works by destroying active thyroid tissue. Because it crosses the placenta, and because the fetal thyroid actively concentrates iodine after 13 weeks, administering it guarantees total destruction of the fetal gland. Managing Graves' disease relies entirely on this calculated risk-benefit crossover, prioritizing the physical formation of the fetus early on and pivoting to save the mother's liver late in the pregnancy. When this hyperthyroid state spirals out of control, it triggers a thyroid storm. This is a life-threatening hypermetabolic crisis caused by the thyroid suddenly dumping massive amounts of hormone into the circulation, overwhelming the heart. The clinical presentation is severe. The patient experiences runaway tachycardia, extreme hyperthermia, severe agitation, and faces impending heart failure. Acute pharmacological rescue requires an immediate, multi-pronged system override. The first arm is high-dose PTU, which acts instantly to inhibit TPO and stop any new hormone synthesis. This schematic details why PTU is chosen over methimazole in an emergency. PTU possesses a crucial secondary advantage. It actively blocks the peripheral conversion of T4 into the highly potent, biologically active T3, rapidly reducing the hormonal load on the tissues. The second arm of the rescue targets the symptoms directly through the immediate administration of propranolol. Excess thyroid hormone aggressively upregulates beta-adrenergic receptors throughout the body. This forces the patient's cardiovascular system into a state of extreme catecholamine hypersensitivity, making the heart violently reactive to adrenaline. In this cellular model, we see propranolol acting as a non-selective beta blocker. It rapidly shields these exposed receptors, neutralizing the adrenaline response and stabilizing the patient's heart rate while the PTU takes effect. Conveniently, propranolol also shares PTU's secondary function, further blocking the peripheral conversion of T4 to T3.
Surviving a thyroid storm relies entirely on deploying these exact drugs to exploit specific dual-action molecular mechanisms. You are manually overriding a runaway metabolic engine to keep the patient alive. Every clinical intervention in pregnancy maps back to this level of biological logic. From mathematically adjusting a levothyroxine dose by 30% to timing a second trimester drug swap, these protocols are strictly dictated by the immutable realities of binding proteins, barrier permeability, and organogenesis. A human fetus requires exactly one source of nutrition, whatever glucose is circulating in the maternal bloodstream. The fetus aggressively shunts this glucose across the placental barrier 24 hours a day, extracting it even when the mother is sleeping or fasting. If the mother's own muscle and fat tissues absorbed glucose normally during fasting periods, there would not be enough left in circulation. The fetus would starve overnight. Evolution's solution is to make the mother's tissues inherently resistant to insulin. Her cells step aside, keeping glucose in the bloodstream longer for the fetus to consume. Insulin resistance in pregnancy is a biological feature, not a disease. Pregnancy is the only physiological state where an organism deliberately makes itself sick to feed another. This necessary resistance crosses into pathology only when the demand outpaces the mother's baseline pancreatic reserve. When her beta cells can no longer produce enough insulin to overcome the barrier evolution built, maternal blood sugar spirals out of control. Every single clinical complication of diabetes in pregnancy, from structural birth defects to physical delivery emergencies, can be traced back to this single feeding mechanism escalating beyond the body's capacity to compensate. This chart maps human placental lactogen, or HPL. Rising in exact proportion to placental mass, it peaks around week 36. Mechanistically, HPL interferes with insulin signaling, trapping the GLUT4 transporter inside the cell so it cannot clear glucose. Other hormones add supporting layers of resistance. Cortisol promotes gluconeogenesis in the liver, while progesterone directly impairs glucose disposal. Human chorionic gonadotropin, or HCG, is excluded because its role is limited to sustaining early pregnancy. The placenta orchestrates this environment through highly selective permeability. Glucose crosses freely via GLUT1 transporters, meaning fetal blood sugar mirrors maternal blood sugar. Thyroxine and oral agents also cross, but maternal insulin is a large peptide of 51 amino acids. It is too massive to pass, and the placenta actively degrades it, forcing the fetus to produce all its own insulin. This endocrine state makes the maternal fasting state highly dangerous. The fetus extracts glucose continuously. If the mother fasts, her glycogen stores drop rapidly, triggering deep hypoglycemia and accelerated starvation. Her metabolism shifts to burning fat, producing ketone bodies that are highly neurotoxic to the fetal brain in large concentrations. The postprandial state carries the exact opposite threat. Because HPL impairs glucose disposal, the carbohydrates from a meal cause the mother's blood glucose to rise much higher and stay elevated much longer than normal. This specific endocrine cocktail perfectly ensures fetal nourishment, but it traps the mother's metabolism between two volatile extremes: neurotoxic ketosis and fetotoxic hyperglycemia. Between weeks 3 and 8 of gestation, human cells differentiate, migrate, and fold to form all major organ systems. The timing of this critical window determines the exact pathology of the disease. It is the physiological dividing line between pregestational and gestational diabetes. In pregestational diabetes, early excess glucose forces mitochondria into overdrive, sparking off superoxide radicals, or ROS. These radicals disrupt signaling pathways, causing severe rotational errors in the developing heart, such as ventricular septal defects or transposition of the great arteries. The damage extends to the neurological and musculoskeletal systems. Hypoglycemic ROS impairs folate-dependent methylation, driving neural tube defects. It also severely damages the caudal mesoderm, making sacral agenesis, the partial absence of the lower spine, the single most highly specific anatomical marker for maternal diabetes. Pregestational diabetes causes permanent structural malformations because the hyperglycemic injury occurs exactly when the cellular blueprints are being read and executed. Because of these structural risks, fetal surveillance follows a precise anatomical timeline. A level 2 ultrasound is performed at 18 to 20 weeks, the exact window where soft tissue resolution is optimal before fetal bone ossification casts shadows. A dedicated fetal echocardiogram is scheduled at 22 to 24 weeks, specifically to hunt for those septation and rotational anomalies. The clinical screening protocols are reverse-engineered directly from this timeline. The first trimester glucose test exists solely to catch undiagnosed pregestational disease. Finding it early is the only way to intervene before embryopathy occurs. Screening for true gestational diabetes waits until weeks 24 to 28. Testing earlier will miss the diagnosis because 24 weeks is exactly when the rising HPL output finally exceeds the capacity of a borderline maternal pancreas. This flowchart breaks down the DIPSY protocol. Utilizing a 75-gram non-fasting glucose load, a reading above 140 indicates GDM risk, while a reading over 200 represents overt beta cell failure, requiring immediate insulin. Any glucose checks performed at the 30-minute mark during this test are purely safety guardrails for patients experiencing symptomatic hypoglycemia. They are not diagnostic criteria. The entire obstetric screening timeline is calibrated to outpace the physiological growth curve of the placenta. In the third trimester, organogenesis is complete. The Peterson hypothesis outlines the new threat. Maternal glucose crosses the placenta freely, triggering fetal hyperglycemia. The fetal pancreas is forced into chronic hypersecretion of insulin to manage the load. This chart outlines the mechanical cascade. Fetal insulin acts as a potent anabolic growth factor, driving metabolic overgrowth known as macrosomia. This overgrowth is highly asymmetric. The brain remains normal, but the insulin-sensitive trunk and shoulders hypertrophy rapidly, setting up the mechanical trap of shoulder dystocia. Fetal hyperinsulinemia also acts on the fetal heart, causing asymmetric septal hypertrophy. This results in hypertrophic obstructive cardiomyopathy. Because this hypertrophy is driven by the maternal glucose supply, it is fully reversible once the baby is delivered. The excess glucose also alters fluid dynamics.
Fetal hyperglycemia creates an osmotic gradient, pulling fluid into the vascular space. This increases renal perfusion and fetal urine output, filling the amniotic sac to cause polyhydramnios. This sits in direct contrast to oligohydramnios, which occurs when long-standing diabetic vasculopathy restricts placental blood flow and reduces fetal urine production. Unlike the structural teratogenesis of early pregnancy, gestational diabetes purely inflicts metabolic and somatotrophic damage, force-feeding the fetus into a state of pathological overgrowth. The maternal biology absorbs equal damage. High tissue glucose feeds asymptomatic bacteriuria and directly impairs the oxidative burst of neutrophils. Chronic hyperglycemia causes endothelial dysfunction, which drives pregnancy-induced hypertension, while pregnancy-induced hemodynamic shifts accelerate any pre-existing retinopathy. Medical nutrition therapy counters this by enforcing a strict macronutrient split: 40% carbohydrates, 40% fat, and 20% protein. To prevent massive postprandial spikes, these calories are distributed across 3 meals and 3 snacks to flatten the glycemic curve. Caloric adjustments are calculated precisely. Normal weight patients add 350 kilocalories daily, and underweight patients add 500. Obese patients subtract 500 kilocalories to mitigate baseline insulin resistance. However, total intake must never drop below 1,600 kilocalories to avoid triggering starvation ketosis. When pharmacology is required, metformin is superior because it suppresses hepatic gluconeogenesis while severely limiting placental transfer. Glyburide, a sulfonylurea, crosses the placenta in meaningful amounts, forcing the fetal beta cells to secrete insulin and guaranteeing neonatal hypoglycemia at birth. This graph illustrates the mechanics of human premix insulin 3070. The 30% short-acting fraction targets the immediate postprandial glucose spike. The 70% intermediate fraction provides a sustained baseline, effectively suppressing overnight hepatic gluconeogenesis while the mother sleeps. Managing this protocol requires rigid logistics. Dose adjustments are evaluated on day 3 to allow to subcutaneous depot to reach steady-state pharmacokinetics.
The insulin must be stored at 4 degrees Celsius to prevent amyloid-like aggregation, and as HPL peaks in the 3rd trimester, monitoring frequency increases to weekly. Every nutritional and pharmacological intervention is simply an attempt to artificially replicate the failed pancreatic compensation of the mother. Delivery timing balances 2 opposing risks. Well-controlled cases are delivered at 39 weeks to secure lung maturity. Poorly controlled cases are delivered at 37 weeks, balancing the risks of prematurity against the escalating risk of unexplained stillbirth. This occurs as the macrosonic fetus demands oxygen the placenta can no longer provide. The primary barrier to early delivery is the fetal lung. Hyperinsulinemia directly inhibits the enzyme pathway required for surfactant production. To confirm maturity, clinicians test for phosphatidylglycerol, or PG. It is the most reliable biochemical marker because it only appears after 35 weeks and remains completely unaffected by blood or meconium contamination. On the day of delivery, the morning insulin dose is withheld. Active labor consumes massive amounts of glucose, so routine insulin would trigger severe maternal hypoglycemia. During labor, clinicians rely on a 4.5 kilogram estimated fetal weight threshold, above which elective C-section is recommended to prevent mechanical impaction. If vaginal delivery is attempted and the asymmetric shoulders wedge behind the maternal pelvis, the turtle sign appears. The fetal head advances and immediately retracts. Applying fundal pressure in this emergency is absolutely contraindicated. Pushing from above drives the impacted shoulder deeper into the pubic symphysis, guaranteeing a C5-C6 brachial plexus avulsion, Erb's palsy. Instead, the helper maneuvers are applied. Techniques like McRoberts hyperflexion, suprapubic pressure, and the Wood screw maneuver rely entirely on geometric logic. They artificially alter the pelvic diameters and rotate the fetal shoulder out of impaction. The final obstetric crises of a diabetic pregnancy are mechanical, structural emergencies driven entirely by months of biochemical overgrowth. The neonatal transition begins with an immediate metabolic crash. Once the umbilical cord is cut, the maternal glucose supply instantly vanishes, but the hypertrophied fetal pancreas continues pumping massive volumes of insulin. This drives severe neonatal hypoglycemia within the first 1 to 4 hours of life, requiring immediate, frequent feeding or intravenous dextrose. The crash extends into a broader metabolic triad. Hypocalcemia occurs because placental transport is severed and the fetal parathyroid is suppressed. Hypomagnesemia follows via calcium competition. Hypokalemia results as the excess insulin continuously drives potassium out of the serum and into the cells. The neonate must also clear excess blood. Fetal metabolic overdrive in utero causes chronic hypoxia, which triggers renal erythropoietin production. This results in polycythemia, too many red blood cells, which break down rapidly after birth into hyperbilirubinemia. The damage extends far past the delivery room. Under the developmental origins of health and disease concept, this hypernutritive environment epigenetically programs the infant's hypothalamus and exhausts the beta cells, ensuring an elevated lifetime risk of type 2 diabetes. This chart shows the maternal resolution. With the placenta delivered, HPL clears the system and levels plunge vertically to 0. 6 weeks postpartum, an oral glucose tolerance test provides the final diagnosis. If abnormal, the patient had underlying type 2 diabetes. If normal, the gestational diabetes is completely cured. Gestational diabetes is an evolutionary feeding mechanism running out of control. The exact timing of the hyperglycemia dictates the exact nature of the damage. When the trade-off between maternal resistance and fetal demand goes too far, the biology of both patients is rewritten.
Preeclampsia is a systemic disease of the endothelium, the delicate inner lining of the mother's blood vessels. High blood pressure is a late-stage, visible result of a cellular failure that begins months before the first symptom appears. Fetal survival depends on the establishment of a high-flow, low-resistance vascular highway to the maternal blood supply. The fetus cannot rely on passive diffusion alone to sustain its development. To build this highway, fetal endovascular trophoblasts actively invade the mother's uterine wall. This migration occurs in 2 distinct waves, an initial remodeling of the surface decidual segment by 12 weeks, and a deeper invasion into the myometrial segment between 16 and 20 weeks. These fetal cells remodel the maternal spiral arteries from the inside out.
They strip away the muscular and elastic walls, replacing them with fibrinoid material. This transformation turns tight, high-resistant pipes into wide, floppy tubes that carry enormous volumes of blood without requiring extra cardiac effort from the mother. In preeclampsia, the critical second wave of invasion fails. The fetal cells do not reach the deeper myometrial segments, leaving the spiral arteries narrow, rigid, and muscular. According to Poiseuille's law, blood flow is proportional to the fourth power of a vessel's radius. Because these arteries never widened, even a small reduction in their diameter causes a massive exponential drop in blood flow to the placenta. The result is a chronically underperfused, ischemic placenta. Deprived of oxygen, it begins secreting distress signals that trigger a systemic inflammatory response throughout the mother's body. The ischemic placenta releases a cascade of biochemical mediators directly into the maternal circulation. This is the bridge between a localized placental problem and a systemic maternal disease. The primary mediator is a protein called SFLT1. It acts as a soluble decoy receptor that floods the mother's bloodstream. Normally, VEGF and placental growth factor bind to endothelial cells to keep them healthy. SFLT1 binds to these growth factors before they can reach their receptors, effectively neutralizing them. Deprived of vital VEGF signaling, the endothelial cells throughout the mother's body become dysfunctional. The tight junctions between cells break down, and fluid moves from the intravascular space into the surrounding tissues. Simultaneously, the placenta alters prostaglandin balance. Production of prostacyclin, a vasodilator, plummets, while levels of thromboxane A2, a vasoconstrictor, surge. This biochemical shift creates generalized vasoconstriction, hypersensitivity to angiotensin II, and a prothrombotic environment. The mother's circulatory system is structurally and chemically primed for collapse. This single mechanism, the destruction of endothelial health, explains the mechanical origin of every clinical symptom of preeclampsia. The kidney is the first maternal organ to suffer. It is highly sensitive to pressure and flow, making it a reliable indicator of systemic vascular damage. The mother exhibits systemic high blood pressure, yet her kidneys are underperfused. This occurs because the glomerular endothelia cells swell dramatically, a condition called glomerular endotheliosis. This swelling physically occludes the capillary lumen, blocking blood flow despite the high pressure behind it. As the filtration barrier fails, large protein molecules leak into the urine, often exceeding 300 milligrams per day. Because the swollen capillaries cannot filter waste effectively, serum creatinine rises above 1.1 milligrams per deciliter, a level that signifies meaningful impairment in a pregnant patient. In the liver, fibrin deposition in the hepatic sinusoids leads to cellular necrosis. This damage releases liver enzymes into the blood, causing SGOT and SGPT levels to spike. The liver tissue swells against its rigid outer membrane, Glissen's capsule. The stretching of this innervated capsule is the source of the epigastric and right upper quadrant pain reported by patients. If the microvascular damage becomes widespread, it triggers HELP syndrome. Red blood cells are physically sheared, squeezing through turbulent, fibrin-choked vessels, while platelets are rapidly consumed attempting to repair endless endothelial injuries. While these appear as separate organ failures, they are the same microvascular traffic jams occurring in different anatomical locations. The brain normally utilizes autoregulation to protect itself, constricting arterioles to prevent systemic pressure spikes from damaging delicate capillary beds. When blood pressure reaches 160/110, this autoregulatory defense is overwhelmed. In a phenomenon called breakthrough perfusion, the high pressure forces blood into the capillary bed with a velocity the vessels cannot contain. Because the endothelial cells are already leaky and inflamed, this sudden pressure causes fluid to pour into the brain parenchyma. This rapid accumulation of cerebral edema increases intracranial pressure. This swelling causes the signature neurological symptoms of severe preeclampsia: persistent headaches, visual scotomas, and posterior reversible encephalopathy syndrome. When this edema reaches a critical threshold, cortical neurons become hyperexcitable and fire synchronously. This electrical surge is the eclamptic seizure. Eclamptic seizures stem from the brain tissue drowning in leaked fluid. Simply lowering the systemic blood pressure does nothing to remove that interstitial edema, which is why antihypertensives alone cannot stop a seizure once the brain is compromised. The fetus depends on the mother's circulation for every metabolic need. Chronic uteroplacental insufficiency restricts fetal growth and reduces fetal renal perfusion, which lowers the volume of amniotic fluid. The umbilical artery Doppler provides a direct measurement of placental resistance. In a healthy pregnancy, blood flows forward through the umbilical artery during both the systolic pump and the diastolic rest. As the placental vascular bed is obliterated by thrombosis and infarction, resistance peaks. The diastolic flow first hits the zero baseline and eventually reverses, flowing backward toward the fetus. This indicates the fetal heart is struggling against an impossible afterload. The failure of trophoblastic invasion is often an immune failure. Normal remodeling requires maternal natural killer cells to tolerate paternal antigens, which explains why prima gravida status or IVF pregnancies carry higher risk. Low-dose aspirin is used for prophylaxis because it selectively alters the prostaglandin balance. Platelets have no nucleus. Once aspirin inhibits their enzymes, they permanently lose the ability to produce thromboxane. Endothelial cells do have a nucleus, allowing them to regenerate their enzymes and continue producing vasodilating prostacyclin. Aspirin must be started between 12 and 16 weeks of gestation. To prevent the disease, the medication must optimize the vascular environment before the critical second wave of trophoblastic invasion fails. Prophylaxis is effective only when it intercepts the architectural development of the placenta. Once ischemia is established, the opportunity for prevention has passed. In clinical triage, the presence of cerebral or hepatic symptoms, like a severe headache or liver pain, classifies the disease as severe. These symptoms indicate active organ failure regardless of the specific blood pressure reading. Delivery is the only definitive treatment for preeclampsia. Because the placenta is the source of the mediators causing the vascular damage, its removal is the only way to stop the disease progression. Delivery occurs at 37 weeks for mild disease and 34 weeks for severe disease. In severe cases, corticosteroids are administered to mature the fetal lungs, but immediate delivery is required for eclampsia, HELP, or fetal distress. Vaginal delivery with neuroaxial anesthesia is the preferred route. Cesarean sections introduce significant surgical trauma and anesthesia risks to a patient whose vascular and coagulation systems are already compromised. Every clinical decision is a balance between the mother's deteriorating vascular health and the risks of fetal prematurity. Magnesium sulfate functions as an anticonvulsant to protect the brain. It has no significant effect on systemic blood pressure. Magnesium prevents seizures by acting as a physiological antagonist at the NMDA receptor. It physically plugs the receptor's calcium channel, preventing the rapid, synchronous neuronal firing that characterizes a seizure. The Pritchard regimen uses an IV loading dose for immediate brain protection and an intramuscular depot for slow, sustained release. This provides constant protection as the body clears the placental inflammatory markers. Because magnesium is cleared by the kidneys, clinicians monitor the patellar reflex. The loss of the knee-jerk reflex is the first physical sign of toxicity, indicating that serum levels are rising toward a dangerous threshold. Magnesium must continue for 24 hours postpartum. The endothelial damage and circulating mediators do not vanish the moment the placenta is delivered, leaving the brain vulnerable during the immediate recovery period. This treatment buys essential time, stabilizing the brain's electrical environment while the source of the vascular storm is removed. Clinicians aim for a blood pressure between 130 and 140 systolic. Because the unremodeled placental vessels lack autoregulation, maintaining this elevated pressure is necessary to drive blood into the resistant placenta and sustain the fetus. Labetalol is the preferred agent because its combined alpha and beta blockade lowers maternal pressure without starving the placenta. Hydralazine is reserved for acute, severe spikes. ACE inhibitors and ARBs are strictly contraindicated at all stages of pregnancy. These drugs block the fetal renin-angiotensin-aldosterone system, which is required for fetal kidney development. Exposure leads to renal agenesis, a total lack of amniotic fluid, and neonatal death. Diuretics are also avoided. Despite the visible edema, the preeclamptic patient is intravascularly volume depleted. Diuretics further reduce the volume of blood available to the placenta, worsening fetal distress. The clinical management of preeclampsia follows the mechanical requirements of the underlying pathology. Every protocol, from delivery timing to drug choice, is a direct response to the failure of the maternal spiral arteries and the resulting endothelial damage. Before any medicine, before any anatomy, we must address the physical reality of the fetus. It is suspended in fluid. Its lungs are filled with liquid, making it incapable of independent respiration. It has no internal food source, and it cannot remove its own waste. Every life-sustaining function that an adult performs independently is outsourced to one organ, the placenta. It serves as the fetal lung, gut, kidney, and liver, all contained within a single disc of tissue attached to the uterine wall. This creates the central clinical challenge of fetal medicine. How do you evaluate the cardiovascular and neurological status of a patient you cannot directly access? You cannot place a stethoscope on a fetal chest, wrap a blood pressure cuff around its arm, or attach a pulse oximeter. If the cord is compressed or the placenta begins to fail, the fetus compromises silently. We require an indirect window, a way to look at the supply line itself and determine if it is delivering adequate oxygen. To determine if this inaccessible patient is thriving or suffocating, clinicians use Doppler ultrasound. They decode the fluid dynamics of the umbilical circuit to measure how the fetus is interacting with its life support system. The cord carries 3 vessels, 2 arteries carrying deoxygenated blood away from the fetus, and 1 enlarged vein returning oxygenated blood. For redundancy, the arteries link at the placental insertion via the hiatal anastomosis, rerouting blood to equalize pressure if obstructed. These vessels are embedded in Wharton's jelly, a dense mucopolysaccharide matrix. Because the fetus rotates continuously and uterine contractions apply pressure, this jelly absorbs compressive forces, preventing the vessel walls from collapsing. This protection depends on amniotic fluid, which acts as an external shock absorber. When a patient develops oligohydramnios, a severe fluid reduction, the cord loses this cushion. It becomes vulnerable to uterine compression, briefly shutting off blood flow, causing sharp variable decelerations. Cord length dictates specific physical dangers. A cord shorter than 30 centimeters risks tearing the placenta away. A cord longer than 70 centimeters introduces excess slack, creating dangerous true umbilical cord knots or prolapsing through the cervix. The physical and embryological architecture of the umbilical cord directly dictates its mechanical vulnerabilities during both gestation and delivery. At the placenta, physical requirements shift. To ensure efficient gas exchange across the membrane, the placenta must satisfy 2 conflicting demands for its maternal blood supply. It needs a high volume of blood flow, but that blood must move slowly enough for oxygen to diffuse. The umbilical arteries branch into millions of terminal villi. As this vascular bed expands exponentially, blood velocity drastically slows, maximizing diffusion time. This massive branching creates a low-resistance system, offering so little opposition that blood glides forward seamlessly, even during diastole. The umbilical artery has a critical anatomical quirk. It has no autonomic innervation. It cannot constrict or dilate in response to neural signals, lacking any ability to auto-regulate flow. Because it cannot adapt, the umbilical artery acts as an unfiltered mirror of downstream placental resistance. Every change in its waveform is a direct readout of how well the placenta is accepting blood. Pathologies like pregnancy-induced hypertension and growth restriction destroy this capacitance. As the placental vascular bed shrinks, fewer functional villi are available, driving up the resistance pushing back against the umbilical artery. Diastolic flow is the canary in the coal mine. Systolic flow is actively driven by the heart, but diastolic flow relies on passive momentum. This makes diastole highly sensitive to increased downstream resistance. When the placenta fails, diastolic flow is the first to drop. Stage 1 elevated SD ratio means restricted diastolic flow. Deliver at 37 weeks. Stage 2 absent end diastolic flow means forward momentum fails completely. Deliver at 33 weeks. Stage 3 reversed flow means blood bouncing backward, indicating immediate jeopardy. Deliver at 32 weeks. If these stages occur prematurely, clinicians use a pharmacological bridge. Administering corticosteroids like betamethasone crosses the placenta to accelerate fetal long maturation, forcing the production of surfactant to reduce the risk of respiratory distress after birth. Every delivery threshold is a calculated triage, weighing the physics of intrauterine compromise against the neonatal risks of prematurity. When oxygen delivery falls, the fetus initiates an emergency triage protocol, the brain-sparing effect. It vasodilates priority organs like the brain and heart, while vasoconstricting the kidneys, gut, and skin. This renal vasoconstriction causes a drop in fetal urine production. Since fetal urine is the primary source of amniotic fluid, this emergency redistribution directly causes oligohydramnios. This creates a diagnostic trap. Measuring the middle cerebral artery during this phase will show a low-resistance waveform with high flow. In the context of a failing placenta, this is an alarm signal confirming the fetus has activated its final compensatory vascular reserves. As the failing right ventricle pumps against massive placental resistance, it stiffens, causing a reversed A wave in the ductus venosus. Terminally, retrograde pressure transmits backward through the venous system, causing the normally steady umbilical vein to aberrantly pulsate. This sequential deterioration from the umbilical artery to the umbilical vein provides a real-time vessel-by-vessel countdown to total cardiac decompensation. While placental insufficiency is a problem of high resistance, fetal anemia is a problem of depleted oxygen-carrying capacity. The resistance is normal, but the red blood cell count is too low to sustain the tissues. The fetus survives this deficit by increasing cardiac output. It pumps the depleted blood faster and harder, creating a hyperdynamic circulation. We diagnose this state by measuring blood velocity in the middle cerebral artery. A peak systolic velocity spiking above a threshold of 1.5 multiples of the median confirms severe anemia. This has specific etiologies: maternal antibodies in Rh isoimmunization, a viral halt from parvovirus B19, or twin-twin transfusion syndrome volume loss. Untreated anemia leads to high-output cardiac failure. As venous pressure rises, fluid leaks into fetal tissues and albumin synthesis fails, culminating in hydrops fetalis, a state of total fluid overload. The middle cerebral artery holds dual diagnostic power. Its resistance reveals a starving brain, while its velocity reveals a failing heart. Sometimes the cord is structurally abnormal from the start. A single umbilical artery is a marker for complex syndromes because cord vessels develop during the same 4 to 8 week window as the heart and kidneys, sharing molecular pathways. Finding a single artery dictates an immediate anatomical scan for heart and kidney defects. If structural anomalies are found, we perform karyotyping to check for chromosomal conditions like trisomy 18. While Doppler tracks the physics of flow, cardiotocography, or CTG, tracks how the fetal brainstem reacts to stress. These heart rate fluctuations are autonomic reflexes to specific types of hypoxia. Late decelerations indicate uteroplacental insufficiency, with hypoxia trailing behind contractions. Variable decelerations indicate mechanical cord compression, triggering an abrupt, unpredictable heart rate drop. A sinusoidal pattern indicates chronic severe anemia, showing the brainstem has lost beat-to-beat autonomic control. The CTG tracing acts as a neurological readout, translating specific physical stressors into a visible autonomic signature. Fetal medicine centers on the study of extracorporeal fluid dynamics. We rely on 3 diagnostic pillars to evaluate the fetus: the high resistance of a failing placenta, the compensatory vasodilation of a hypoxic brain, and the hyperdynamic velocity of an anemic heart. Every precise threshold, from the 32-week delivery for reversed flow to the 1.5 mom velocity warning, is determined by the progressive physical collapse of the umbilical supply line. The Doppler waveform provides a real-time observation of the fetus negotiating its survival against the rigid constraints of fluid dynamics. A third trimester patient seizes while her liver undergoes spontaneous rupture. Another slips into a hypoglycemic coma. A third presents with sudden, unexplained fetal cardiac arrest. These terminal presentations represent systemic readouts of specific upstream biological failures. Today, we are deconstructing 3 devastating third trimester emergencies: HELP syndrome, acute fatty liver of pregnancy, and intrahepatic cholestasis of pregnancy. Identifying the cellular locus of failure, whether at the endothelial layer, inside the mitochondrion, or across the biliary canaliculus, allows every diagnostic criterion and clinical complication to be deduced strictly through physiological logic. We begin with HELP syndrome. The pathology originates in the uterus. Normal placentation requires trophoblastic cells to convert maternal spiral arteries into wide, low-resistance conduits. In preeclampsia, this fails. The spiral arteries remain narrow, reactive, and chronically ischemic. This animated diagram shows a cross-section of an ischemic placenta releasing distress signals into the maternal bloodstream. The most critical protein, SFLT1, binds and neutralizes circulating growth factors like VEGF. Without these factors, the mother's endothelial cells lose their anti-inflammatory properties, triggering generalized maternal endothelial dysfunction. Moving inside the microvessel, the inflamed endothelial walls rapidly spin chaotic webs of fibrin strands directly across the vascular channels. When red blood cells enter the vessel, they are forced through these partially occluded channels at high velocity. The 8-micron cells collide with the fibrin webs and mechanically fracture into asymmetrical helmet-shaped fragments called schistocytes and Burr cells. This is microangiopathic hemolytic anemia. These dynamic charts show the immediate chemical fallout. The dissolved red cells release large amounts of hemoglobin and LDH, driving LDH levels above 600 international units per milliliter. Macrophages convert the heme to unconjugated bilirubin, pushing serum levels past 1.2 milligrams per deciliter. Simultaneously, the haptoglobin bar plummets below 25 milligrams per deciliter, as it is consumed binding the flood of free hemoglobin. Exposed collagen along this damaged endothelium continuously consumes platelets. The systemic consumption outpaces bone marrow production, driving platelet counts into the thresholds defined by the Tennessee classification: Class 3 up to 150,000, Class 2 up to 100,000, and the severe Class 1 dropping below 50,000 platelets per microliter. HELP is the mechanical consequence of a single placental distress signal, manifesting independently of infectious or direct hepatic toxicity. As this widespread fibrin deposition hits the liver, the webs obstruct the hepatic sinusoids. The resulting ischemia forces hepatocytes to leak intracellular enzymes, driving AST and ALT levels above 70 international units per liter, precisely double the upper limit of normal for pregnancy. Alkaline phosphatase is deliberately excluded from these diagnostic criteria. By the 3rd trimester, the placenta produces its own massive supply of ALP, rendering the enzyme useless for detecting maternal liver injury. Clinical symptoms follow a strict anatomical sequence. Right upper quadrant pain hits first as sinusoidal obstruction congests the liver, stretching the inelastic Glisson's capsule. Jaundice lags behind, appearing only after enough bilirubin accumulates in the plasma to visibly stain the tissue. Endothelial breakdown at the blood-brain barrier leads to plasma fluid leakage into the cerebral parenchyma. This vasogenic edema, combined with local ischemia, creates zones of neuronal hyperexcitability that culminate in eclamptic seizures. We prevent these seizures using magnesium sulfate. Focusing on the neural synapse in this diagram, excessive glutamate binds the NMDA receptor to trigger a depolarization cascade. The magnesium ion physically plugs the calcium channel, directly halting the excitotoxicity at the receptor level. The remaining complications extend directly from the vascular damage. Endothelial necrosis in the decidual vessels causes placental abruption. Capillary leak in the lungs produces non-cardiogenic pulmonary edema. Finally, the diffuse consumption of platelets and clotting factors exhausts the coagulation system, triggering DIC. Every feature of HELP, from liver hematomas to cerebral seizures, maps logically back to the initial destruction of the endothelial lining. Acute fatty liver of pregnancy moves the locus of failure to the hepatocyte mitochondrion. This pathology originates in a genetic mismatch, a heterozygous mother carrying a fetus that is homozygous and entirely LCHAD deficient. The LHAD enzyme catalyzes the third step in the beta oxidation cycle, converting long-chain fatty acids into energy. Its absence stalls the cycle, causing toxic 3-hydroxy fatty acid intermediates to accumulate. During the third trimester, maternal fat oxidation massively increases to conserve glucose for the fetus. Simultaneously, fetal 3-hydroxy intermediates cross the placenta into the maternal circulation. This dual metabolic load overwhelms the mother's limited mitochondrial capacity. Male fetuses and twin pregnancies amplify this maternal hepatic overload through higher metabolic demands and a larger flux of toxic intermediates. Looking inside the mitochondrion, these accumulated 3-hydroxy intermediates act as toxic detergents. They insert themselves directly into the inner lipid membrane, causing protons to leak across the gradient without passing through ATP synthase. The electron transport chain is blocked, and ATP production collapses. This maternal fetal genetic bottleneck triggers a total cellular energetic blackout across the liver. When hepatic ATP fails, energy-dependent processes like gluconeogenesis stop immediately, resulting in profound, rapid-onset hypoglycemia. The urea cycle, which clears toxic ammonia, also requires ATP. When it ceases, ammonia accumulates rapidly in the bloodstream. As this diagram shows, ammonia crosses the blood-brain barrier into star-shaped astrocytes. The cells convert the ammonia into glutamine, drawing in water by osmosis. The astrocytes rapidly swell, compressing surrounding neural tissue and driving the patient into the coma of hepatic encephalopathy. Back in the liver, the loss of ATP paralyzes canalicular transport pumps, stopping bile secretion and bilirubin conjugation. The systemic fallout includes DIC from failed clotting factor synthesis, pancreatitis from acinar cell mitochondrial failure, and proximal tubule toxicity causing acute renal failure. The criteria for fulminant hepatic failure in AFLP represent the clinical reality of a liver utterly devoid of ATP. Intrahepatic cholestasis of pregnancy isolates our focus to the biliary canaliculus. Normally, ATP-dependent transporters like BSEP and MDR3 pump bile acids out of the hepatocyte and into the bile ducts. Genetic variants in these specific transporter genes leave certain women with a baseline bile clearance capacity at the lowest end of the normal range. Referencing the BSEP transport pumps in this diagram, the third trimester brings massive levels of estrogen and progesterone metabolites. These hormone molecules wedge themselves directly into the pumps, jamming their mechanisms and stopping the flow of bile acids. With the pumps blocked, bile acids back up inside the cell and forcefully spill out the opposite side into the maternal bloodstream. This mechanical bottleneck explains why combined oral contraceptives are contraindicated in these patients. Once in the bloodstream, the spilled bile acids activate TGR5 and TRPA1 receptors on sensory neurons. Because the palms and soles have a high density of these nerve endings, the neurogenic itch is concentrated there, worsening at night as cutaneous blood flow increases. ICP represents an endocrine-driven mechanical bottleneck, manifesting separately from the ischemia of HELP, or the metabolic collapse seen in AFLP. Because bile acids are blocked from reaching the maternal gut, the digestive system cannot form the mixed micelles required to absorb fat-soluble vitamin K. Without vitamin K, the liver cannot activate clotting factors 2, 7, 9, and 10. It produces non-functional PVICPA proteins instead, leading to massive postpartum hemorrhage. The danger extends to the fetus. Maternal bile acids cross the placenta and stimulate TGR5 receptors, prompting the premature passage of meconium and increasing the risk of lethal aspiration. Looking at this fetal ECG tracing, bile acids bind to TGR5 receptors on fetal cardiomyocytes. This inhibits potassium currents, stretching the QT interval dangerously wide and triggering lethal sudden arrhythmias. As the line graph demonstrates, bile acid concentrations rise exponentially with advancing gestation. We mandate induction of labor at 36 to 37 weeks to interrupt this curve before the risk of cardiac arrest spikes. Dual therapies address these physiological blocks. Ursodeoxycholic acid displaces toxic bile acids and forces the insertion of new BSEP pumps. Simultaneously, intramuscular vitamin K bypasses the gut to directly restore functional clotting factors. The seemingly disconnected triad of ICP, itching, hemorrhage, and fetal death, is entirely dictated by the specific receptor affinities of displaced bile acids. This tripartite illustration summarizes 3 loci of failure: vascular endothelial ischemia in HELP, genetic mitochondrial collapse in AFLP, and endocrine-blocked canaliculus in ICP. Each pathology expands from a single microanatomic failure into an entirely predictable systemic catastrophe. In advanced pathology, arbitrary memorization of clinical criteria is obsolete when you possess a lossless understanding of the underlying molecular logic.
The clinical management of Rh pregnancy begins with a single baseline scenario: an Rh-negative mother carrying an Rh-positive fetus. The Rh system consists of protein markers on red blood cells encoded on chromosome 1. The D antigen is the most immunogenic of these. People who have it are Rh positive. Those who lack it are Rh negative. These D antigens appear on fetal red cells by 38 days of gestation. Because fetal red cells are antigenetically mature early in the first trimester, well before the placenta becomes a robust mechanical barrier, any early disruption can expose the mother to D-positive fetal cells. A fetus only becomes Rh positive if it inherits the D antigen from the father. If the father is Rh negative, he has no D gene to contribute. All children will be Rh negative, and there is no risk of incompatibility. If the father is Rh positive, we must consider the probability of transmission. Without zygosity testing to determine if he carries 1 or 2 copies of the D gene, clinical practice assumes a 50% chance that the fetus is Rh positive. This genetic requirement makes identifying the father's Rh status the first step at the initial antenatal visit. If the father is negative, the disease framework does not apply, and the patient requires only routine care. These 3 variables, maternal Rh status, the early appearance of fetal antigens, and paternal genetics, form the boundaries for every subsequent clinical decision. Although the placenta separates fetal and maternal blood, it is not a perfect seal. Small volumes of fetal red cells can escape into maternal circulation throughout pregnancy, with the largest transfer typically occurring during the placental separation of delivery. This is feto-maternal hemorrhage. When an Rh-negative mother encounters Rh-positive cells for the first time, her immune system produces a primary response. This reaction is slow and characterized by the production of IgM antibodies. IgM is a large 5-pronged structure. Because of its size, it cannot bind specific neonatal Fc receptors used to transport antibodies across the placenta. This physical exclusion prevents maternal IgM from reaching the fetal circulation, which is why the first fetus is unaffected. However, this primary exposure establishes permanent memory B cells against the D antigen. The mother is now sensitized. In a subsequent pregnancy, this rapid response produces high concentrations of IgG. IgG has a sleek Y-shaped structure, binding precisely to the placenta's transport receptors. The placenta actively moves these antibodies into the fetal bloodstream, coating fetal red cells and marking them for destruction by spleen macrophages. This mechanical distinction, the exclusion of IgM versus the active transport of IgG, explains why Rh disease typically bypasses the first pregnancy and targets the second. Once maternal IgG enters the fetal circulation, it initiates a cascade of destruction. The spleen clears the coated red cells faster than the fetus can replace them, leading to progressive anemia. To compensate for the loss, the fetal bone marrow begins releasing immature, nucleated red blood cells, erythroblasts, into circulation. This state of marrow desperation is known as erythroblastosis fetalis. If the marrow cannot keep up, the liver and spleen resume their early fetal roles as blood factories. This extramedullary hematopoiesis causes both organs to expand, resulting in hepatosplenomegaly. As the anemia worsens, the cardiovascular system attempts to maintain oxygen delivery by pumping faster and increasing cardiac output. This high output state is sustainable only until the heart reaches its mechanical limit and enters failure. Because the fetal liver is focused on making red cells, it produces less albumin. The resulting drop in oncotic pressure means the blood can no longer hold fluid within the vessels, causing it to leak into the body cavities. We define hydrops fetalis as fluid accumulation in at least 2 of 4 compartments: the pericardial sac, the pleural space, the abdominal cavity, or the subcutaneous tissue. This is a diagnosis made purely by ultrasound. Because the scalp has low tissue resistance, scalp edema, the Buddha sign,
is often the first sonographic indicator of fluid accumulation. Postnatally, the destruction of red cells continues, but the baby can no longer rely on the placenta to clear waste. The immature neonatal liver cannot process the resulting surge of unconjugated bilirubin, which can cross the blood-brain barrier and cause the neurological damage known as kernicterus. If the fetus develops severe hydrops, the placenta becomes edematous and releases vasoactive factors into the maternal blood. The mother then develops edema and hypertension, mirroring the fetal condition in what is known as Ballantyne syndrome. Each of these findings, from fetal scalp edema to maternal hypertension, is a direct physiological consequence of uncompensated anemic hypoxia.
To manage this process, we use diagnostic tests that track the immune response. The indirect Coombs test identifies free anti-D antibodies in maternal serum. A positive result confirms the mother is sensitized, while a negative result allows for preventative care. In contrast, the direct Coombs test is performed on the newborn's blood. It checks if the baby's red cells are already coated with maternal antibodies, indicating that an immune attack is currently underway. If sensitized, we perform serial dilutions of maternal serum to find the antibody titer, identifying the highest dilution where antibody activity remains detectable. Clinical data establishes a critical threshold at a 1:16 dilution. Below this titer, severe anemia risk is low. At or above 1:16, we shift from monitoring the mother to directly evaluating the fetus. We assess the fetus non-invasively using Doppler ultrasound of the middle cerebral artery. This measures the speed of blood flow to the brain. The test physics are based on viscosity. Anemic blood has fewer red cells, making it thinner. This lower viscosity blood flows faster through the vessel under the same cardiac pressure. When velocity exceeds 1.5 multiples of the median for the gestational age, it indicates significant anemia. If the Doppler reaches this threshold, we perform chordocentesis. This involves sampling blood directly from the umbilical vein to get a precise measurement of the fetal hemoglobin and hematocrit. This diagnostic sequence follows the pathology as it moves from maternal antibodies to fetal fluid dynamics to direct fetal blood sampling. If we suspect a large hemorrhage, such as after abdominal trauma or a difficult delivery, we use the Rosette test for screening. If that is positive, we quantify the blood transfer using the Kleauer-Betke test. This test uses acid to distinguish between adult and fetal hemoglobin. Adult hemoglobin denatures an acid, leaving the maternal red cells as transparent ghost cells. Fetal hemoglobin is acid-resistant, so those cells retain their color and stain darkly. We calculate the volume of the hemorrhage by multiplying the percentage of fetal cells found by the mother's estimated blood volume. This volume determines the dosing for anti-D immunoglobulin. Anti-D consists of passive IgG antibodies directed against the D antigen. It works through immunological erasure. The injected antibodies bind to fetal red cells and clear them from maternal circulation before the mother's immune system can recognize the antigen and create memory B cells. A 300 microgram dose neutralizes 30 milliliters of fetal blood. Since a standard delivery usually involves less than 4 milliliters of transfer, this dose provides comprehensive coverage for most patients. This blockade is only effective if given before sensitization. Once memory B cells exist, passive antibodies can no longer prevent the maternal immune response. Other minor antigens are plotted on this same matrix based on how often they are encountered and the severity of the hemolysis they cause. The KEL antigen is particularly dangerous because its antibodies do more than cause hemolysis. They also suppress the production of new red cells in the bone marrow, preventing the fetus from compensating for its losses. Conversely, Lewis antigens typically trigger an IgM response. Because these large antibodies cannot cross the placenta, Lewis incompatibility does not pose a clinical risk to the fetus. The clinical importance of any minor antigen is determined by its antibody structure and its effect on red cell production. These principles define the two primary clinical pathways. In pathway A, the mother is unsensitized. The objective is to use anti-D to prevent the immune system from ever seeing the D antigen. This involves administering anti-D at 28 weeks, early cord clamping, and a postpartum dose if the neonate is Rh positive and direct Coombs negative. In pathway B, the mother is sensitized.
Prevention isn't an option, so focus shifts to monitoring fetal hemodynamics. This requires antibody titers every 2 to 4 weeks, followed by MCA Dopplers once the critical 1 to 16 threshold is met. If the Doppler indicates anemia, we confirm the severity through chordocentesis. If we confirm severe anemia in a fetus under 35 weeks, we perform an intrauterine blood transfusion to provide healthy red cells until the baby is mature enough for delivery. The blood used for transfusion must be O negative, CMV negative, and irradiated to prevent graft versus host disease. For a fetus at 35 weeks or older, the risks of continuing the pregnancy outweigh the risks of prematurity. At this stage, delivery is the standard of care. The RH protocol functions as a sequence of logical gates. By measuring antibody transport and fetal fluid dynamics, clinicians can determine the precise moment to move from observation to intervention. Every clinical decision in the management of pregnancy loss derives from one single sequential master question asked in sequence. Bypassing any part of this logic leads directly to diagnostic scatter. Jumping straight to laboratory investigations without verifying the sequence of events results in over-investigation, patient anxiety, and missed pathology. To eliminate that clinical noise, we construct a 6-step algorithm from first biological principles. This sequence maps every detail of acute presentation and recurrent loss. The spine of this algorithm consists of 6 chronological nodes: existence, viability, mechanism, pattern, state, and cause. Adhering strictly to this chronological logic tree forces an objective evaluation of the patient, providing a reliable defense against clinical error. We begin at Node 1, existence. A confirmed pregnancy strictly requires ultrasound documentation of a gestational sac or histopathological examination of expelled tissue. Counting unconfirmed losses, like late periods, anovulatory cycles, or implantation bleeding, pollutes the data. This triggers invasive recurrent pregnancy loss workups for patients who may never have truly had multiple pregnancies. This timeline displays Node 2, viability. The World Health Organization operational threshold places a divide at 20 weeks gestation or a fetal weight under 500 grams. A loss before this mark is an abortion. Anything at or beyond this threshold is an intrauterine fetal death, which requires different legal and clinical documentation. Note 3 establishes the mechanism. We must differentiate a spontaneous abortion, where the body naturally terminates the pregnancy, from an induced medical termination. The rest of this logic applies exclusively to spontaneous loss. Node 4 addresses the pattern. A single loss does not trigger an investigation. Approximately 50 to 60% of early pregnancy failures are caused by random de novo chromosomal errors in that specific embryo. Biologically, a single event is most likely a probabilistic accident. The clinical standard that mandates a full diagnostic workup is the occurrence of 2 or more consecutive confirmed losses. The word consecutive holds biological weight. 2 losses separated by a healthy pregnancy often reflect isolated events. Back-to-back failures implicate a systematic mechanism, a constant factor in the maternal environment disrupting the process. Filtering the patient history through these first 4 nodes establishes the baseline. Only a confirmed, spontaneous, and recurrent loss earns a clinical workup, isolating systematic failures from random chance. In an acute presentation, Node 5 governs the clinical state. We evaluate 5 variables: bleeding, pain, expelled tissue, ultrasound findings, and the cervical Oz. The cervical Oz acts as the definitive biomarker. It operates as a binary switch, categorizing the physiological process as either salvageable or irreversibly committed. A threatened abortion presents with bleeding, but the os remains closed and ultrasound confirms a live fetus. The environment is disturbed, but the process is reversible. Management requires pelvic rest and vaginal micronized progesterone. An inevitable abortion presents with heavy bleeding, active uterine cramping, and an open os. The uterus is actively contracting to expel the pregnancy. The open os confirms the process has committed. Management facilitates expulsion using misoprostol or suction curettage. If the patient passed tissue but the os remains open and ultrasound shows heterogeneous echogenic material remaining in the cavity, this is an incomplete abortion. Retained products must be evacuated. Clinical guidelines mandate manual vacuum aspiration, or MVA, over sharp curettage. Sharp curettage risks creating intrauterine adhesions, known as Asherman syndrome. Oxytocin is administered to control bleeding. A complete abortion is diagnosed when pain stops, the Oz closes, and the uterus appears empty. However, an empty uterus on ultrasound can also indicate an ectopic pregnancy. You must confirm falling serum HCG levels before finalizing the diagnosis. In the presence of acute bleeding, the entire treatment protocol pivots on the physical diameter of the cervical canal. The algorithm also accounts for silent presentations. In a missed abortion, the embryo dies, but residual trophoblastic tissue continues secreting enough progesterone to temporarily prevent expulsion. The Oz remains closed. These ultrasound parameter readouts show the absolute diagnostic thresholds required to avoid premature diagnosis. A missed abortion requires a crown rump length of at least 7 millimeters with no cardiac activity, or a mean sac diameter of at least 25 millimeters with no visible embryo. Management options include waiting for natural expulsion, surgical MVA, or medical management using exactly 800 micrograms of misoprostol. A septic abortion is an absolute clinical emergency caused by a polymicrobial infection of retained products. This is frequently associated with unsafe or unhygienic procedures. Management is simultaneous. You initiate aggressive fluid resuscitation, draw blood cultures, and immediately administer a triple IV antibiotic regimen: ampicillin, gentamicin, and metronidazole. Surgical intervention is mandatory. The infected uterus must be evacuated immediately because antibiotics cannot cure the infection while the necrotic tissue source remains. Note 5 organizes a chaotic emergency presentation into a predictable triage path based on objective physical evidence.
Note 6 investigates the cause of recurrent loss. We systematically deconstruct the 4 biological requirements of gestation: endocrine, structural, genetic, and vascular. Endocrine failures compromise hormonal support. The primary culprits are uncontrolled diabetes, PCOS, hyperprolactinemia, and luteal phase defect, where the corpus luteum fails to produce adequate progesterone before the placenta takes over at 10 weeks. Hypothyroidism is the most critical endocrine target. Elevated TRH drives TSH production and stimulates prolactin release, which can disrupt implantation. For early pregnancy, the TSH threshold is strict. It must be below 2.5 MIUL per liter. This wireframe highlights structural failures evaluated via transvaginal sonography. On the left, a septate uterus appears normal externally, but contains an internal avascular fibrous partition that starves the embryo of blood supply. On the right, a bicornuate uterus results from incomplete fusion, leaving a deep external indentation and 2 separate vascularized horns. Distinguishing these 2 congenital anomalies is vital because the surgical corrections differ. An avascular septum is resected via hysteroscopic metroplasty, while a bicornuate uterus requires an open abdominal Strassmann metroplasty. Acquired structural defects include submucous fibroids, which require hysteroscopic myomectomy, and Asherman syndrome. Asherman syndrome involves the destruction of functional endometrium and is treated with hysteroscopic adhesiolysis followed by hormonal therapy. Structural and hormonal investigations verify that the uterine environment is physically sound and its metabolic supply lines are intact. Cervical incompetence is a mechanical collapse of the internal Oz under the increasing weight of the pregnancy. This results in painless cervical dilation exclusively in the 2nd trimester. The structural weakness can be congenital, as seen in Ehlers-Danlos syndrome, or acquired through trauma, like a previous Letz procedure or cone biopsy. Diagnosis in a non-pregnant patient relies on the painless passage of a Hager No. 8 dilator through the internal Oz. During pregnancy, diagnosis depends on a transvaginal ultrasound showing a cervical length below 2.5 centimeters. The mechanical solution is a surgical cerclage. A history-indicated elective cerclage is placed at 14 weeks. An ultrasound-indicated cerclage is placed between 16 and 24 weeks if shortening is detected. A rescue cerclage is an emergency measure. If the patient has developed chorioamnionitis, a rescue cerclage is contraindicated. Sealing the cervix would trap the infection inside the uterine cavity. The surgical technique is determined by suture height. The McDonald cerclage sits low on the active cervix. The Sherrod-Carr cerclage requires dissecting the bladder to place the suture higher, closer to the internal Oz. The transabdominal cerclage, or TAC, is placed laparoscopically at the highest possible structural point. A transabdominal cerclage is permanent and cannot be removed vaginally.
This commits the patient to deliver via cesarean section for all future pregnancies. Because cervical incompetence is a load-bearing failure of tissue integrity, it requires an anatomical, surgical fix rather than pharmacological intervention. The final causal vectors operate at the microscopic level. A phenotypically healthy parent can repeatedly trigger pregnancy loss through a condition known as a balanced translocation. In this parent, 2 chromosomes have swapped segments without losing genetic data. However, during meiosis, these chromosomes can separate improperly, generating unbalanced gametes. Identifying this via parental karyotyping allows for solutions like preimplantation genetic testing. Vascular competence depends on maintaining blood flow. Antiphospholipid syndrome, or APS, occurs when autoantibodies attack phospholipid binding proteins. This causes endothelial damage and thrombotic placental failure. APS involves the lupus anticoagulant paradox. In vitro, the lupus anticoagulant artificially prolongs clotting times, mimicking an anticoagulant. In vivo, however, it is profoundly prothrombotic. Diagnosis requires the Sapporo-Sidney criteria. Because viral infections can cause transient antibody spikes, positive lab results must be repeated at least 12 weeks apart to confirm a persistent autoimmune state. This prothrombotic state is systemic, presenting with livido reticularis, thrombocytopenia, Liebman-Sachs endocarditis, or arterial strokes. Management during pregnancy requires low-dose aspirin and low molecular weight heparin. Heparin is used instead of warfarin because warfarin crosses the placenta and is teratogenic. Genetic errors and placental thrombosis represent the last categories in the sequence, capable of terminating pregnancies that appear otherwise healthy. When we zoom out, the clinical complexity of pregnancy loss resolves into our 6-step algorithmic map. This map provides a specific diagnostic panel: TSH, fasting glucose, prolactin, transvaginal sonography, the 12-week APS panel, and parental karyotyping. This contrasts the algorithmic panel with tests clinically obsolete for early recurrent loss. Torch and syphilis cause single sporadic fetal deaths, yielding meaningless low-level titers. Routine thrombophilia panels testing for factor V Leiden are excluded. These mutations link to late-term losses, not early abortions. Adhering to the sequential biological requirements of gestation identifies the underlying pathology more reliably than memorizing lists of diseases or ordering exhaustive lab panels. True clinical clarity is a product of this logic.
Let's look at the monitors. Blood pressure is dropping, heart rate is spiking. The ultrasound shows free fluid pooling in the abdomen, and the urine test for HCG is positive. In a hemodynamically unstable reproductive age woman, this combination means a ruptured ectopic pregnancy until proven otherwise. Medical training often treats this emergency as a list of discrete facts to memorize: arbitrary diagnostic thresholds, disjointed symptoms, and isolated surgical criteria. Ectopic pregnancy functions as a predictable, mechanical failure of a complex biological system. We are going to trace this pathology step by step, from cycle day 14 to the operating table. Every clinical feature you see on the ward can be derived strictly from first principles. Replacing rote memorization with a systematic physiological model is the only way to avoid lethal diagnostic traps. To understand the failure, we first need to establish the baseline. In a normal cycle, fertilization occurs in the ampulla of the fallopian tube. The fertilized egg divides into a blastocyst as it travels down the tube and into the uterine cavity. This animated graph shows what happens next. As the blastocyst implants into the uterine wall, its outer layer of cells, the trophoblast, begins secreting beta-human chorionic gonadotropin, or beta-HCG. This molecule acts as a chemical signal sent directly back to the ovary. Beta-HCG shares a nearly identical structure with luteinizing hormone. Because it binds effectively to the LH receptors on the corpus luteum is tricked into surviving, which triggers a massive spike in progesterone production. That continuous flow of progesterone is required to maintain the secretory endometrium and prevent menstruation. The entire pregnancy relies on this fragile feedback loop until the placenta matures enough to synthesize its own progesterone. This transition, called the luteoplacental shift, occurs around 8 to 10 weeks of gestation. Any disruption to the trophoblast's ability to produce HCG in the first trimester causes a total collapse of this hormonal chain. The primary mechanical error in an ectopic pregnancy is impaired tubal transport.
Conditions like pelvic inflammatory disease or the pharmacological effects of nicotine can paralyze the fallopian tube cilia, trapping the dividing blastocyst in place. Stranded in the tube, the blastocyst begins to implant into the thin tubal mucosa instead of the uterus. This creates a suboptimal trophoblast, a cellular layer incapable of normal development. We can see the chemical consequences on this split-screen graph. On the left, a normal intrauterine pregnancy produces steep, exponential HCG and progesterone curves. On the right, the ectopic pregnancy's suboptimal trophoblast produces a sluggishly rising HCG curve, causing the progesterone curve to falter. This specific hormonal profile explains the first clinical symptom, amenorrhea. The sluggish HCG is still enough to provide an initial rescue for the corpus luteum, suppressing the menstrual cycle. The second symptom, pain, arises from tubal distension. As the trophoblast invades the wall, stretching signals travel along sympathetic fibers back to spinal cord levels T11, T12, and L1. This places the pain in the lower abdomen and inner thigh, exactly where pre-rupture ectopic pain is felt. Finally, the third symptom, bleeding. As the suboptimal trophoblast fails, the dropping HCG starves the corpus luteum, progesterone levels crash, and the unsupported uterine lining breaks away as a cohesive, empty decidual cast. Vaginal bleeding in early ectopic pregnancy is progesterone withdrawal. It is not a tubal rupture, and it does not mean the patient is safely miscarrying an intrauterine pregnancy. Once we map the hormonal failure, we must account for the physical ticking clock of the anatomy. This 3D topographical model divides the fallopian tube into 4 distinct segments, each with its own luminal diameter and adjacent vascular network. The ampulla is the widest and most highly plicated segment. Because it accommodates growth the longest, it is the most common site for an ectopic pregnancy, typically presenting around 8 to 10 weeks. Moving medially, we find the isthmus. Its narrow, rigid walls cannot accommodate expanding trophoblastic tissue. Pressure builds rapidly, forcing it to rupture earliest, usually between 6 and 8 weeks. The interstitial segment sits within the thick uterine myometrium. This muscular support allows the pregnancy to survive up to 12 weeks. When it does rupture, its direct connection to the uterine artery guarantees catastrophic hemorrhage. Conversely, an ectopic at the open fimbrial end rarely ruptures under high pressure. Instead, the tissue is simply expelled out into the peritoneum, a process called tubal abortion. When a tubal rupture does occur, it floods the peritoneal cavity with blood, rapidly inducing severe hypovolemic shock. As that blood pools under the diaphragm, it irritates the phrenic nerve, referring sharp pain directly to the patient's shoulder tips. The specific topographical site of implantation dictates the timeline of the emergency and the exact volume of blood loss. Diagnosis begins when a positive urine pregnancy test triggers a transvaginal ultrasound. Interpreting this imaging requires separating definitive confirmation from visual illusions. On the left is a true intrauterine gestational sac, defined by a double decidual sign and a visible yolk sac. On the right is a pseudogestational sac. A pseudogestational sac is merely fluid trapped between shedding layers of decidua, driven by the same progesterone withdrawal we derived earlier. It is not a true pregnancy, but it routinely tricks clinicians into ruling out an ectopic. To interpret an empty or confusing uterus, we use the discriminatory zone. This chart establishes a strict diagnostic threshold for a transvaginal ultrasound at 2,000 international units per liter of serum HCG. If the serum HCG is above 2,000 and the uterus is empty, a normal pregnancy is anatomically impossible, mandating an immediate ectopic workup. If the value falls below that line, we track the kinetic trend using the 48-hour rule. In a normal pregnancy, HCG levels rise by at least 53% over 48 hours. Ectopic pregnancies produce a sluggish, failing kinetic trend. Interpreting an ultrasound in isolation without mapping it against quantitative HCG kinetics is functionally useless. Treatment decisions are dictated by tissue mechanics. Hemodynamic stability is the first node in our logic tree. Unstable patients require an instant laparotomy to manually compress bleeding vessels. For stable patients, we turn to pharmacology. This is methotrexate. It competitively binds to the DHFR enzyme, blocking the synthesis of tetrahydrofolate. Without it, rapidly dividing trophoblastic cells cannot replicate their DNA, and they die.
We derive the eligibility criteria for methotrexate strictly from the size of the trophoblastic mass, high HCG above 5,000, a sac larger than 4 centimeters, or fetal cardiac activity indicate a mass too large for a single dose to kill without causing systemic maternal toxicity. The monitoring protocol requires measuring HCG on days 1, 4, and 7. HCG levels frequently spike on day 4, marking the physical measurement of mass trophoblastic cell lysis, releasing stored hormones into the bloodstream. If a stable patient requires surgery via laparoscopy, the choice is between removing the tube entirely, a salpingectomy, or preserving it with a linear salpingostomy. In a linear salpingostomy, the surgeon extracts the ectopic tissue while preserving future fertility. The incision must be made specifically on the antimesenteric border, the side opposite the blood supply, to prevent hemorrhage. Once the tissue is extracted, the incision is left completely unsutured. Sutures act as a foreign body, inciting inflammation and creating strictures. The tube must heal by secondary intention to prevent luminal stenosis. These medical protocols represent strict, unforgiving applications of folate antagonism and tubal fluid dynamics. We apply these exact same anatomical rules to unusual implantation sites. This 3D model uses the round ligament as the definitive boundary. It creates a separation between an angular pregnancy on the medial intrauterine side and a true corneal ectopic pregnancy on the lateral side. A cervical ectopic is definitively identified by a closed internal os, proving the pregnancy is implanted in the tissue, not just passing through. An ovarian ectopic requires Spiegelberg's criteria, demanding histological proof of ovarian tissue in the sac wall. The most extreme outlier is a secondary abdominal ectopic, where the placenta parasitizes the bowel vasculature to survive. Because tearing this tissue away causes fatal hemorrhage, surgeons deliver the fetus and leave the placenta entirely in situ to regress chemically. We can unify all major patient risk factors: pelvic inflammatory disease, smoking, endometriosis, and past surgeries all trigger the same mechanical failure. They impair luminal transport. Regardless of the specific trigger, a paralyzed cilium or an anatomical scar, the resulting cascade of extrauterine failure follows the same physiological trajectory. We now assemble every concept into a single logic tree. This maps the process from cilia transport to HCG mimicry, topographical rupture, and DHFR pharmacology. Let's trace it. Transport failure forces abnormal implantation, throttles HCG production, starves the corpus luteum, crashes progesterone, and triggers bleeding. While this hormonal collapse is happening, the rigid anatomy of the fallopian tube acts as a ticking countdown to surgical crisis. By abandoning rote memorization and viewing ectopic pregnancy through the lens of first principles, clinicians unlock a predictable physiological map capable of saving lives. Around day 6 or 7 after fertilization, a blastocyst arrives at the uterine wall and begins burying itself into the maternal tissue. At a cellular level, this normal implantation behaves with the same aggressive mechanics as a malignant invasion. The outer layer of the blastocyst, the trophoblast, differentiates into 2 distinct populations. The cytotrophoblast is the stem cell layer, mononuclear, proliferative cells that act as a reservoir. These cells fuse together to form the syncytiotrophoblast, a giant multinucleated mass that serves as the invasive secretory interface with maternal blood. This syncytiotrophoblast layer actively degrades the maternal extracellular matrix using matrix metalloproteinases. It does not merely attach to the uterus, it aggressively infiltrates the decidua. It proceeds to penetrate maternal spiral arteries, remodeling them from narrow muscular vessels into wide, low-resistance conduits. During this process, it begins producing human chorionic gonadotropin, or HCG, in enormous quantities. To survive this invasion, the tissue must escape immune destruction. It expresses HLA-G, a non-classical molecule that suppresses maternal natural killer and T-cell activity, essentially preventing the mother's body from recognizing the tissue as foreign. In a normal pregnancy, this invasion is kept within bounds by a built-in genomic stop signal.
Once the spiral arteries are remodeled and the placenta is established, paracrine signaling from the embryo and the maternal environment causes the invasion to cease. Gestational trophoblastic disease occurs when fertilization errors remove this regulatory governor. Without these molecular breaks, the trophoblast simply continues to do what it was designed to do: proliferate, invade, and produce HCG, but without any limit. The physical pathology of these diseases is dictated by genomic imprinting. This is an epigenetic mechanism where specific genes are expressed only from the maternal copy or only from the paternal copy. This diagram shows the origin of a complete mole. An ovum that has lost its nuclear DNA is fertilized by a single sperm. That sperm then replicates its DNA without the cell dividing, a process called endoreplication, producing a cell where all 46 chromosomes are of paternal origin. Because the genome is entirely paternal, the imprinting balance is destroyed. Genes that are normally only expressed by the father, like insulin-like growth factor 2, are now overexpressed. This acts as a massive growth driver, fueling the overgrowth of the trophoblast. Simultaneously, genes normally expressed by the mother are completely absent. Without a maternal genome, there is no p57, a protein that normally acts as a brake on the cell cycle. This loss of p57 is why complete moles exhibit such unrestrained proliferation. Mammalian development requires both genomes to build an embryo. Without the maternal instructions, no organized embryonic apsis forms. This means no fetal mesenchyme develops, and crucially, no fetal blood vessels form within the villi. Because there is no fetal circulation to move fluid, water accumulates within the villus stroma through osmotic forces. The villi swell into large translucent balloons, the hydropic degranulation that creates the characteristic grape-like appearance of molar tissue. A partial mole, illustrated here, occurs when a normal ovum is simultaneously fertilized by 2 sperms. This results in a triploid cell with 69 chromosomes. This dyspermy happens because of a failure in the cortical reaction, the calcium signaling wave that is supposed to instantly harden the ovum's outer layer to prevent additional sperm entry. Since a maternal genome is present, p57 is expressed, and some highly abnormal embryonic development occurs. You get a mixed histological picture. Some villi become vascularized by a rudimentary fetal heart, while others undergo hydropic change, creating a characteristic scalloped villus outline. The ratio of maternal to paternal genetic material determines the physical outcome, either a pure avascular tumor or a partially vascularized anomaly. In a molar pregnancy, the massive expansion of the syncytio trophoblast layer exponentially increases the production of HCG. This molecular comparison shows that HCG shares an identical alpha subunit with LH, FSH, and TSH. Their beta subunits are also structurally similar, a consequence of these hormones evolving from a common ancestral gene. When HCG concentrations reach extreme levels, the hormone begins to bind to TSH receptors. This triggers a CAMP cascade that drives thyroid hormone synthesis, leading to clinical thyrotoxicosis, tachycardia, tremors, and in severe cases, a life-threatening thyroid storm. HCG also binds avidly to LH receptors. This continuously stimulates the theca cells in the ovaries, causing bilateral hyperstimulation. The result is the formation of large theca lutein cysts, which can grow to over 10 centimeters in diameter. Within the uterus, the disorganized trophoblastic invasion fails to properly remodel the spiral arteries. They remain narrow and high resistance, leading to relative placental ischemia. This ischemia disrupts the angiogenic balance. The tissue produces an excess of SFLT1, a soluble receptor that overwhelms pro-angiogenic factors like VEG. This excess of SFLT1 causes widespread maternal endothelial dysfunction, manifesting as hypertension and proteinuria. Because idiopathic preeclampsia almost never occurs before 20 weeks, its presence this early is a primary red flag for gestational trophoblastic disease. Physically, the uterus fills with the bulk of the proliferating villi, making the fundal height greater than expected for the gestational age. Because there is no rigid fetal skeleton or tense amniotic sac, the uterus has a characteristic doughy, compressible feel on palpation.
These clinical crises, from hyperthyroidism to early preeclampsia, are predictable ripples caused by excess HCG and failed vascular remodeling. Molar pregnancy can cross a threshold into true malignancy through the accumulation of somatic mutations. When these already abnormal cells acquire enough genetic damage, they begin to grow independently of any remaining stop signals. An invasive mole occurs when the tissue retains its villus architecture, but physically breaches the fibrinoid layer at the myometrial interface, invading deep into the uterine muscle. Because this invasion is local and growth is steady, HCG levels typically plateau, staying within a narrow range for weeks rather than falling or rising sharply. Choriocarcinoma is the fully malignant phenotype. It lacks villi entirely, consisting of sheets of cytotrophoblast and syncytiotrophoblast in a biphasic pattern. Because choriocarcinoma cells proliferate exponentially, HCG levels rise rapidly. The tumor often outgrows its blood supply, leading to widespread local necrosis and hemorrhage. These malignant cells spread through the blood. Entering the uterine veins, they are carried to the right heart and into the pulmonary capillaries, the first anatomical filter. This creates the cannonball opacities seen on a chest X-ray, as the invasive trophoblast establishes spherical colonies in the lungs. Metastases also frequently appear in the vagina due to the venous plexus connecting it to the uterus. These deposits are highly vascular and lack proper vessel walls. Because the tissue is inherently invasive and fragile, a biopsy will cause catastrophic hemorrhage that the surrounding tissue cannot provide hemostasis for. Malignant transformation discards the villus structure and weaponizes the trophoblast's innate ability to invade blood vessels to disseminate systemically. This raises an immunological question. Why does the mother's immune system fail to reject these foreign malignant cells? The tumor exploits the normal trophoblast's evasion tactics. It uses PD-L1 to shut down, secretes immunosuppressive cytokines like IL-10, and induces regulatory T cells, preventing an immune attack in the decidua. But not all trophoblastic tumors follow this path. Some arise from a third cell type found at the implantation site, the intermediate trophoblast. This comparison matrix shows that while typical molar disease involves rapidly dividing cells, intermediate trophoblast is mononuclear and slow-growing. It produces placental lactogen, or HPL, rather than primarily producing HCG. This cell line gives rise to placental site trophoblastic tumors, or PSTT, and epithelioid trophoblastic tumors. Because these tumors proliferate slowly, they are inherently resistant to standard chemotherapy, which targets rapidly dividing cells. As a result, surgery is the mainstay of treatment, and HPL is used as the primary surveillance marker. The cellular origin of the tumor dictates its survival strategies and its vulnerability to treatment. Most gestational trophoblastic neoplasia is highly curable. The same rapid proliferation that makes the disease so dangerous is exactly what makes it a perfect target for chemotherapy. Anti-metabolite drugs are designed to hit cells that are actively dividing, while leaving slower-growing normal tissues relatively unharmed. Methotrexate inhibits dihydrofolate reductase, halting the folate cycle and starving the cell of DNA building blocks to stop division. Clinicians use folinic acid as a rescue strategy. This reduced folate bypasses the block, allowing slow-dividing normal cells to survive, while rapidly dividing tumor cells die. EMA-CoW uses 5 agents to attack cellular pathways simultaneously. Etoposide breaks DNA. Methotrexate blocks synthesis. Actinomycin D prevents RNA creation. Cyclophosphamide cross-links strands. And vincristine arrests mitosis. This bottleneck makes the probability of a cancer cell resisting all 5 lethal mechanisms nearly zero. Gestational trophoblastic disease is a predictable consequence of normal trophoblastic biology, a cell designed to invade and proliferate, executing its program without its genomic controls. Women have always sought to terminate pregnancies. Making the procedure illegal does not make it stop. It simply strips away medical supervision. The procedure is pushed out of clinics and into unhygienic settings, performed by untrained individuals using improper instruments. Without accountability or emergency backup, the clinical outcomes are predictable. The patient suffers hemorrhage, sepsis, bowel or bladder perforation, and often death. Maternal mortality from unsafe abortion is a well-documented public health catastrophe.
In India, the Penal Code historically established a default prohibition, strictly criminalizing the act of causing a miscarriage. The Medical Termination of Pregnancy Act functions as a strictly defined exception to this default prohibition. It establishes the specific circumstances and professional qualifications under which a termination becomes lawful. By acknowledging that patients will seek termination regardless of the law, the government designed the MTP Act as a strict harm reduction policy. It builds a regulated medical pathway to expand access, while installing mandatory safeguards to ensure the medical system itself does not become dangerous. To understand how these safeguards work, we map them against this visual timeline, tracking gestation from 0 to 24 weeks and beyond. The top axis defines the legal constraints, while the bottom maps the required clinical methods. The exception begins with a valid medical indication. If continuing the pregnancy poses a direct threat to the woman's life, such as severe pulmonary hypertension, or risks grave injury to her physical health, termination is authorized. The law also recognizes psychological trauma. It explicitly states that a pregnancy resulting from rape is legally presumed to constitute a grave injury to mental health. The patient does not have to separately prove her anguish. The fact of the assault is sufficient. An individual taking steps to prevent pregnancy who experiences contraceptive failure is in a situation she did not consent to. The 2021 amendment explicitly extended this indication to unmarried women, protecting reproductive autonomy regardless of marital status. The law actively removes administrative barriers. A woman seeking termination for rape is not required to file a police report first, nor is she required to provide proof of marriage. Forcing a patient to navigate the criminal justice system before receiving health care is re-traumatizing. By stripping away these hurdles, the policy ensures immediate medical access, recognizing that bureaucratic delays drive vulnerable patients straight back to unsafe alternatives. Access also requires valid consent, and the legal framework here relies entirely on medical capacity. An adult, mentally competent woman requires only her own signature. The law actively overrides social hierarchies, granting no legal authority to a husband to veto his wife's medical decision. Guardian consent is strictly required for minors or mentally unstable adults. This acts as a reflection of legal capacity, not a sign of social subordination. As gestational age increases, so does the risk of intervention. The law tightens its oversight accordingly. Up to 20 weeks, a single qualified doctor's approval is sufficient. Between 20 and 24 weeks, the physiological complexity and ethical stakes rise. Here, the law mandates opinions from 2 doctors. One clinician's judgment is no longer enough. Peer oversight is required. Beyond 24 weeks, the upper gestational limit is removed entirely, but strictly for severe congenital abnormalities, such as late-diagnosed anencephaly. To authorize this late-stage exception, a state-mandated medical board must convene. It requires a gynecologist to assess procedural risk, a radiologist to confirm the imaging, a pediatrician to evaluate the neonatal prognosis, and a state government appointee to provide administrative accountability. The regulatory structure scales directly with the clinical reality. As the pregnancy advances and the physical risks escalate, the law sequentially replaces single provider judgment with mandatory peer oversight and multidisciplinary boards, preventing potential abuse. When executing the termination, clinicians follow a strict physiological principle. Always use the safest, least invasive procedure appropriate for the gestational age. Before 9 weeks, pharmacological methods dominate. The process begins with mifepristone, a progesterone receptor antagonist. By blocking these receptors, it starves the early pregnancy of hormonal support, breaking down the uterine decidua. 24 to 48 hours later, the patient takes misoprostol. Prostaglandin E1 analog binds to myometrial receptors, driving rhythmic uterine contractions and softening the cervix to expel the tissue. A pre-procedure ultrasound is not routine. It is strictly mandated to answer specific clinical questions, such as identifying an internal device that needs removal, resolving a discrepancy in gestational dates, or locating a suspected ectopic pregnancy, which these drugs cannot treat. Medical abortion fails in roughly 5 to 10% of cases. If follow-up imaging detects persistent fetal cardiac activity, the patient faces severe risks. First trimester exposure to misoprostol is linked to teratogenic effects, including facial nerve palsy and profound limb reduction defects.
Because of these severe developmental anomalies, continuing a pregnancy after misoprostol exposure is medically unacceptable. If the drugs fail, surgical evacuation becomes an absolute mandate. Between 9 and 12 weeks, the method shifts to suction evacuation. The physician places the patient in the lithotomy position, exposes the cervix with a speculum, and secures it with sponge-holding forceps. They will use a flexible plastic tube called a Carman's cannula, sized exactly to match the gestational weeks. Before any instrument enters the uterus, the physician performs a bimanual exam to determine its size and position. Pushing blind risks immediate perforation. The physician inserts a calibrated uterine sound through the internal os to measure the uterocervical length and confirm whether the uterus is anteverted or retroverted. Next, they administer a paracervical block, injecting 1% lidocaine into the 4 and 8 o'clock positions. The lateral 3 and 9 o'clock positions must be avoided. The descending cervical branch of the uterine artery lies here, and striking it causes systemic toxicity and severe hematoma. The internal os is then progressively opened using smooth, solid metal rods called Hagar's dilators. Once dilated, the Carman's cannula is inserted. Connected to an electric machine, it applies 600 millimeters of mercury of negative pressure, systematically clearing all 4 quadrants of the uterine cavity. The physician confirms complete evacuation through 3 physical signs: decreased blood in the tubing, an increased resistance as the internal os begins to close, and a distinct tactile gripping sensation on the cannula as the emptied uterus contracts. In rural clinics lacking reliable electricity, clinicians use manual vacuum aspiration. This utilizes a 60 milliliter syringe with 2 pinch valves to manually generate the vacuum. It is highly active, replacing the obsolete menstrual regulation technique, which relied on a smaller syringe and a single valve. If a sudden loss of resistance occurs during any of these steps, indicating a uterine perforation, the protocol is absolute. The physician must stop immediately and leave the instrument exactly where it is. Pulling it out could release bowel contents or trigger active hemorrhage. The patient is stabilized and assessed for a diagnostic laparoscopy or, if crashing, an emergency laparotomy. Suction evacuation relies entirely on anatomical awareness. A single pass in the wrong direction or a careless injection into an arterial line instantly converts a routine outpatient procedure into a hemorrhagic emergency. Past 12 weeks, the products of conception are significantly larger, and the procedural risks multiply. The methodology shifts to an inpatient setting, utilizing repeated doses of prostaglandins like misoprostol over several hours to induce expulsion. This split-screen diagram shows why oxytocin is pharmacologically useless here. Oxytocin is highly effective in the 3rd trimester because the myometrium is densely packed with active receptors. In the 2nd trimester, those receptors are sparse. There is no target for the drug to bind to. For surgical intervention in the 2nd trimester, clinicians use dilatation and evacuation. This requires placing oslonic dilators in advance, followed by the use of ovum forceps to extract larger tissue that cannot pass through a standard suction cannula. Any necessary scraping inside a standard pregnant uterus requires blunt curettage. The uterine walls at this stage are soft, edematous, and highly vascular. Using sharp instruments risks deep tissue injury and rapid blood loss. There is exactly one exception: the molar pregnancy. Molar trophoblastic tissue adheres aggressively to the uterine wall. Sweeping it with a blunt tool leaves residual cells that develop into invasive disease. Here, sharp curettage is mandatory. By the 2nd trimester, the uterus is a vastly different organ, physically enlarged, heavily vascularized, and mechanically fragile. Operating within it demands rigorous inpatient oversight. Clinicians evaluate MTP requests through a sequential algorithm, tracking legality, personnel, method selection, and documentation. They verify clinical indications, consent, and provider qualifications. Then they select the least invasive method: pharmacology before 9 weeks, suction up to 12, and inpatient induction up to 24. Finally, the physician maintains the medical records for 5 years to ensure regulatory accountability, explicitly without demanding police reports or proof of marriage. The MTP Act aligns legal permissions with physiological risk to replace unregulated, dangerous procedures with a standardized clinical pathway. It creates a precisely engineered architecture where medical guardrails provide a safe, supervised alternative to a historical public health catastrophe. A patient presents at 28 weeks gestation with bleeding. You are immediately facing threats of maternal hypovolemia, fetal hypoxia, and silent coagulopathy. This is why antepartum hemorrhage is taught as a syndrome, not a single disease. You do not have the time to work through a differential diagnosis at your leisure. The mother may be losing blood faster than you can see it, and the fetus could already be in distress. This reality dictates an inflexible, governing sequence for management. Stabilize first, diagnose second, and only then manage specifically. The entire architecture of this topic relies on understanding the two primary culprits, placenta previa and abruptio placentae. Their diametrically opposed clinical presentations are not random lists of symptoms to be memorized. They are absolute, logical derivatives of two completely distinct pathophysiological mechanisms. Internalizing this first principles derivation allows you to bypass diagnostic curiosity. It forces you directly into life-saving, therapeutic decisiveness in an emergency. Normal blastocyst implantation happens in the thick, highly vascular decidua of the upper uterine segment. Placenta previa is defined structurally by implantation in the lower uterine segment, close to or covering the internal os of the cervix. You will often hear about placental migration, but the placenta does not actually move. Instead, the non-pregnant isthmus, initially measuring about 0.5 centimeters, elongates to form a 5 centimeter lower segment by term. An initially low anterior placenta appears to move relatively upward purely through this differential uterine growth. As the upper uterine segment contracts and shortens, the passive lower segment is pulled upward and stretched. Because the placenta is inelastic, this opposing movement creates a severe mechanical shearing force right at the uteroplacental interface. This shearing tears the venous sinuses in the intervillous space. But crucially, the main body of the placenta remains firmly anchored to the uterine wall. It does not detach. Because there is no true placental separation, no thromboplastin is released into the maternal circulation. Without thromboplastin to irritate the muscle, the uterus remains soft, non-tender, and relaxed. The blood escaping from those torn venous sinuses drains directly out of the vagina. It is fresh, bright red venous blood. The bleeding is entirely painless, and because the exact same mechanical trigger occurs with normal uterine growth, the bleeding characteristically recurs. Placenta previa bleeding represents the mechanical reality of normal uterine growth acting on abnormally sited tissue. Modern clinical classification revolves around a strict measurement. A placenta is low-lying if its edge is within 2 centimeters of the internal os. It is classified as placenta previa if it reaches, touches, or completely covers the os. This threshold dictates delivery. Placentas more than 2 centimeters from the os typically permit safe vaginal delivery. Those within 2 centimeters heavily favor or absolutely mandate a cesarean section. The risk factors for placenta previa follow a clear logic. The blastocyst implants lower if the preferred upper implantation site is damaged by previous C-sections, DNC, or endometritis. Alternatively, conditions requiring a massive placental surface area, like diabetes or multiple pregnancy, force the tissue to spread downward. This low implantation introduces the placenta accreta spectrum. Over previous surgical scars, the protective decidua basalis layer is often missing. Without it, the root-like chorionic villi aggressively penetrate deep into the muscular myometrium. There is no plane of cleavage. This anatomy creates an absolute clinical rule. Performing a digital vaginal exam before clearing previa via ultrasound can catastrophically rupture these exposed venous sinuses. For stable, premature cases, we use expectant management, the McAfee-Johnson regime. This requires strict bed rest, zero cervical stimulation, corticosteroids for fetal lung maturity, and magnesium sulfate for fetal neuroprotection. The combination of the 2 centimeter threshold and the risk of accreta establishes placenta previa as a complex surgical challenge that may require a cesarean hysterectomy. Abruptio placentae is the exact anatomical inverse. It is the pathological premature disruption of a normally sited placenta in the upper uterine segment. The initiating event is the rupture of a decidual spiral artery. Blood immediately pools into the potential space behind the placenta, forming a rapidly expanding retroplacental hematoma. Because the blood has nowhere else to go, this expanding dark pool acts as a physical wedge.
It forcefully and progressively strips the placenta away from the uterine wall. Here is the crucial physiological pivot.
This violent disruption of placental tissue releases massive volumes of thromboplastin into the maternal circulation. Thromboplastin acts as a powerful uterotonic. It triggers continuous tetanic contractions. The result is a rigid, woody, and exquisitely tender uterus that does not relax. Simultaneously, the cascade activates matrix metalloproteinases, causing local tissue necrosis, and triggers systemic disseminated intravascular coagulation. Abruptio placentae acts as a self-amplifying biological cascade, using the mother's own uterine muscle and coagulation system to drive the pathology forward. The hemorrhage has two potential fates. In a revealed abruption, blood escapes through the cervix. But in a concealed abruption, blood remains trapped behind the placenta, accumulating in massive volumes internally, while external bleeding remains virtually invisible. This creates a lethal clinical trap. A concealed abruption causes maternal hypovolemic shock that is vastly out of proportion to the visible external blood loss. Abruption severity is graded from 0 to 3. Grade 3 is the cataclysmic end of the spectrum, defined by fetal death, profound maternal shock, and massive DIC risk. The risk factors triggering this vessel rupture fall into two pathways. First, vascular ischemia, driven by chronic hypertension, smoking, or cocaine-induced vasospasm. Second, sudden mechanical decompression, such as the rapid fluid loss from a ruptured polyhydramnios or direct physical trauma. Relying on imaging here is dangerous. Ultrasound misses up to 75% of abruptions because fresh hematomas are isoechoic to the placenta. They look exactly like normal tissue. Abruption remains a strictly clinical diagnosis. Managing a grade 3 abruption with fetal death requires a counterintuitive approach. You must correct the mother's coagulopathy with cryoprecipitate and fresh frozen plasma before performing a surgical delivery. Otherwise, she will exsanguinate on the operating table. In abruption, waiting for visual confirmation, whether waiting to see external blood or waiting for ultrasound proof, is a fatal error. The mother's vital signs must completely dictate your timeline. You must also differentiate true hemorrhage from anatomical mimics. Preterm labor presents with bloody show from a dilating cervix and colicky contractions, lacking the continuous rigidity of an abruption. Uterine rupture is identified by a loss of uterine contour. The fetal station regresses, and fetal parts become easily superficially palpable through the abdominal wall as they extrude from the torn muscle. Vasa previa occurs when exposed vessels cross the internal os. This is strictly fetal blood loss. It presents as immediate fetal bradycardia upon membrane rupture and can be confirmed using the APT test for alkali-resistant fetal hemoglobin. The final common pathway for severe obstetric hemorrhage is disseminated intravascular coagulation. This is a consumptive coagulopathy. The cascade aggressively deposits fibrin microthrombi systemically until all clotting factors are exhausted, resulting in uncontrollable bleeding. A falling fibrinogen level is your earliest warning sign, followed by elevated D-dimers and schistocytes on a blood film. Treatment requires exact component replacement, cryoprecipitate for depleted fibrinogen and factor VIII, and fresh frozen plasma for prolonged clotting times. Misidentifying the anatomical source of bleeding means applying the wrong algorithm to a rapidly ticking clock. You are either racing against the depletion of the fetus's tiny total blood volume in vasa previa, or the mother's dropping fibrinogen in DIC. Before identifying the specific etiology, every antepartum hemorrhage is managed with a universal stabilization algorithm. Start by positioning the patient in a left lateral tilt to relieve aortocaval compression and administer 15 liters per minute of oxygen. Next, secure 2 large bore IVs, 14 or 16 gauge, for rapid crystalloid infusion. However, you must carefully titrate the fluids. Over-infusing crystalloid before blood products are available will dilute the remaining clotting factors and aggressively worsen coagulopathy. Immediately order coagulation screens and cross-match 4 units of packed red cells. If the patient is in life-threatening shock, you do not wait for the cross-match. Administer O-negative blood instantly. Once initial stabilization is achieved, you face an inviolable decision rule. Assess 3 things: maternal vitals, the fetal CTG, and coagulation status. If any single one of those 3 factors is abnormal, immediate cesarean section is mandated, regardless of gestational age or the specific etiology.
Only when all three are normal do you proceed to diagnosis. The logic separates cleanly. Placenta previa is a placenta in the wrong place that mechanically shears without detaching. There is no thromboplastin, leading to painless, bright red bleeding and a soft uterus. Abruptio placentae is a placenta in the right place, but a pathological vascular rupture behind it causes physical separation. This unleashes massive thromboplastin, resulting in continuous pain, dark red blood, a rigid uterus, and DIC. Clinicians manage APH effectively by relying on the mechanical principles of the utero-placental interface and maintaining a strict priority on physiological stabilization.
Following delivery, the uterus undergoes an immediate extreme volume reduction. As it empties of the baby and fluid, the muscular uterine wall aggressively contracts. While the muscular uterus shrinks, the rigid placental mass lacks the capacity to contract. This sharp mismatch in contractility generates the immense shearing force required to buckle the placenta and physically detach it from the uterine wall. This sudden collapse in volume transforms placental separation into a physically forced, structurally violent event. This separation occurs along a precise anatomical line within the decidua basalis, the zona spongiosa. It features large gland remnants, wide intersonular spaces, and large venous sinuses. Offering minimal mechanical resistance, it serves as a built-in perforation line. As the sinuses tear, blood pools rapidly behind the rigid placental disc. This retroplacental hematoma acts as a physical wedge, forcefully dissecting the tissue layers. Shearing through this specific layer allows the placenta to detach while leaving the underlying basal layer intact to regenerate the endometrium for future cycles. The retroplacental hematoma provides the essential mechanical drive required for a healthy separation. After detaching, the placenta follows one of two physical pathways to exit the uterus. In the Schultz mechanism, seen in 80% of cases, the central hematoma pushes the shiny fetal surface out first. The blood remains contained behind the placenta until after it delivers. In the Matthews-Duncan mechanism, the lower edge separates first. This allows maternal blood to escape the cervix before the dull red maternal surface of the placenta appears. Physicians identify internal separation through several external signals, beginning with a sudden, immediate gush of blood. The umbilical cord then appears to lengthen by 8 to 10 centimeters as the detached placenta migrates lower into the uterine segment. As the placenta vacates the upper segment, the uterus tightens from a flat disc into a firm, globular ball, causing the fundus to rise higher in the abdomen. The surest sign of separation is directly palpating the detached placenta within the lower segment during a vaginal examination. These clinical signs serve as direct physical markers of the placental mass moving into the lower uterine segment. Under active management, the third stage of labor must conclude within 30 minutes. Beyond this window, the case is managed as a retained placenta. Active management utilizes oxytocin at the delivery of the anterior shoulder to trigger uterine contractility before separation begins, which speeds the process and reduces blood loss. During the Brandt-Andrews maneuver, the physician applies controlled downward cord traction while maintaining vital upward fundal support. An aggressive downward pull on the umbilical cord without supporting the fundus can cause the entire organ to turn inside out. Retained placentas are caused by three distinct mechanisms: entrapment by a contracting cervix, physical adherence due to incomplete separation, or morbid adherence where no cleavage plane exists. Attempting to force the mechanical sequence with unsupported traction leads to catastrophic hemorrhage and structural collapse. Architectural anomalies create specific risk. In placenta succenturiata, localized deficiency causes an isolated accessory lobe to form away from the primary disc. Delivery of the main placenta can shear the connecting vessels, leaving the accessory lobe retained and causing severe hemorrhage. In placenta bilobata, a symmetric failure of disc formation results in two roughly equal lobes connected by a tissue bridge. Placenta membranacea is a rare failure of villi atrophy, causing the placenta to envelop the entire uterine cavity. This necessitates a C-section and carries a high risk of hysterectomy. In extrachorial placentas, the chorionic plate is smaller than the basal plate, forcing the membranes to fold back inward and create a thick ring at the placental edge.
These anomalies in shape create geometric hazards by either leaving tissue stranded or exposing unprotected vessels. Controlled invasion relies on Kneidebusch's layer, a biological stop signal within the decidua that prevents trophoblast cells from invading the uterine muscle. Surgical scars lack a normal decidua layer, meaning Kneidebusch's layer never forms at the scar site. This lack of a stop signal results in the accreta spectrum. Accreta attaches to the myometrium, increta invades the muscle, and percreta penetrates through the serosa to surrounding organs. The risk of accreta compounds exponentially when placenta previa occurs over previous C-section scars. After 4 or more surgeries, the risk of morbid adherence exceeds 67%. Placenta previa, implantation in the lower uterine segment, presents as painless bleeding because mechanical stretching of the tissue tears the placental sinuses. This differs from placental abruption, where the formation of a retroplacental hematoma causes uterine irritation and painful bleeding. Diagnosing previa with transvaginal ultrasound is effective because the probe angle avoids direct pressure on the vulnerable placental mass. These abnormalities in depth and location bypass the natural clearances and barriers necessary for a safe delivery. Central cord insertion ensures that mechanical forces are distributed evenly and that vessels remain protected by thick tissue. In a battledore placenta, the cord attaches at the very margin of the disc, though the vessels remain somewhat protected by Wharton's jelly until they reach the chorionic plate. Velamentous insertion is more extreme. The cord attaches to the membranes, forcing fetal vessels to travel completely unprotected to reach the placenta. Vasa previa occurs when these exposed vessels run directly over or within 2 centimeters of the internal cervical os. During labor, under the intense physical pressure of a membrane rupture, these unprotected fetal vessels can immediately snap. This rapid fetal exsanguination produces a sinusoidal pattern on the fetal monitor, indicating immediate profound hypovolemia. Exposed vessels over the cervical opening turn a routine rupture of membranes into a fatal event for the fetus. When painless bleeding occurs at term, the physician must quickly distinguish between maternal blood from a previa and fetal blood from a vasa previa. The APT test provides this distinction by testing the blood sample's resistance to a highly alkaline solution. Maternal hemoglobin A contains beta chains, while fetal hemoglobin F uses gamma chains, optimized for intrauterine oxygen transport. When introduced, an alkaline solution rapidly destabilizes the maternal hemoglobin structure, causing it to quickly denature and turn muddy brown. The structural variance of the fetal gamma chain resists this denaturation, allowing the sample to remain pink and confirming the presence of fetal blood. From the macroscopic shearing of the uterine wall to the microscopic resistance of hemoglobin chains, these clinical complications follow a consistent anatomical logic.
In a normal delivery, the placenta shears away from the uterine wall along a precise, microscopic cleavage plane. It leaves the underlying muscle intact, allowing the uterus to contract and naturally seal off its blood vessels. But in placenta accreta spectrum, or PAS, attempting to force a separation yields a catastrophic result. The tissue does not shear. Instead, the uterine muscle tears, exposing the major arterial network of the pelvis and immediately flooding the surgical field with pulsatile hemorrhage. This hemorrhage happens because the physiological cleavage plane between the placenta and the uterus does not exist. The trophoblast in these cases is behaving normally. It is following its inherent biological program to invade. However, it is operating in a uterine environment that has lost its ability to signal a stop. The complications of the delivery, the vascular signatures on imaging, and the specific surgical maneuvers required to survive them all trace back to the iatrogenic loss of a microscopic regenerative layer. To understand the defect, we first have to map the healthy uterine wall. It consists of 3 primary layers. The innermost lining is the endometrium, followed by the thick muscular wall called the myometrium, and finally a thin outer boundary known as the serosa. The endometrium itself is divided into 2 highly specialized sublayers. The stratum functionalis is the temporary tissue that sheds with menstruation. Beneath it lies the stratum basalis, a deep, permanent layer that regenerates the functionalis every cycle. When pregnancy occurs, progesterone triggers a structural transformation in the stratum functionalis. It thickens, its cells enlarge, and it becomes the decidua. The decidua prepares a controlled landing zone for the embryo. It acts as an active molecular gatekeeper,
secreting chemical signals that tell the incoming placental trophoblast how far it is allowed to invade before halting. Where the invading trophoblast meets this healthy decidua, a physical barrier forms. This is Niederbuck's layer, a dense, microscopic deposit of fibrin and extracellular matrix that acts as a physical fence. A healthy stratum basalis is the absolute prerequisite for this entire system. It builds the decidua, which triggers Niederbuck's layer, creating the microscopic scar line required for a clean, avascular placental delivery. Surgical instruments that breach the uterine wall, whether through a cesarean section, a deep curettage, a myomectomy, or an endometrial ablation, can destroy the stratum basalis. The body repairs this surgical damage by laying down fibromuscular scar tissue. This collagen patch lacks the cellular architecture found in normal endometrium and is biologically incapable of decidualization. If a new blastocyst implants directly over this surgical scar, it encounters fibrous tissue rather than a healthy decidua basalis. Without the decidua to secrete molecular braking signals, Niederbuck's layer never forms, and the physical fence is absent. The placental trophoblast continues its programmed invasion, boring into the uterine wall because the environment lacks its natural restraint system. This process is particularly dangerous in the lower uterine segment. This area is anatomically thinner. It is the primary site for cesarean scars, and it sits directly against the maternal bladder. The combination of a prior C-section and a placenta previa creates a high-risk synergy. The previa acts as a delivery mechanism, positioning the new placenta directly over the compromised scummer of the lower segment. The depth of invasion in placenta accreta spectrum is a continuous variable, determined by the size of the initial scar and the thickness of the remaining myometrium. In accreta, placental villi attach directly to the surface of the myometrium. The cleavage plane is gone, but the deep muscle fibers remain largely intact. In increta, the villi grow between the smooth muscle fibers, embedding into the network of uterine, arcuate, and radial arteries running through the muscle wall. In percreta, or FIGO grade 3A, the villi traverse the entire thickness of the myometrium and breach the outer serosa. If surgical adhesions eliminate the space between the uterus and the bladder, the placenta can invade directly into the bladder trigon. This is grade 3B percreta, which presents with hematuria and risks severe ureteric injury. These deeper invasions entangle the placenta with the massive arterial network of the pelvis. Any manual extraction attempt will cause catastrophic hemorrhage from multiple arterial branches simultaneously. Diagnosing this architecture before delivery is essential for patient survival. Maternal serum markers like AFP and HCG may elevate as disrupted architecture leaks proteins and deeper invasion increases syncytio-trophoblast contact, but they lack diagnostic specificity. Ultrasound is the primary diagnostic tool, allowing clinicians to identify the missing decidua and resulting chaotic vascularity through 5 distinct signs. Sign 1, placental lacunae. Color Doppler reveals chaotic, moth-eaten pools of turbulent blood within the placental mass, representing destruction of the normal spiral artery interface. Sign 2, thinning retroplacental myometrium. Measuring less than 1 millimeter of muscle behind the placenta indicates the trophoblast is nearing the serosa. Sign 3, bridging vessels. Color Doppler shows new blood vessels running perpendicularly across the uterine serosa toward the bladder, an indicator of advanced 3B percreta. Sign 4, disrupted echogenic line. The sharp acoustic boundary between the bladder and the uterus becomes broken and bulging as tissue forces through the interface. Sign 5, loss of the retroplacental hypoechoic zone. The dark acoustic band that normally sits behind the placenta disappears entirely. The disappearance of this dark band is the visual confirmation that the decidua basalis is missing. The absence of a cleavage plane dictates the surgical protocol. Delivery is planned between 34 and 35 weeks to balance the risk of neonatal prematurity against the risk of spontaneous labor, which would force an uncontrolled emergency extraction. The surgeon must use a classical, vertical incision high in the upper uterine segment, bypassing the standard lower transverse cut. A lower incision would slice directly through the abnormally vascularized placental bed, causing torrential hemorrhage before the baby is delivered. After delivering the baby, the surgeon closes the uterus and leaves the placenta untouched inside. The uterus acts as a sealed container for the pathological tissue during the subsequent hysterectomy. By ligating the main uterine arteries first, the team controls the primary blood supply to the organ before disturbing the dangerous placental bed. This procedure requires general anesthesia to allow for hemodynamic control during massive transfusion and to accommodate surgical extensions if urological or oncological dissection is needed. Adjuvant tools often fail to prevent complications. Illuminated ureteric catheters do not reduce injury rates because invasion obliterates the normal tissue planes, making the anatomy hazardous even when the ureters are identified. Preoperative balloon occlusion of the internal iliac arteries is also frequently ineffective. The pelvic circulation is highly collateralized. If the iliacs are blocked, arterial blood immediately bypasses the occlusion through the ovarian, inferior epigastric, and obturator arteries. Successful management depends on identifying the absent cleavage plane and controlling the blood supply before the pathological tissue is ever disturbed. Conservative management for fertility preservation involves ligating the umbilical cord at the placental insertion point, closing the hysterotomy, and applying mechanical compression packing. Tying off the cord cuts the fetal blood supply, turning the placenta into devascularized necrotic tissue. Monitoring this tissue requires serial imaging. Beta-HCG levels are ineffective here because they measure proliferating trophoblast. The levels will fall as the tissue dies, but this provides no information regarding the risk of hemorrhage or infection. Methotrexate is contraindicated in PAS because it targets rapidly dividing cells. Because the placenta in conservative management is devascularized and necrotic, methotrexate provides no benefit. It only risks bone marrow suppression in a patient who already faces a significant risk of intrauterine infection. Conservative management carries a 20% failure rate. Delayed hemorrhage or sepsis frequently force surgical intervention, making this a temporary delay of an inevitable hysterectomy. The arc of this obstetric hemorrhage is a logical progression. The emergency hysterectomy is necessary because the cleavage plane is gone. The cleavage plane is absent because Nitabux's layer never formed, and Nitabux's layer failed to form because a previous surgery destroyed a microscopic layer of basalis cells. PAS follows the mechanical logic of iatrogenic endometrial destruction. Every diagnostic sign and every surgical maneuver traces back to the absence of that single regenerative layer. Managing placenta accreta spectrum requires recognizing that the safety of the delivery depends entirely on the structural integrity of this microscopic boundary.
Observe this single fertilized cell. In approximately 1 out of every 250 human pregnancies, regardless of maternal age or geography, this zygote undergoes a spontaneous, stochastic error in early development. It cleaves into 2 distinct, genetically identical embryos. The consequences of that split are best understood by looking at the baseline sequence of a normal singleton conception. A single oocyte is fertilized by a single sperm, forming a zygote. That zygote divides and compacts into a morula, and eventually implants in the uterine wall as a blastocyst. At the blastocyst stage, the cells separate into 2 distinct compartments. The outer layer becomes the trophoblast, which will eventually form the chorion and the placenta. The inner cell mass becomes the embryo itself, enclosed by a membrane called the amnion. Dizygotic or fraternal twins follow a different biological pathway. 2 separate oocytes are released and fertilized by 2 separate sperm. They are genetically distinct individuals sharing a uterus, each implanting separately to develop their own placenta and their own membranes. Every clinical pathology in a twin pregnancy, from hemodynamic collapse to specific delivery protocols, is a deterministic consequence of the precise timeline of early embryological cleavage. Dizygotic twinning is driven by maternal levels of follicle-stimulating hormone, or FSH. Women with naturally higher FSH levels, or those who are genetically predisposed to high FSH sensitivity, recruit more follicles per cycle, increasing the probability of hyperovulation. This hormonal variance creates predictable demographic differences. West African populations, such as the Yoruba in Nigeria, have genetically higher baseline FSH secretion, resulting in a twin rate of roughly 1 in 20 pregnancies. In contrast, East Asian populations exhibit much lower rates, closer to 1 in 400. This animated diagram outlines Helen's rule. If the baseline chance of dizygotic twins is 1 in 80,
The probability squares for triplets at 1 in 6,400 and cubes for quadruplets, reaching 1 in 512,000. Because sperm can survive in the female reproductive tract for up to 5 days, heteropaternal superfecundation can occur. If a woman releases 2 eggs days apart within the same hyperovulatory cycle, they can be fertilized by sperm from 2 separate acts of coitus. Superfetation, where a second egg is fertilized in a different menstrual cycle, is restricted by 3 physiological barriers. Rising progesterone suppresses ovulation, and cervical mucus becomes impenetrable to sperm. And by 16 weeks, the expanding chorion obliterates the uterine cavity, leaving no space for a new implantation. While dizygotic gestations are the predictable output of maternal genetics, monozygotic twinning is a random embryological error occurring at a fixed global rate. Chorion commits by day 8, amnion by day 10. Splits before day 4 yield DCDA twins. Days 4 to 8 create MCDA twins. Days 8 to 13 form MCMA twins. Post-day 13 splits fail, yielding conjoined twins. We identify these structures using first trimester ultrasound. In a DCDA pregnancy, independent chorionic villi grow into the base of the intertwin membrane, creating a triangular projection of tissue known as the lambda sign. Contrast this with an MCDA pregnancy, which has only one chorion. With no space for villus invasion, the dividing membrane meets the shared placenta at a strict 90-degree angle, creating the T sign. Identifying these architectural barriers on a 10 to 14-week ultrasound is the critical diagnostic step. It dictates the hemodynamic risk profile and the monitoring protocol for the rest of the pregnancy. A shared chorion mandates vascular anastomoses. Superficial connections equalize pressure, but deep artery-to-vein anastomoses permit unidirectional flow. Chronic shunting here causes twin-to-twin transfusion syndrome, as one twin pumps blood directly into the other's circulation. The donor twin suffers immediate hypovolemia. To compensate, its kidneys activate the renin-angiotensin-aldosterone system. Renal perfusion drops, leading to severe oliguria. Without urine to replenish the amniotic fluid, the sac collapses, creating the stuck twin presentation. To maintain cerebral oxygen delivery despite profound anemia, the donor's brain initiates an autoregulatory response. It dilates cerebral vessels to increase flow velocity, registering on ultrasound as an elevated middle cerebral artery peak systolic velocity. The recipient twin faces a volume crisis. Massive hypervolemia forces its kidneys into polyuria, causing polyhydramnios. Simultaneously, the influx of red blood cells drives its hematocrit to dangerous levels, creating severe polycythemia. This viscous blood flows slowly through the recipient's brain, resulting in a low MCA velocity. Overwhelmed by fluid, the recipient's heart dilates. This high venous pressure eventually forces blood backward into the ductus venosus, leading to cardiac failure and hydrops fetalis. Clinicians track this deterioration using Quintero staging. The scale moves from stage 1 fluid imbalance to stage 3 hemodynamic abnormalities, eventually reaching stage 5, the demise of one or both twins. Before 26 weeks, fetoscopic laser ablation is the definitive intervention. A laser coagulates surface anastomoses, converting the placenta into independent functional units. TTTS is a mechanical volume crisis driven by the specific physics of shared placental plumbing. When AV anastomoses are microscopically small, blood transfers too slowly to trigger acute fluid imbalances. This results in twin anemia polycythemia sequence, or TAPS. In TAPS, the kidneys of both twins can compensate for the slow transfer, keeping amniotic fluid levels normal. However, a severe hemoglobin discordance silently accumulates over time. Because fluid volumes remain balanced, TAPS is identified by mapping velocity extremes in the middle cerebral artery. The donor shows fast-flowing blood, while the recipient shows slow, viscous flow. TRAP sequence stems from superficial artery-to-artery anastomoses. The viable pump twin forces deoxygenated blood retrograde into the acardiac twin. Losing pressure upwards, the acardiac twin develops only lower limbs, while the overloaded pump twin faces fatal cardiac failure. The physical geometry of the anastomosis, whether deep, superficial, large, or microscopic, dictates the resulting clinical syndrome. If the initial cleavage of the inner cell mass divides the placental territory unequally, one twin receives a smaller nutrient supply. This causes selective intrauterine growth restriction, marked by weight discordance between the fetuses. Without a dividing membrane, progressive umbilical cord entanglement in MCMA pregnancies is inevitable. Constant fetal movement creates an ever-present risk of acute vascular compression. If one twin dies in a monochorionic pregnancy, the survivor faces an immediate crisis. The dead twin loses all vascular resistance, and blood from the living twin rapidly hemorrhages across the open anastomoses into the dead twin's body, triggering severe watershed brain injury in the survivor. The immense placental mass required for twins also strains maternal health. Extra trophoblastic tissue releases excess anti-angiogenic factors, increasing the risk and severity of preeclampsia. Early low-dose aspirin is used to support the remodeling process. It inhibits the synthesis of proconstrictive platelet thromboxane A2, while preserving vasodilatory prostacyclin in the endothelium, supporting vital placental blood flow. The physical volume of the pregnancy also initiates premature mechanical signals. Chronic uterine overdistension triggers prostaglandin cascades that cause preterm labor, while exhausted muscle often fails to contract after delivery, resulting in postpartum hemorrhage. The physical mass and chemical output of a coupled gestational system place predictable mechanical and immunological strains on maternal physiology. Clinical management maps to zygosity. For aneuploidy testing, monozygotic gestations require sampling only one amniotic sac, while dizygotic gestations mandate sampling both to prevent false negatives. Vanishing twin syndrome is a common consequence of IVF superovulation. One twin undergoes early demise and is reabsorbed, often leaving the survivor with lower birth weights due to early competition for resources. During delivery, if the first twin delivers vaginally but the second is in a transverse lie, a standard vaginal extraction is impossible. This cross-section demonstrates an internal podolic version. A clinician reaches through the cervix to grasp the fetal feet and turn the baby for a breech extraction. This maneuver requires general anesthesia to achieve the profound uterine relaxation necessary to turn the fetus safely. If the first twin is breech and the second is cephalic, their chins can lock at the pelvic inlet. This creates a mechanical jam that cannot be resolved vaginally, mandating a cesarean section. Once the first twin is delivered, the 30-minute rule dictates the safe window for extracting the second twin before changing uterine conditions escalate the risk of cord prolapse or placental abruption. Zygosity dictates genetic identity, cleavage timing defines placental architecture, vascular structures dictate systemic pathology. In the management of twin pregnancy, the architectural blueprint established in the first 2 weeks of life dictates the clinical outcome. Throughout normal pregnancy, the uterus persists in an actively maintained state of suppression. It is a metabolic, energy-intensive process designed to keep the smooth muscle tissue from contracting. Progesterone drives suppression by acting on PRB receptors, keeping smooth muscle relaxed and inhibiting prostaglandin synthesis. It specifically blocks gap junction formation. Without these channels, muscle may twitch, but cannot produce the organized wave of contraction necessary for labor. At full term, a functional progesterone withdrawal occurs. The receptor subtype ratio shifts as PRA begins to dominate over PRB. Removing this progesterone brake allows gap junctions to form rapidly, linking individual muscle cells into a single synchronized unit. This shift initiates a coordinated inflammatory cascade. Rising estrogen levels upregulate oxytocin receptors, while prostaglandins begin the enzymatic breakdown of cervical collagen. Preterm labor is the activation of this exact inflammatory cascade before 37 completed weeks of gestation. Clinicians distinguish true preterm labor from benign Braxton-Hicks contractions based on the state of the cervix. Braxton-Hicks are uncoordinated muscle twitches. True labor requires the full cascade, resulting in frequent contractions and structural cervical change, softening, shortening, and dilating. True preterm labor represents an irreversible shift in uterine physiology. Because the biochemical cascade is self-sustaining, the clinician's focus must move from maintaining the pregnancy to managing an imminent delivery. 5 distinct mechanisms can breach uterine quiescence, all converging into a central inflammatory pathway. Mechanism 1 is uterine overdistension. Mechanoreceptors trigger intracellular signaling when stretched past a physical threshold, signaling immediate upregulation of oxytocin receptors and prostaglandin synthesis. The uterine wall responds to volume regardless of the source. This pathway is triggered identically by twin pregnancies or by excess amniotic fluid, known as polyhydramnios. Mechanism 2 is infection. Bacteria carry pathogen-associated molecular patterns, or PAMPs, which bind to toll-like receptors on the decidua, activating the NF-kappa B pathway to release inflammatory cytokines. In conditions like bacterial vaginosis, the loss of protective acid-producing flora allows anaerobic bacteria to thrive. These pathogens produce enzymes that degrade the cervical mucus plug, removing the physical barrier against ascending infection. Mechanism 3 is placental pathology, like abruption. When the placenta separates from the uterine wall, that segment undergoes sudden decompression and responds with reflex contractions. The resulting retroplacental hematoma releases massive amounts of thrombin, acting as a direct stimulant for myometrial smooth muscle contraction. Mechanism 4 is stress. Elevated fetal cortisol from placental insufficiency stimulates the placenta to produce corticotropin-releasing hormone, accelerating prostaglandin synthesis. This stress pathway serves as a biological survival signal, indicating that the intrauterine environment is more dangerous than early birth. Mechanism 5 is structural cervical incompetence. Due to collagen weakness, the cervix dilates passively and painlessly under the pregnancy's weight. Once open, membranes prolapse and rupture, secondarily triggering the prostaglandin cascade. Whether the trigger is mechanical stretch, bacterial infection, thrombin release, fetal stress, or structural failure, the resulting biochemical emergency is identical. The diagnostic challenge lies in identifying which pregnancies are moving toward this cascade before the patient feels a single contraction. Clinicians look for fetal fibronectin, a glycoprotein that acts as biological adhesive. It glues the fetal membranes to the uterine decidua. Between 24 and 35 weeks, its presence in cervicovaginal secretions indicates this glue is being disrupted. Fetal fibronectin has an exceptional negative predictive value. A negative test means delivery within 2 weeks is highly unlikely. Transvaginal ultrasound tracks cervical effacement with millimeter precision as the internal os moves downward. However, a full bladder exerts pressure against the lower uterine segment, pushing the anterior wall upward and artificially elongating the apparent cervical length. When diagnostics identify a high-risk patient, exogenous progesterone supplementation is used to reinforce the suppressive threshold. It prevents the early shift toward PRA dominance. For structural failures, clinicians use a cervical cerclage, a purse-string suture placed at the internal os. This is reserved for patients with a history of prior preterm labor, a currently short cervix, and a singleton pregnancy. These preventative tools serve to fortify existing barriers during the quiet period. Once the inflammatory cascade is fully active, they lose utility. When a patient presents with regular contractions and cervical change, the clinical protocol shifts to active management. The first examination must be a speculum exam. Digital vaginal exams are prohibited until ruptured membranes are ruled out, as introducing fingers can push vaginal flora past a rupture site and initiate ascending infection. At 34 weeks of gestation, fetal organ maturity is sufficient that the benefits of intervening are outweighed by the risks. Labor proceeds. Before 34 weeks, tocolytics buy 48 hours by blocking contraction pathways, though the inflammatory cascade continues. Nifedipine blocks calcium channels, and atosiban blocks oxytocin receptors. Indomethacin halts prostaglandins, but is restricted to under 32 weeks to prevent premature closure of the fetal ductus arteriosus. Beta agonists like terbutaline inactivate the myosin light chain kinase to force muscle relaxation. Their use is limited by severe maternal side effects, including tachycardia and pulmonary edema caused by beta receptor stimulation. Magnesium sulfate is not a tocolytic. The dose required to reliably stop uterine contractions is nearly identical to the dose causing maternal respiratory arrest, making it unacceptably dangerous. Tocolytics offer no long-term survival benefit for the pregnancy. They exist solely to buy 48 hours for the administration of fetal therapeutics. Within that 48-hour window, clinicians deploy interventions to prepare the fetal organs for premature exposure to the environment. Without surfactant, fetal alveoli collapse completely at the end of each breath. Reinflating them requires enormous physical effort, leading quickly to rapid respiratory exhaustion. Before 34 weeks, corticosteroids bind to type 2 pneumocytes, forcing transcription of surfactant proteins to compress weeks of lung maturation into 2 days. Before 32 weeks, magnesium sulfate stabilizes fragile vessels and blocks NMDA receptors, preventing excitotoxic cell death and cerebral palsy. Due to rapid renal clearance, magnesium requires a loading dose followed by a maintenance infusion, with constant monitoring of maternal reflexes to prevent toxicity. Antibiotics are not part of the baseline treatment for preterm labor. They are reserved for specific infectious risks, such as Group B strep prophylaxis or suspected chorioamnionitis. These therapeutics are precision tools used to force mature the specific fetal organs most likely to fail upon delivery. The complications of prematurity follow a predictable anatomical logic. Each pathology results from an organ system forced to function before its developmental timeline is complete. Respiratory distress syndrome is the direct result of immature type 2 pneumocytes. Severe intraventricular hemorrhage occurs because the fragile blood vessels of the germinal matrix have not yet involuted. Necrotizing enterocolitis results from a deficient mucosal barrier in the gut, which allows bacteria to translocate across the immature intestinal wall. Severe neonatal hypoglycemia occurs because the liver has not yet reached the 3rd trimester window for massive glycogen storage. Systemic hypothermia and overwhelming infection are the mechanical consequences of a lack of subcutaneous fat and a failure to complete the transplacental transfer of maternal antibodies. Every drug choice and clinical cutoff discussed today exists to push the fetus past these specific anatomical failure points. Preterm labor management uses maternal physiology as a conduit to reach the fetus. By using a pharmacological delay to force mature internal organs, clinicians attempt to align a baby's anatomical readiness with its sudden early birth. The amniotic sac performs several critical jobs simultaneously. It mechanically cushions the fetus from trauma, actively maintains fluid volume necessary for lung development, and serves as a permanent, sterile biological barrier against the colonized vaginal microbiome. To understand when this system fails, we establish a clinical baseline by defining normal labor. Medically, labor consists of regular uterine contractions that cause progressive cervical change. PROM, or premature rupture of membranes, occurs when the membrane ruptures explicitly before labor begins. The word premature in this diagnosis refers to the timing relative to contractions, regardless of gestational age. This timeline plots maturity versus infection. At term PROM, over 37 weeks, infection dictates immediate delivery. In late pre-PROM, 34 to 37 weeks, delivery is favored. For pre-PROM, 24 to 34 weeks, daily maturation is critical. Before 24 weeks, pre-viable P-proprum carries overwhelming non-viability. These definitions reflect rigid biological thresholds, where crossing from one category to the next forces an absolute shift in clinical management. Intact membranes execute 3 mandatory functions: providing mechanical protection, maintaining the fluid volume required for alveolar stretch, and walling off the sterile intrauterine cavity from vaginal bacteria. The structural integrity of this barrier is absolute. Once the collagen matrix fails, there is no biological mechanism for healing or resealing. Ascending bacteria from the vaginal microbiome produce enzymes that digest the amniotic sac's structural matrix from below. Physical forces also destroy the matrix. Extreme outward pressure from polyhydramnios or multiple gestations creates excess tension, causing microtears and eventual rupture. A mechanically incompetent or short cervix compounds this process. It prematurely exposes the lower segment of the membranes to vaginal enzymes and inflammation for prolonged periods. Systemic factors further weaken this structural integrity. Previous cases of PPROM indicate constitutional differences in how a patient synthesizes collagen, while maternal smoking actively impairs collagen production and immune response. The loss of amniotic fluid marks the structural failure of the fetus's primary defense, immediately exposing it to ascending infection and mechanical compression. The immediate threat is ascending infection. Vaginal bacteria migrate upward through the newly opened cervix, initiating a polymicrobial infection of the membranes and fluid known as chorioamnionitis. This infection follows a predictable mechanical timeline. The resulting inflammation triggers the release of prostaglandins, which induce uterine contractions. This cascade typically leads to labor within 1 week of rupture. Parallel to the infection is the physical loss of fluid, or oligohydramnios. Removing the mechanical cushion allows the fetus to compress the umbilical cord during normal movement, resulting in variable decelerations. If the presenting part is high, the cord can physically prolapse through the open cervix. Oligohydramnios also halts lung maturation. The fetus must breathe amniotic fluid in utero to physically stretch the developing alveoli. Without fluid, pulmonary hypoplasia occurs, a condition that is nearly always fatal if the rupture happens before 24 weeks. If the infant is born prematurely, they face respiratory distress syndrome. Before roughly 34 weeks, the type 2 pneumocytes do not produce enough surfactant, causing the infant's alveoli to collapse entirely upon exhalation. Extreme prematurity also exposes the developing brain. The highly vascular germinal matrix in a preterm brain lacks autoregulation and features extremely fragile vessels, leading directly to intraventricular hemorrhage. Gut ischemia and bacterial invasion cause necrotizing enterocolitis in the immature intestinal tract, while the high concentration of inflammatory cytokines from the early birth process damages developing white matter, leading to cerebral palsy. Even the mother's anatomy is at risk. The sudden decompression of the uterus following massive fluid loss causes the uterine wall to contract down forcefully, creating shearing forces that can physically tear the placenta from the uterine lining. Without the amniotic barrier, clinical management must simultaneously address the rising risk of sepsis, fetal asphyxia, and the systemic complications of prematurity. Confirming a rupture requires a strict procedural rule. A sterile speculum examination is mandatory. Inserting a digit pushes vaginal flora directly toward the open, sterile cavity. Using the speculum, the clinician looks for a single, highly reliable physical sign: amniotic fluid physically pooling in the posterior fornix by gravity. Normal vaginal flora keeps pH at 4.5. Amniotic fluid is alkaline, between 7.0 and 7.8, turning nitrazine paper blue. However, false positives occur. Blood, semen, trichomonas, and bacterial vaginosis also sit on the alkaline side and will turn the indicator blue. The Ferning test verifies the fluid's physical properties. When dried on a slide, the specific proteins and salts unique to amniotic fluid crystallize into a distinct, frost-like dendritic pattern. Normal vaginal discharge lacks this composition and will not fern. When visual and pH tests are equivocal, such as when blood is present, clinicians rely on highly specific biochemical tests like Amnisure to detect PAMG1 or Actim-Prom to detect IGFBP1. These tests are decisive because they detect specific biological molecules concentrated 100 to 1,000 times higher in amniotic fluid than in vaginal secretions. Ultrasound plays a secondary role here. It can confirm the consequence of a rupture by showing low fluid levels, but it cannot diagnose the actual rupture itself. Accurate diagnosis of prematurity relies entirely on exploiting the stark chemical, structural, and biological differences between the fetal and vaginal environments. Pharmacological interventions do not cure the rupture. They exist strictly to buy a finite 48-hour window to artificially accelerate the neuropulmonary maturation of the fetus. Corticosteroids, specifically betamethasone, execute this acceleration. They push type 2 pneumocytes to mature early and produce surfactant, while simultaneously reducing capillary permeability in the preterm brain. These steroids are administered to patients strictly under 34 weeks. Hydrocortisone and prednisolone are intentionally avoided because the placental 11-beta-HSD enzyme chemically inactivates them before they reach the fetus. Tocolytics pause contractions to buy that 48-hour steroid window. They are completely contraindicated in cases of chorioamnionitis, fetal distress, or after 34 weeks. Note that prophylactic progesterone maintains uterine quiescence before labor, but it is not a tocolytic and cannot stop active contractions. This cellular model shows how tocolytics act on myometrial cells. Nifedipine blocks the calcium influx required for contraction. Adasobin acts as an oxytocin antagonist, preferred for maternal heart disease. Indomethacin blocks the COX pathway to halt prostaglandins, but is limited to use before 32 weeks. For neuroprotection under 32 weeks, clinicians administer an IV loading dose of magnesium sulfate. It blocks NMDA receptors in the preterm brain, reducing excitotoxic glutamate damage and significantly lowering the risk of cerebral palsy. These pharmacological tools are highly targeted biological overrides. They're deployed solely to rapidly prepare an extremely premature fetus for the environment outside the womb. Because early-onset neonatal sepsis is rapidly fatal to a premature immune system, clinicians screen for Group B Streptococcus colonization between 35 and 37 weeks. Screening at this specific window accurately reflects the bacterial status likely present at term delivery. Intrapartum penicillin G is administered during delivery if the mother is a known GBS positive, has had a previous GBS-affected infant, shows GBS bacteriuria, or has an unknown status combined with prolonged membrane rupture over 18 hours. This clinical checklist outlines the immediate diagnostic criteria for chorioamnionitis. The diagnosis is entirely clinical, requiring a maternal fever of at least 39 degrees Celsius, plus either fetal tachycardia, elevated maternal white blood cells, or purulent cervical discharge. Clinicians never wait 48 hours for a culture because fetal sepsis evolves too rapidly. Once diagnosed, an infected intrauterine environment mandates immediate delivery via the vaginal route. Cesarean sections are avoided unless absolutely necessary, as operating in an infected field increases the risk of wound abscess and systemic sepsis. The patient receives ampicillin and gentamicin to cover both GBS and gram-negative bacteria. However, antibiotics alone cannot sterilize a polymicrobial infection inside a necrotic amniotic cavity. In the presence of chorioamnionitis, all temporizing measures cease. The infected uterus transitions into a source control problem that requires immediate physical evacuation. This flowchart distills PPROM management to one question: inside or outside? For early preterm without infection, staying inside is safer. Clinicians use steroids, tocolytics, and magnesium sulfate to buy time. But with chorioamnionitis, or beyond 34 weeks, infection risk mandates immediate delivery. Every physical diagnostic test confirms exactly where a patient sits within this matrix, and every pharmacological agent, from tocolytics to corticosteroids, serves strictly to manipulate the timing of this singular vital risk-benefit calculation. Human gestation operates on a relentless biological timeline, moving rapidly through cell division and fetal development toward an inevitable endpoint. In clinical practice, normal pregnancy duration is calculated as 280 days from the last menstrual period, or exactly 40 weeks based on Naegele's rule. A pregnancy crosses into the categorical definition of postterm when it continues beyond 42 weeks, or 294 days. This graph shows exactly why that cutoff exists. It is not an arbitrary label. Through weeks 40 and 41, the morbidity timeline remains relatively flat. But as gestation crosses the 42-week line, the rate of severe complications, like placental insufficiency and stillbirth, sharply escalates. Because the morbidity curve is so steep, clinical management requires an absolute certainty of the starting point. Reviewing the menstrual history is the foundational step. To confirm that starting line, an early first trimester ultrasound is the gold standard, because early embryonic growth is highly uniform across all individuals. By the third trimester, fetal growth diverges drastically based on genetics, nutrition, and underlying pathology. That divergence makes late pregnancy ultrasound mathematically unreliable for establishing a date. If gestational age is miscalculated, a term pregnancy is mislabeled as postterm, or vice versa. Everything downstream, from the timing of a medical induction to the intensity of fetal surveillance, fails if this single number is wrong. The onset of normal labor is driven by a cooperative steroidogenic cascade between the fetus and the placenta. Look at this biochemical flowchart. The placenta possesses the enzyme aromatase, but it entirely lacks 17-alpha-hydroxylase. Progesterone attempts to convert into C19 androgens, but hits a structural wall. Because of this enzymatic blind spot, the placenta cannot synthesize estrogen on its own. It requires an external precursor source. The fetal adrenal cortex, specifically its transient fetal zone, provides the missing enzymes. The fetal adrenal gland absorbs maternal cholesterol, converting it into the C19 precursor, DHEA. DHEA is active. To protect fetal tissues during transport, a sulfate group is added, locking the molecule into an inert, water-soluble form called DHEAS. DHEAS travels back into the placenta. Here, placental sulfatase strips away the sulfate group, regenerating active DHEA. Placental aromatase then takes over, converting these androgens into estrogens, specifically E1, E2, and the dominant hormone of pregnancy, estriol, or E3. This rising estrogen pool acts as the biological trigger. It upregulates oxytocin receptors and forms connexin 43 gap junctions within the myometrium, priming the tissue for synchronized electrical pacing. Labor only initiates when this specific fetal adrenal to placental cascade successfully primes the myometrium for a coordinated mechanical contraction. This completed pathway explains every primary etiology of a post-term pregnancy. If a gestation passes 42 weeks, there is a physical or enzymatic break somewhere along this chain. In anencephaly, lacking a pituitary axis, the fetal adrenal zone atrophies, cutting off precursor supply at the source. Fetal demise behaves the same mechanically. A deceased fetus ceases all adrenal steroidogenesis, and the cascade halts. In X-linked placental sulfatase deficiency, the fetal adrenal gland functions perfectly. DHEAS is delivered to the placenta, but the missing enzyme stalls the conversion. The precursor simply pools. If the enzymatic failure occurs one step further down at aromatase, estrogen production fails, and unaromatized androgens build up. They spill backward into the maternal circulation, driving maternal virilization. In fetuses with trisomy 21, or Down syndrome, the fetal adrenal gland globally reduces its output of C19 precursors, severely starving the cascade of raw material. Without sufficient precursor reaching the placenta, or without the specific enzymes to convert it, the trigger to deliver never fires. When that trigger fails, the internal environment becomes increasingly hostile. The core pathology of a post-term pregnancy is a physical and biological mismatch. The fetus maintains its trajectory of growth, while the placenta passes its biological expiration date. As gestation drags on, placental villi suffer severe fibrin deposition, calcification, and focal infarction. This gradual loss of exchange surface area drives uteroplacental insufficiency. This chart displays the diagnostic signature of an aging placenta, late decelerations. As a contraction peaks, oxygen delivery transiently drops. Because the fetus is already surviving on a compromised oxygen supply, a chemoreceptor response triggers a heart rate drop that noticeably lags behind the contraction. Simultaneously, the failing placenta reduces fetal renal perfusion. The fetus redistributes blood flow to prioritize the brain, further decreasing urine output. The result is oligohydramnios, with amniotic fluid plummeting to as little as 200 milliliters. This drastic loss of fluid removes the mechanical cushioning around the umbilical cord, leaving it highly vulnerable to compression during fetal movement or uterine contractions. The CTG trace for mechanical cord compression looks entirely different. It produces variable decelerations, sharp V-shaped drops in the fetal heart rate that hit abruptly and do not align consistently with the contraction rhythm. Under chronic hypoxic stress, a vagal response relaxes the fetal anal sphincter. The fetus passes meconium directly into this severely reduced fluid volume, turning it into a thick, concentrated sludge. If the fetus gasps in utero due to that ongoing hypoxia, it pulls this concentrated meconium deep into the airway, causing severe chemical pneumonitis and surfactant inactivation. Evaluating a post-term CTG requires identifying the specific mechanical failure in the environment. Late decelerations signal a failing placenta, while variable decelerations point to a shrinking fluid volume. The other half of the post-term mismatch is unchecked growth. In the Indian clinical context, a fetal weight of 4.0 kilograms or greater meets the diagnostic criteria for macrosomia. Post-term macrosomia happens simply because the fetus has more time to grow. This is pathophysiologically distinct from maternal diabetes, where maternal hyperglycemia crosses the placenta and triggers excess fetal insulin, which acts as a potent growth factor. Look at these comparative thresholds for a planned cesarean. Fetal hyperinsulinemia in a diabetic pregnancy specifically drives disproportionate fat deposition across the trunk and shoulders. Due to this altered geometry, the cesarean threshold is lowered to 4.5 kilograms, whereas non-diabetic fetuses grow more proportionally and tolerate a threshold of 5 kilograms. The disproportionate truncal mass dramatically increases the risk of shoulder dystocia. Successfully delivering the fetal head does not guarantee the wider torso can clear the maternal pelvis. The massive physical force required to birth a macrosomic fetus applies extreme mechanical stress to the uterine walls. Therefore, macrosomia serves as a strict relative contraindication for attempting a vaginal birth after cesarean, as it directly threatens uterine rupture along the old scar line. Accurately calculating fetal weight determines the mode of delivery. Ultrasound is the gold standard method, relying predominantly on the abdominal circumference measurement because it accurately captures soft tissue and fat deposition. When ultrasound is unavailable, clinicians calculate weight using Johnson's formula. This equation uses the fundal height measurement minus a variable denoted as x to correct for how deep the fetal head has descended into the maternal pelvis. If the head sits high and unengaged, x equals 13. But once the head descends below the ischial spines, part of the fetal length moves below the measurement reference point. The x variable drops to 11, correcting the math so the total weight isn't artificially underestimated. Managing a post-term pregnancy ultimately requires recognizing a broken biological trigger and calculating the exact moment when the mechanical demands of a massive fetus exceed the physiological limits of an expiring placenta.
During vaginal delivery, a rigid fetal head must navigate the narrow, bony dimensions of the maternal pelvis without sustaining neural damage. The fetal skull divides its architecture. The vault, 2 frontal, 2 parietal, and the squamous occipital bones, forms through intramembranous ossification directly from mesenchyme. These soft membranous plates shift to accommodate the birth canal. Conversely, the skull base undergoes endochondral ossification, becoming rigid bone. This rigid architecture protects the brainstem, the cranial nerves, and the major vessels passing through the basal foramina, structures that cannot tolerate deformation. Because the base cannot yield, basal skull fractures in obstetric trauma are far more clinically significant than the normal molding of the vault. The fetal skull isolates mechanical compliance and structural rigidity into separate zones to meet these competing functional demands. These vault bones are separated by distinct sutures. The frontal suture divides a frontal bone halves, while the coronal suture runs transversely. The lambdoid suture borders the occipital bone, and the temporal squamosal sutures define the lateral margins. The sagittal suture runs along the midline, connecting the anterior bregma to the posterior lambda. During labor, clinicians identify fetal position by palpating these suture lines through the cervix. Tracing the sagittal suture to a specific fontanelle shape diagnoses occipito-anterior versus occipital-posterior positions at the bedside. Fontanelles form wherever 3 or more suture lines converge. The anterior fontanelle, or bregma, is a diamond-shaped junction where 4 bones meet, the 2 frontal and 2 parietal plates. It remains open for roughly 18 months, allowing clinicians to assess an infant's intracranial pressure and hydration status by checking for bulging or sinking at this site. The posterior fontanelle, or lambda, is a triangular junction of 3 bones, the 2 parietal plates and the occipital bone. This smaller gap typically ossifies shut within 6 to 8 weeks of birth. The same geometric rule defines the 4 lateral fontanelles, the paired anterolateral pterion, where 4 bones meet, and the paired posterolateral asterion, formed by 3 bones. The location and shape of these soft spots are the direct result of suture convergence, providing a predictable map of the vault's structural flexibility. A vertical line through the parietal eminences divides the vertex into the posterior occiput and the anterior sinciput. Fetal attitude operates as a continuous flexion-extension dial, following a U-shaped curve of efficiency. In a well-flexed vertex presentation, the head leads with the suboccipital bregmatic diameter. As it slightly deflexes, the required clearance increases to 10 centimeters. In a neutral military attitude, the engaging occipitofrontal diameter increases to 11.5 centimeters. In a brow presentation, the head leads with the mento-vertical diameter. At 13.5 centimeters, this is the largest diameter of the fetal skull. This 13.5 centimeter dimension is why brow presentations are undeliverable vaginally at term. The head is simply too wide to pass through the pelvic cavity. If the head extends further into a face presentation, the diameter drops back to 11.5 centimeters,
and eventually reaches 9.5 centimeters at full extension. The transverse diameters remain constant, the 7 centimeter bimastoid, the 8 centimeter bitemporal, and the 9.5 centimeter biparietal diameter, the standard for fetal biometry. The U-shaped curve proves maximum flexion and maximum extension are equally efficient for delivery, while the intermediate brow position creates a mechanical blockage. Engagement occurs when the biparietal diameter, the widest transverse part of the head, successfully enters the pelvic inlet. The inlet is widest in its transverse and oblique dimensions. Its anteroposterior diameter, the conjugate vera, is its narrowest point at roughly 11 centimeters. Selheim's law of accommodation states that two ovoid objects align their longest axes to fit. The fetal head naturally enters oriented transversely or obliquely. As the head descends through the mid-pelvis, it passes between the ischial spines, narrowing to 10.5 centimeters. At the pelvic outlet, the geometry changes. The widest dimension is now the anteroposterior diameter, having shifted 90 degrees from the inlet's orientation. Internal rotation is a passive realignment. The fetal head continuously rotates to match its longest axis to whichever pelvic plane is widest as it descends. During a vertex delivery, the skull is compressed along its leading suboccipitobregmatic axis, while being squeezed laterally by the pelvis. This pressure causes the parietal bones to override the frontal and occipital plates at the coronal and lambdoid sutures. This overlap is typically asymmetrical. In most positions, the posterior parietal bone overrides the anterior one along the sagittal suture. Grade 3 molding represents a state where these bones are fixed in an overlapping position. At this point, the membranous vault has exhausted its capacity to deform. Cephalopelvic disproportion is diagnosed when this grade 3 molding is observed alongside an arrest of labor progress, indicating the head cannot physically adapt any further to the maternal pelvis. The scalp features 6 layers: skin, subcutaneous tissue, galea aponeuretica, loose areolar tissue, periosteum, and bone. Caput succedaneum is superficial subcutaneous fluid that freely crosses sutures. Conversely, cephalhematoma is subperiosteal blood, tightly bound at the margins, confined to one bone. The primary risk of a cephalhematoma is the metabolic load as blood resorbs, potentially leading to neonatal jaundice. Subgaleal hemorrhage occurs when blood enters the loose areolar plane, often from ruptured emissary veins during vacuum-assisted delivery. This is a life-threatening emergency. Because the subgaleal plane is not restricted by sutures and spans the entire scalp, it can hold an infant's entire blood volume, leading to rapid hypovolemic shock. These conditions demonstrate that in neonatal trauma, the severity of the injury is defined by the anatomical boundaries of the tissue layers.
In obstetrics, the birth canal consists of both soft tissues and bone, but while the cervix and perineum can stretch, bone is inelastic. It cannot yield to the forces of labor. This physical reality forces the fetal skull to navigate a fixed, rigid path, negotiating 3 independent spatial levels: the inlet, the cavity, and the outlet. Success at one level does not guarantee passage through the next. A fetal head might easily clear a wide inlet, only to become completely arrested lower down at a narrow mid-pelvis. This is because the pelvic axis is not a straight tube. It runs downward and then curves anteriorly. To follow this specific curve, the fetal head must execute precise movements, rotating and extending as it descends. To understand how this mechanism operates, we must map the anatomical boundaries of the true pelvis, quantify the exact dimensions that define a contraction, and differentiate a strictly structural blockage from a dynamic disproportion. Mastering this spatial geometry is the difference between facilitating a safe delivery and failing to recognize a catastrophic mechanical obstruction. The maternal skeletal structure is divided into 2 functionally distinct regions. The false pelvis lies above the brim and cradles the pregnant uterus, while the true pelvis forms the actual bony birth canal below. Separating these 2 regions is a continuous closed ring known as the pelvic brim or linea terminalis. Tracing from front to back, this boundary begins at the upper border of the pubic symphysis, moves across the pubic crest and tubercle, travels along the ascending pubic ramus, and follows the iliopectineal line.
It continues backward across the sacroiliac joint, traces the wing, or ala, of the sacrum, and closes at the posterior midline on the sacral promontory. That final structure, the sacral promontory, projects forward into the available space, creating a rigid physical obstruction at the back of the ring. Successfully passing through this fully closed bony ring is the first non-negotiable requirement for vaginal birth. This upper opening is the pelvic inlet. In the standard female pelvis, it forms a transverse oval. Its widest dimension spans from side to side, measuring exactly 13 centimeters. Because the fetal head is also an oval, it naturally aligns its longest axis with the inlet's widest space. This requires the head to enter, or engage, facing sideways or at an oblique angle. Once positioned, the head must clear the front to back space. There are 3 antero-posterior diameters here: the true conjugate at 11 centimeters, the obstetrical conjugate at 10.5, and the diagonal conjugate at 12. The fetal head does not touch the very top of the pubic bone as it enters. The shortest distance between the back of the symphysis and the sacral promontory is the obstetrical conjugate, the minimum gap the head must traverse. If the obstetrical conjugate measures less than 10 centimeters, the inlet is defined as contracted. Vaginal delivery is no longer feasible. Clinicians estimate this gap by measuring the diagonal conjugate, the distance from lower symphysis to promontory, and subtracting 1.5 to 2 centimeters. Because of this, an unreachable sacral promontory is a highly reassuring clinical sign. Without a sufficient obstetrical conjugate, the mechanism of labor is defeated before engagement can even occur. Once past the inlet, the head enters the pelvic cavity. Here, the anatomy is highly asymmetrical. The anterior wall at the pubic symphysis is remarkably shallow, only about 4 centimeters deep, while the posterior sacral wall drops to 12 centimeters. This deep posterior sacral concavity is mechanically essential. It gives the fetal head the physical space needed to tuck its chin, flex maximally, and accommodate the curve of the birth canal. The upper portion of this cavity is spacious, known as the plane of greatest pelvic dimensions, but immediately below it lies the plane of least pelvic dimensions, the most restrictive bottleneck in the pelvis. This mid-pelvic plane is bounded by the lower symphysis and the lower sacrum. More critically, its transverse width is defined by the distance between the 2 protruding ischial spines, measuring just 10 centimeters. A bispinous diameter of less than 8 centimeters constitutes mid-pelvic contraction. Clinicians test this by attempting to touch both ischial spines simultaneously with one hand during an exam. This geometry creates a trap. The fetal head entered the 13-centimeter inlet in a transverse position, but it must now navigate a 10-centimeter mid-pelvis. To pass, it must rotate 90 degrees to an antero-posterior position. Failure to complete this internal rotation before hitting the bispinous bottleneck is the precise structural cause of deep transverse arrest. Those ischial spines serve as the 0 point for mapping fetal descent. We measure the vertical location of the head in centimeters, from -5, high above the spines, down to +5. In a prima gravida, 0 station defines engagement. For a physician to safely apply an operative vacuum or forceps, the head must descend well past this point, usually to at least +2 station. The spines also physically drive rotation. The levator ani muscles attach directly to the spines, forming a downward sloping plane. As the occiput descends and hits this inclined surface, it is deflected forward, turning the head into the correct anterior position. Behind the spine, the pudendal nerve curves tightly around the sacrospinous ligament. To perform a nerve block, the clinician uses the palpable ischial spine as the blind target for transvaginal anesthesia. The ischial spines are the master control nexus for descent mapping, rotational mechanics, and pain management in labor. The final level is the anatomical outlet. It is framed by the lower symphysis in front, the tip of the coccyx in back, and the 2 ischial tuberosities, the sitting bones, on the sides. At this level, the spatial geometry reverses. While the inlet was wider transversely, the outlet's AP diameter is now the dominant measurement at 13 centimeters, while the transverse bituberous diameter is only 11. If the bituberous diameter is contracted below 8 centimeters, the posterior space must compensate. According to the Thoms criterion, the sum of the bituberous and posterior sagittal diameters must exceed 15 centimeters to allow delivery. The shape of the pubic arch dictates the exit safety. A wide, obtuse subpubic angle allows the head to comfortably extend and crown, while a narrow android arch forces the head backward, significantly increasing the risk of perineal trauma. The entire mechanism of labor is a process of constantly aligning the widest diameter of the fetal head with whichever diameter of the pelvis happens to be widest at that exact level. To predict how these structural variations affect labor, the Caldwell-Malloy classification categorizes pelvis based on inlet shape and sidewall geometry. The gynecoid pelvis features a wide transverse oval and wide arch, making it highly favorable. By contrast, the android pelvis is heart-shaped with convergent sidewalls and encroaching spines, carrying a high risk for labor arrest. The anthropoid pelvis is an AP oval that favors direct occiput posterior delivery, while the platypeloid is a flat, wide transverse oval associated with high rates of engagement failure. In clinical reality, textbook presentations of these shapes are rare. Most women possess mixed pelvic architectures. While these archetypes help predict the tendencies of labor, they do not replace the requirement to evaluate exact structural thresholds. A contracted pelvis represents an absolute anatomical reduction below critical thresholds. When the inlet is under 10 centimeters, or the mid-pelvis is under 8, vaginal delivery is structurally impossible and requires a scheduled cesarean. This is distinct from cephalopelvic disproportion, or CPD. CPD is a dynamic mismatch between a specific maternal pelvis and a specific fetus, dependent on variables like head position, skull molding, and contraction force. Because CPD depends on so many real-time factors, static imaging and pelvimetry are notoriously poor predictors before labor begins. This is why global health bodies like the WHO reject routine admission pelvimetry. CPD is diagnosed intrapartum during a trial of labor. Signs include arrested cervical dilation, failure of descent despite full dilation, extreme scalp edema, and significant overlapping of the fetal skull bones. Since these factors change with every pregnancy, a prior cesarean for CPD does not automatically preclude a future vaginal birth after cesarean. While a contracted pelvis is a predictable structural certainty, CPD is an unpredictable, real-time mechanical failure that can only be diagnosed on the intense battlefield of labor. Safe passage through the birth canal requires clearing 3 exact functional gates: the obstetrical conjugate at 10.5 centimeters, the bispinous diameter at 10, and the bituberous diameter at 11. Through each gate, the ischial spines serve as the singular unifying landmark, tying together station, rotation, and transverse capacity. Safe obstetric management requires a rigorous spatial understanding of how an adaptive fetus navigates these precise, unforgiving geometric planes.
Safely delivering a human child requires navigating highly specific anatomical clearances. Before labor begins, clinicians must solve a complex problem of 3-dimensional spatial geometry. Obstetricians use a 5-tier checklist to map the pelvis: lie, presentation, presenting part, attitude, and position. Complicating this, the left rectosigmoid colon pushes the uterus rightward, causing dextrorotation. Examiners must mentally correct this rotation, returning the frame of reference to a true anatomical zero. Because the baseline geometry of the uterus is naturally skewed, failing to account for this initial rotation compromises every subsequent measurement on the 5-tier checklist. This graphic diagrams the relationship between the maternal and fetal spines, called the lie. There are 3 variations. Parallel at 0 degrees is a longitudinal lie. 90 degrees is a transverse lie. An angle of roughly 45 degrees is an oblique lie. Longitudinal is the only lie contractable with a normal vaginal delivery, accounting for roughly 99% of term pregnancies. A transverse lie is mechanically blocked from the birth canal and requires surgical or manual intervention. An oblique lie is inherently unstable and usually shifts into one of the other 2 configurations as labor approaches. Abnormal lies occur with too much space or an obstruction. Grand multiparity creates lax uterine walls, giving the fetus excess room to shift. Polyhydramnios does the same. Alternatively, pelvic tumors or a low-lying placenta can physically block the pelvic brim, preventing the fetus from settling longitudinally.
Looking at the lower uterine segment, presentation identifies exactly which fetal pole occupies this space. When the head sits in the lower pole, it is a cephalic presentation. Any alternative, like the buttocks in a breech or a shoulder, is classified as a malpresentation. The lie dictates the overall geometric feasibility of the birth. The presentation identifies exactly which piece of fetal anatomy will first challenge the pelvic inlet. Within a cephalic presentation, clinicians must identify the presenting part. This is the specific anatomical landmark resting directly over the internal cervical os. Which part presents is entirely dictated by the fetus's attitude. In this cross-section of the pelvic brim, we see fetal attitude, the degree of flexion of the fetal head relative to its chest. When the head is fully flexed, it creates a vertex presentation. Virtual calipers measure the suboccipitobregmatic diameter. At an average of 9.5 centimeters, this presents the smallest, most favorable geometric profile to the pelvis. But if the fetal neck partially extends, the attitude shifts. The brow faces down, and the presenting diameter expands significantly to measure the mento-vertical diameter. The mento-vertical line represents the longest distance across the fetal skull. It is generally too massive to negotiate a normal maternal pelvis. A persistent brow presentation creates a mechanical roadblock, mandating a cesarean section. Pushing into maximal extension creates a face presentation. The calipers shift again, now measuring the submentobregmatic diameter across the face. Vaginal delivery here is possible, but depends heavily on whether the chin, the mentum, points forward or backward. Note the terminology. Brow and face are not classified as malpresentations. They are abnormal attitudes within a cephalic presentation. A shift of mere millimeters in cranial flexion alters the presenting geometric diameter. This subtle change in angle shifts the clinical management plan completely, from a natural delivery to mandatory surgery. This split screen compares two scenarios that sound superficially similar: a hand co-presenting with the head and a hand protruding into the vaginal canal. On the left is a compound presentation. Because the underlying lie is longitudinal, the co-presenting hand will safely and naturally slide upward out of the way as the head descends into the pelvis.
Vaginal delivery remains the standard. Contrast this with hand prolapse, seen on the right. This occurs within a transverse lie. The hand protrudes because the shoulder is the true presenting part. Vaginal delivery of a transverse fetus is physically impossible, requiring an immediate C-section. These outcomes are determined by the lie, the broader geometric context that dictates whether the anatomy can physically clear the pelvis. Looking top-down at the maternal pelvic brim, we divide the perimeter into 8 specific sectors. Position defines how a specific fetal landmark, the denominator, rotates against these coordinates. The denominator changes based on presentation. It is the occiput for vertex, the mentum for a face presentation, and the sacrum for a breech. For a vertex presentation, there are 8 standard positions. The left occipital anterior, or LOA sector, is the most common and structurally favorable orientation for straightforward delivery. Complications arise in occipito-posterior, or OP positions. Here, the denominator rotates backward, driving the hard fetal occiput directly against the maternal sacrum. A fetus can sit in a perfectly parallel longitudinal lie and feature a fully flexed vertex presentation. Yet, if the micro-rotation of its position is posterior, it still faces severe mechanical disadvantage and a prolonged, painful labor. To extract this internal 3D geometry without imaging, clinicians rely on the external tactile algorithm known as Leopold's maneuvers. With the patient supine and the bladder empty, the clinician faces the patient's head. In this diagram of the first maneuver, the fundal grip, the examiner's hands press flat against the top of the uterus to identify which fetal pole sits there, establishing the lie. Moving down to the second maneuver, the lateral grip, the hands stabilize the umbilicus. One hand feels a smooth, continuous curve, indicating the fetal back, while the other feels the small, irregular nodes of the limbs. This pinpoints the position. The third maneuver is Pollock's grip. The examiner grasps the lower abdomen just above the pubic bone to confirm the presenting part.
By attempting to rock it gently from side to side, they test for fixation, whether the head is firmly wedged or still floating above the pelvis. For the fourth maneuver, the deep pelvic grip, the examiner executes a crucial positional shift, turning to face the patient's feet. The hands press deeply downward to assess engagement. Fixation simply means the head cannot move laterally. This graphic demonstrates engagement, the precise moment the widest transverse diameter of the presenting part, the biparietal diameter, physically drops below the bony pelvic inlet. Clinicians measure this using the fifths palpable method above the brim. 2/5 or less indicates the head is fully engaged. Executing the maneuvers in this specific order provides the data required to complete the 5-tier spatial checklist. We can see the results of this geometry on the surface. This silhouette displays a saucer-shaped flattening just below the umbilicus. This depression, along with fetal heart sounds transmitting toward the maternal flank, points directly to an occipital posterior position, where the fetal limbs sit forward against the abdominal wall. Recognizing this abdominal contour and lateral heart tone placement allows clinicians to prepare for back labor and surgical risks before a vaginal exam even occurs. The diagnostic pipeline scales down systematically, beginning with the broad maternal fetal axis, moving to flexion of the skull, ending at the exact rotational denominator. The strict separation of lie, presentation, attitude, and position provides the definitive mechanical blueprint required to navigate the high-stakes physics of human birth.
Successful vaginal delivery is an exercise in strict spatial geometry, a mechanical conflict between two hard objects, the fetal skull and the maternal pelvis. Nature's baseline for solving this spatial conflict is the left occipito-anterior position, or LOA. In this orientation, the fetus sevels its heaviest part, the head, into the widest segment of the pelvis. Looking at this 3D cross-section, we see exactly how LOA works mechanically. The fetus tucks its chin to its chest, achieving full cervical flexion, which presents the smallest possible diameter of the skull. It faces the mother's spine, utilizing the deeper spatial reserves of the posterior pelvis, while the back of its head leads the descent. But the maternal pelvis is not a uniform bowl. It presents one of 4 distinct topological architectures. These geometric variations dictate and strictly limit exactly how that skull can navigate the birth canal. This first map, the gynecoid pelvis, represents the physiological ideal. Its round, capacious inlet provides optimal spatial clearance for the skull to rotate and descend without obstruction. Moving to the anteroid pelvis, we see a heart-shaped, male-type geometry. Notice these red vectors. They demonstrate how the narrow anterior arch physically restricts the fetal head from rotating forward. The anthropoid pelvis is oval, characterized by an extended anterior-posterior axis. Because this AP diameter is so generous, it readily permits labor, but the geometry naturally biases the fetus to remain in a posterior, face-up position. Finally, the rare platypeloid pelvis is flat and wide side to side, with a severely restricted AP gap. Navigating this shallow space forces the fetal skull into extreme cranial extension. Every malpresentation we observe in clinical practice stems directly from this anatomical reality. They are strict mechanical conflicts caused by specific deviations from the geometric ideal. In the occipito-posterior, or OP position, the fetal alignment is reversed. The occiput, the back of the head, faces the mother's posterior, meaning the baby's face aligns directly with the maternal abdomen. This diagram illustrates exactly why this happens. When a fetus with a deflexed head encounters the narrow anterior arch of an android pelvis, the tight space physically forces the occiput away from the front. The pelvic geometry actively pushes the baby into a posterior position. You can identify this anatomical mismatch simply by palpating the abdomen. Instead of feeling the firm, continuous curve of the fetal back, the examiner feels a flat, irregular contour created by the forward-facing anterior limbs. In the majority of cases, nature resolves this conflict. As the head descends, it encounters the levator ani muscles of the pelvic floor, which act as a physical guide, forcing the skull to execute a 3/8 forward rotation back into the normal OA position. But if that rotation begins within the rigid constraints of an anthropoid pelvis, the skull can halt mid-turn. It becomes wedged horizontally.
This creates a state of deep transverse arrest, halting labor completely. Conversely, if the skull rotates 1/8 of a turn backward into a direct OP position, it requires specific clearance to descend. We see here how the elongated anterior-posterior axis of the anthropoid pelvis uniquely permits this posterior pathway. A persistent direct OP results in a face-to-pubes delivery. Because the head is forced through the outlet, presenting a significantly wider diameter, it places immense strain on the maternal tissue. A prophylactic episiotomy becomes a necessary surgical intervention to prevent a complete tearing of the perineum. This illustration shows a transverse lie, where the fetus rests entirely horizontally within the uterus. The shoulder presents at the internal os, leaving the pelvis completely unengaged. This extreme spatial deviation is primarily caused by multiparity. After multiple pregnancies, the uterine and abdominal muscles lose the baseline tone necessary to maintain the fetus in a longitudinal, vertical axis. On examination, the spatial dimensions of the abdomen are distinctly skewed. The uterine width greatly exceeds expectations for the gestational age, while the fundal height is demonstrably diminished because the vertical space is empty. A shoulder presentation is an absolute mechanical impasse. There is zero biomechanical mechanism by which a fetal shoulder can dilate a cervix or descend through the birth canal. The immediate threat lies in the empty cervix. Without an occlusive head plugging the os, the moment the membranes rupture, the exiting fluid violently drags the umbilical cord down through the opening, resulting in immediate cord prolapse and acute fetal hypoxia. To prevent this, obstetricians utilize external cephalic version, or ECV. Attempted at exactly 37 weeks, it is a targeted manual intervention applying external pressure to mechanically rotate the fetus into a head-down orientation. This diagram maps the strict safety algorithm required before attempting ECV. The clinician must verify 7 exact prerequisites: a singleton pregnancy, intact membranes, adequate amniotic fluid, a reassuring CTG, no placenta previa, normal pelvic architecture, and a gestational age over 36 weeks. 2 precise pharmacological adjuncts are also necessary. Terbutaline is administered to achieve uterine tocolysis, relaxing the muscle wall for manipulation. And in Rh-negative patients, anti-D is mandatory to prevent feto-maternal sensitization from microbleeds caused by the procedure. The procedure is strictly limited to 2 attempts. Pushing beyond this threshold rapidly escalates the mechanical trauma risks of placental abruption and cord entanglement, heavily outweighing any benefit of avoiding a cesarean section. Shifting from pelvic shape to the fetal posture itself, we must look at fetal attitude, the exact degree of cranial flexion or extension as the head enters the pelvis. When the head is thrown into full extension, it results in a face presentation. This posture is typically forced by a restrictive nuchal cord, a shallow platypeloid pelvis, or the loss of cerebral mass seen in anencephaly, which eliminates the tone that normally keeps the chin tucked. In a face presentation, this diagram shows how millimetric geometry dictates the outcome. If the chin, or mentum, faces anteriorly, the skull can sweep under the pubic symphysis and flex, creating a viable mechanical pathway for a vaginal delivery. But if the chin faces posteriorly, it points directly towards the sacrum. To clear the pelvis, the head would need to extend further, an anatomical impossibility since it is already in maximum extension. This creates an absolute mechanical impasse, mandating a cesarean section. Between normal flexion and full face extension lies the brow presentation. This is an unstable intermediate state of partial extension, diagnosed exclusively by palpating the anterior fontanelle and the supraorbital ridges on examination. The danger here comes down to raw numbers. A face presentation engages a submentobregmatic diameter of about 9.5 centimeters, but a brow presentation forces the mento-vertical diameter into the pelvis, measuring a massive 13.5 to 14 centimeters. The maximum average pelvic inlet is only 12 centimeters. Because the mento-vertical geometry completely exceeds the spatial capacity of the bone, a persistent brow presentation offers no mechanism for labor and remains an absolute indication for surgical extraction. By 36 weeks, the fetal head, being the heaviest pole, is driven by gravity to settle into the lower uterus. The primary cause of a breech presentation is simply prematurity, a failure of the fetus to complete this gravity-driven inversion in time. Breech variations are categorized by lower limb posture, which determines how effectively the fetal body acts as a physical plug against the cervical os. In a frank breech, the hips are flexed and knees are straight in a pike position. This dense structure acts as a firm, highly occlusive plug, yielding the lowest risk of the umbilical cord slipping past. The complete breech, with both hips and knees flexed in a cross-legged position, is moderately occlusive, maintaining a relatively low risk profile for prolapse. Moving to the bottom tiers, knee and footling breech presentations introduce an irregular shape with negligible occlusion. These tiny extremities leave severe spatial gaps at the cervix, creating the maximal risk for umbilical prolapse. Breech stability is a matter of fluid dynamics and plug quality. A failure to firmly occlude the cervix virtually guarantees a catastrophic cord prolapse the moment the membranes rupture. The primary mechanical hazard of any vaginal breech delivery is sequence reversal. Instead of the head slowly molding to the pelvis over hours, the largest, entirely unmolded fetal structure arrives suddenly at a potentially unyielding cervix. This spatial danger is why cesarean sections are mandatory for footling configurations, fetal weights under 1,500 grams or over 4 kilograms, twins, and any instance of cephalopelvic disproportion. This sequence illustrates the reversed mechanics of a left sacro-anterior breech. A 10-centimeter bitrochanteric diameter engages the inlet first, followed by descent, internal rotation of the buttocks, and lateral flexion of the trunk. When this structural sequence arrests, specific obstetric maneuvers are required to intervene. Groin traction is applied to resolve a complete breech, while Pinard's maneuver is used to manually press behind the knee, unlocking the legs from a rigid frank breech. If the bisacromial shoulders arrest, Loveset's maneuver is deployed. By executing a precise 180-degree trunk rotation while maintaining downward traction, the operator physically guides each shoulder out from under the rigid pubic arch. The most critical moment is managing a trapped aftercoming head. While manual traction can be used, Piper's forceps are specifically designed to secure the unmolded skull, controlling the speed of descent to prevent explosive cranial decompression. Beyond these maneuvers lies breech extraction, utilizing an internal pedalic version. This is an extreme emergency tool, indicated exclusively for the rapid intervention of a transverse second twin when the cervix is already fully dilated. The rapid barometric shifts and immediate umbilical compression during these procedures make intracranial hemorrhage and asphyxia the primary risks. If delivery is delayed, these mechanical forces quickly compromise fetal viability. The mechanical success of labor depends on the precise intersection of 3 spatial vectors: fetal presentation, orientation, and maternal pelvic architecture. Sound clinical management relies on identifying when nature can provide a mechanical solution, such as the levator ani forcing a spontaneous OP rotation, or a frank breech safely occluding the cervix. We evaluate those physiological pathways against spatial configurations that dictate absolute surgical intervention. Checking the diameter limits shown here dictates our response. A flexed LOA is a clear mechanical go, while a persistent brow or a footling prolapse strictly demands the operating room. Navigating the critical threshold between these extremes requires patience. Early labor conditions, like a mento-posterior face presentation, demand a wait-and-watch approach, allowing time for spontaneous rotation before committing to surgery. Malpresentation represents an applied problem of biological physics, demanding algorithmic, anatomically precise responses from the obstetrician. Mammalian pregnancy is defined by a central biological paradox. For 9 months, the uterus enforces absolute mechanical retention of the fetus, containing immense outward pressure, only to pivot to decisive expulsion at the moment of birth. This mid-pregnancy state, known as uterine quiescence, is actively enforced. Smooth muscle is molecularly prevented from contracting through a sophisticated inhibitory system. Prostaglandins, gap junctions, and oxytocin receptors are all suppressed by the hormone progesterone. It acts as a systemic brake, keeping the intracellular environment unfavorable for coordinated muscular effort. Labor occurs when the fetus initiates a program to systematically dismantle this inhibitory state. Every obstetric rule and intervention follows from this transition, making the management of labor a matter of applied first principles physiology. In mammals, labor triggers when progesterone plummets. Human data shows our progesterone remains high. This is functional withdrawal. The myometrium replaces inhibitory receptors with PRA, antagonizing the hormone. The brakes wear down, even with a full progesterone tank. The fetus acts as the primary timekeeper for this shift. As it matures, the fetal hypothalamus begins releasing corticotropin-releasing hormone, or CRH. This CRH triggers the release of ACTH from the fetal pituitary, driving the fetal adrenal glands to produce massive quantities of DHEA sulfate. Once this DHEA sulfate reaches the placenta, it is aromatized into estrogen, specifically estriol. Rising estrogen dominance upregulates oxytocin receptors, promotes the formation of gap junctions, and stimulates local prostaglandin synthesis. Through this entire endocrine cascade, the maturing fetus actively signals its own readiness, making labor a fetal-driven process. Physical shifts begin around 38 weeks as the fetal head engages in the pelvis. In a first pregnancy, this drops the uterine fundus and relieves pressure on the diaphragm, a transition called lightening. Simultaneously, the cervix undergoes a biochemical transformation into a soft, dilatable channel. Local prostaglandins activate enzymes to degrade the collagen matrix. Hyaluronic acid displaces dermatan sulfate, rapidly pulling water into the tissue to increase its compliance. This process results in 3 structural changes: decreased collagen cross-linking, increased water content, and a total softening of the cervical wall. Clinical assessments like the Bishop score measure the extent of these molecular changes. If a score is low, clinicians must use exogenous prostaglandins to ripen the tissue before an induction can succeed. This molecular preparation distinguishes true labor from false labor. True labor requires gap junctions, allowing electrical waves to propagate from cornual pacemaker cells across the entire uterus in roughly 15 seconds. Clinical observations of progressive contractions and cervical scores act as proxies for the underlying cellular expression of gap junctions and the changing collagen matrix. Active labor is tracked through 4 functional stages, moving from cervical dilation and fetal expulsion to the delivery of the placenta and the critical postpartum observation of uterine tone. Uterine performance follows precise pressure thresholds. A basal tone of 10 to 20 millimeters of mercury is normal. Sensation begins at 15 millimeters, while cervical dilation requires 20 to 25. The most intense expulsive forces during delivery can reach 120 millimeters of mercury. Clinicians calculate Montevideo units to measure cumulative mechanical work, multiplying the amplitude of contractions by their frequency over a 10-minute window. However, high uterine pressure decreases uterine volume, which compresses the spiral arteries. This causes a temporary pause in blood flow to the placenta during the peak of every contraction. When contractions occur too frequently, a state called tachysystole, the fetus may develop hypoxia because the intervals are too short for reperfusion. Recovery requires optimizing maternal position and oxygenation to restore placental flow. During labor, the uterus differentiates into an active upper segment that contracts and a passive lower segment that thins and stretches. Because the lower segment is thin and under intense tensile stress, it is the primary site for complications like uterine rupture and placenta previa bleeding. If labor progress is insufficient, clinicians augment the process. Artificial rupture of membranes, or ARM, provides mechanical stimulation of the cervix and releases local prostaglandins, while oxytocin provides a direct biochemical drive to the muscle. The sequencing of these interventions depends on spatial mechanics. If the fetal head is engaged at spation 0, it acts as a plug. In this position, ARM can be safely performed first because the head prevents the umbilical cord from slipping through. If the head is unengaged and floating, a gap exists between baby and cervix. Rupturing membranes in this state risks cord prolapse. Clinicians must use oxytocin first to drive the head down and obliterate that space before rupturing the membranes. Fluid dynamics also govern the management of polyhydramnios. Excess fluid creates high wall tension. An abrupt rupture can shrink the uterus so rapidly that the inelastic placenta shears off. This necessitates a controlled, slow decompression. These clinical protocols function as rigid safety rules, dictated entirely by the physics of fluid volume and anatomical space. The pelvic inlet is widest transversely, while the outlet is widest front to back. During engagement, the fetal head aligns horizontally. It maximizes this fit through asynclitism, tilting to present its narrowest profile to the varying geometry of the pelvis. As the head descends, resistance from the pelvic floor forces the chin to the chest. This flexion reduces the presenting diameter from 11.5 centimeters to a more compact 9.5 centimeters. At the level of the ischial spines, internal rotation occurs. The head rotates 90 degrees, so its longest axis aligns with the front-to-back diameter of the pelvic outlet. As the head reaches the pubic arch, the upward curve of the birth canal forces the fetus to extend. It uses the pubic bone as a fulcrum to sweep upward and out. Following delivery, the neck untwists in a movement called restitution, allowing the shoulders to rotate and align for their own passage through the outlet. The cardinal movements represent the mathematical necessity of moving a fixed object through a geometrically shifting tunnel. Labor pain follows specific neural pathways. In the first stage, myometrial ischemia in the upper uterus sends signals through T10 to L1 sympathetic fibers, causing pain that radiates to the back and thighs. Cervical dilation is mediated by the sacral plexus at S2 to S4. In the second stage, pain is concentrated at S2 to S4 as the fetal head stretches the vagina and perineum, activating the pudendal nerve. Because the highest pain signals originate at T10, placing an epidural at that level covers all downstream labor pain. A cesarean section requires a higher T4 block to account for the pain of surgical handling. Obstetricians use bupivacaine to create a differential block, which suppresses sensory nerves while sparing motor function. This allows the mother to push while benefiting from the vasodilation that improves uterine blood flow. However, local vascular anatomy creates specific risks. A paracervical block is contraindicated in labor because the anesthetic can be absorbed into the uterine artery and delivered to the fetus, where it depresses the fetal heart rate. Effective pain management relies on these anatomical maps, allowing clinicians to block sensory trauma without disrupting the mechanics of delivery. Prostaglandins serve as the ultimate molecular integrators. Synthesized locally, they act on adjacent cells, ensuring their effects are concentrated precisely where they are needed. Prostaglandins simultaneously ripen the cervix, amplify the force of contractions, and link mechanical changes like membrane rupture to the progression of labor. From the initial fetal signal to the geometric rotation of the head, every phase of birth is part of a single coordinated program. Ultimately, clinical obstetrics functions as an extension of this biological program. Every clinical threshold, procedure, and contraindication follows from these physiological first principles. Labor is a mechanical sequence by which the uterus executes the forceful expulsion of the fetus, placenta, and membranes through the birth canal. Clinical timelines and definitions are difficult to apply without understanding the three biological imperatives that occur in sequence: cervical remodeling, fetal descent, and finally, expulsion. These imperatives map directly onto the four clinical stages of labor. Stage 1 remodels the cervix. Stage 2 covers descent and expulsion of the fetus. Stage 3 delivers the placenta, and Stage 4 is a period of physiological surveillance. With this functional map established, clinical thresholds, from dilation rates to arrest criteria, become logically derivable consequences of human biomechanics. Before labor begins, the cervix is a thick, firm structure composed of collagen-rich stroma. It is designed to keep the pregnancy sealed within the uterus. The latent phase is effacement. The thick collagen stroma is dismantled and pulled upward into the lower uterine segment. This biochemical remodeling makes the cervix flexible. It takes time, averaging 12 hours for a primigravida and 8 for a multigravida. Because this structural preparation is a significant biological task, a slow latent phase is considered a normal physiological variation. When the latent phase is prolonged, clinical management focuses on conservative therapeutic rest and sedation to allow the remodeling to continue naturally. Rushing this structural remodeling with a cesarean section ignores the requirements of early labor biology and can lead to avoidable surgical harm. Historical guidelines often place the onset of active labor, the point where dilation accelerates, at a threshold of 3 or 4 centimeters. Modern observational data from ACOG and the WHO has shifted this boundary. Active labor is now defined as beginning at exactly 6 centimeters of dilation. The danger of the older 4-centimeter rule was the misdiagnosis of failure to progress in patients who were actually still undergoing normal latent phase effacement. The 6-centimeter threshold is an evidence-based shield. It protects healthy women from unnecessary operative deliveries by allowing the latent phase to complete its biological work. Once active labor begins at 6 centimeters, the cervix should dilate at approximately 1 centimeter per hour. The classical WHO partogram used a rigid line to trigger intervention at this rate. However, the newer WHO labor care guide uses a surveillance-based model that allows for individual variation in labor speed. If dilation falls below the 1 centimeter per hour floor, it is termed protracted. This triggers a vaginal examination for mechanical resistance, specifically cephalopelvic disproportion, or CPD. Signs include scalp swelling and cranial molding, where fetal skull bones overlap from pelvic pressure. CPD must be distinguished from a persistent occiput posterior malposition. While an occiput posterior head may rotate spontaneously, true CPD requires a cesarean section. Protraction is a mechanical trigger. It prompts investigating the physical fit between the passenger and the pelvis before concluding the uterus is inadequate. Arrest is the complete cessation of cervical change. It is a more severe diagnosis than protraction and carries direct surgical implications. 2 absolute prerequisites must be met before diagnosing an active phase arrest. The cervix must be at least 6 centimeters dilated, and the amniotic membranes must be ruptured to allow for maximum uterine pressure. If these conditions are met, arrest is confirmed when there is no cervical change for 4 hours despite adequate contractions of at least 200 Montevideo units. If contractions are inadequate, clinicians wait 6 hours while administering oxytocin before diagnosing an arrest. Surgery performed before these criteria are met results in an incorrect diagnosis of active phase arrest. This clinical labeling follows the patient in future pregnancies, potentially restricting her options for vaginal birth based on a failure that never actually occurred. The second stage begins at full 10-centimeter dilation. If the fetal head does not descend for 2 hours in a first pregnancy or 1 hour in subsequent ones, it is considered an arrest of descent. Instrumental delivery via forceps or vacuum can be considered if the cervix is fully dilated, the fetal position is known, and the head is at least 2 centimeters below the ischial spines. To protect the perineum, the birth attendant manages the delivery. By encouraging flexion and controlled extension, the smallest cranial diameter sweeps over the perineum. Supportive techniques such as warm compresses and massage are used to help the tissue accommodate the fetus. Routine episiotomies are discouraged by the WHO in favor of this controlled biomechanical approach. Patience and proper positioning allow physics to protect the maternal anatomy from severe lacerations. Obstructed labor is a mechanical emergency. The upper uterine segment thickens to force the fetus down, while the lower segment is pulled thin, reaching a point of imminent rupture. This creates Bandel's ring, a visible and palpable groove across the abdomen. It marks the boundary between the thick upper segment and the dangerously distended lower segment. Prolonged compression leads to tissue necrosis, resulting in a vesico-vaginal fistula days later. In contrast, a constriction ring is a different pathology, an isolated, functional spasm of the uterine muscle, usually caused by excessive oxytocin rather than structural obstruction. Bandel's ring requires an immediate emergency cesarean section to prevent rupture. A constriction ring is managed with tocolytic agents like terbutaline to relax the specific band of spasming muscle. Misinterpreting a localized muscular spasm for a macroscopic structural obstruction leads the clinician toward either unnecessary surgery or catastrophic organ rupture. After the placenta is expelled in stage 3, the focus shifts to stage 4. This is a critical 1 to 2 hour window of intensive surveillance. This window is used to monitor for postpartum hemorrhage and hemodynamic instability before the mother is transferred out of the labor ward. Labor efficiency is supported by early ambulation, regular bladder emptying every 2 hours to prevent mechanical interference, and the intake of oral fluids. While fluids are encouraged, solid foods are withheld during active labor. This reduces the risk of aspiration if emergency surgery requiring general anesthesia becomes necessary. Clinical thresholds must align with the physical mechanics of the birth process. By waiting for true biological limits to be reached, surgery remains an intervention for true failure, rather than a result of clinical impatience. Intrapartum care is a high-stakes clinical environment measured in seconds and minutes. Clinicians must identify life-threatening complications immediately, avoiding interventions that disrupt a natural labor. Monitoring tools exist to standardize this process. They are designed to assist birth attendants in recognizing abnormal labor patterns and fetal distress, ensuring consistent decision-making regardless of the setting or the provider's experience level. Two systems currently dominate this space: the 1994 Modified WHO Partograph and the 2020 WHO Labor Care Guide, or LCG. The LCG functions as a complete replacement for the Partograph, discarding the 1994 model's mathematical framework in favor of a different set of physiological assumptions. This transition represents an evolution in obstetric knowledge, revising the medical understanding of what a normal delivery looks like. The new standards are rooted in the 2018 WHO Intrapartum Care Recommendations, which provided the evidence base for modernizing labor management globally. By measuring modern labor against outdated benchmarks, the medical field often medicalized a natural process. The LCG was built to realign clinical practice with actual human biology. In the 1950s, American obstetrician Emanuel Friedman began charting cervical dilation over time to find a statistical baseline for labor. He produced the Friedman sigmoid curve, which divided labor into 4 phases: latent, acceleration, maximum slope, and deceleration. His data led to a rigid clinical mandate: active labor must progress at a rate of at least 1.2 centimeters per hour. However, Friedman's study used a small, non-representative group of women who were heavily sedated. We now know that his deceleration phase, a slowing down near full dilation, was an artifact of that sedation, not a natural part of labor. Despite these flaws, researchers Philpott and Castle adopted Friedman's work in the 1970s for use in rural Zimbabwe, creating a practical tool for the field. They established an alert line, drawn at a rate of 1 centimeter per hour, starting from 3 centimeters of dilation. Crossing this line signaled that the woman required closer attention. They also added an action line 4 hours to the right. This specific 4-hour gap was chosen to allow for the time it took to transport a patient to a referral hospital. It was a logistical buffer, not a biological rule. In 1994, the WHO simplified this into the modified Partograph, removing the latent phase and setting the start of active labor at 4 centimeters. For 3 decades, clinical progress was measured against a 1950s mathematical curve and a 1970s transport buffer, leading to frequent misdiagnoses of slow labor. In 2010, researchers like Jun Zhang analyzed over 60,000 deliveries, producing data that contradicted Friedman's curve. Zhang found that the transition to rapid dilation happens at 5 to 6 centimeters, and that labor before that point is naturally much slower than 1 centimeter per hour. This overdiagnosed labor dystocia, the medical term for slow progress, contributed to a surge in unnecessary oxytocin use and cesarean sections. The structure of the 1994 modified WHO Partograph enforced this rigid diagnostic framework through its 3-section layout. Section 2 tracked progress. If a woman was admitted at 5 centimeters, her first plot had to be placed directly on the alert line, beginning a countdown toward the action line, regardless of her actual physiological pace. Section 1 monitored the baby, recording heart rate and molding, the overlapping of fetal skull bones. A +3 mold warned of cephalopelvic disproportion, where the baby's head cannot fit through the mother's pelvis. The bottom section tracked maternal vitals and contractions. Shaded boxes indicated strong contractions lasting over 40 seconds, while tracking the risk of hyperstimulation, which can restrict fetal oxygen. However, this chart lacked space for the mother's respiratory rate, oxygen levels, oral fluid intake, or pain management. While the Partograph excelled at basic disease screening, its mechanical thresholds prioritized a fixed schedule over modern physiological data or the patient's physical experience. The WHO Labor Care Guide replaces this 3-part chart with a 7-section system organized by the mnemonic Smart, Beautiful Women Love Me, covering supportive care, baby, woman, labor, and medications. The LCG's architecture integrates clinical safety with a requirement for supportive care throughout the delivery process. Section 2, Supportive Care, requires clinicians to document the presence of a birth companion, the intake of oral fluids, and the use of proactive pain relief. A mother lying supine or flat on her back triggers a clinical alert due to aortocable compression, which can restrict blood flow to the uterus. Additionally, denying a birth companion is now recorded as a direct failure in care. Section 3 adds specific detail to fetal monitoring, differentiating between early, late, and variable heart rate decelerations, while also tracking fetal positions like occipito-posterior. In Section 5, the LCG removes the alert and action lines entirely. It replaces them with the 5, 6, 7, 8, 9 rule. Active labor is redefined as beginning at 5 centimeters, using time-bound limits, up to 5 hours to reach 6 centimeters, 4 hours to reach 7, and so on. This schedule reflects the reality that labor is slow during early transition, but should accelerate rapidly as the mother approaches full dilation. Sections 6 and 7 track medications and the action plan, ensuring clinical accountability from the first stage of labor through the active pushing of the second stage. The LCG functions as a holistic clinical decision engine, focusing on individual physiology rather than a predetermined hourly rate. To see the impact of these systems, we apply identical patient data to both the partograph and the LCG. In clearly abnormal cases, they agree. A 3-hour stall at 8 centimeters triggers alerts on both charts, identifying a medical need for intervention. Differences emerge in nuanced scenarios, like a woman at 5 centimeters taking 3 hours to reach 6. On the partograph, she fails the 1 centimeter per hour rule. Her plot enters the warning zone, triggering a dystocia diagnosis and labor-accelerating drugs. Under LCG guidelines, that same progress is well within the 5-hour allowance for the 5 centimeter stage. Her labor is recorded as normal and no intervention is required. Fetal null position provides another point of collision. A baby in the occipito-posterior, or face-up position, often causes a slower, more painful delivery. The partograph does not track fetal position, leaving the clinician with a failure to progress of unknown cause. The LCG documents the position, allowing the provider to suggest postural changes or manual rotation instead of moving directly to surgery. Finally, consider pain management and support. These failures are invisible on the partograph. On the LCG, denying a companion or failing to offer pain relief triggers immediate alerts, requiring the medical team to address the mother's human rights and physical comfort. With identical patient data, the legacy tool often leads to unnecessary surgery and overlooked trauma, while the modern tool prioritizes observation and human support. The Labor Care Guide is an evidence-based refinement of obstetric care. It maintains past safety standards while incorporating an accurate understanding of labor duration. This model recognizes childbirth as a physiological process requiring support, prioritizing the mother's well-being alongside the clinical detection of risk. Modern intrapartum care has moved away from 1950s schedules to focus on the mother's physiology and the support needed for a safe, respectful delivery. The protocols used for labor induction are not a collection of arbitrary rules. They are the clinical application of the cervix's own biochemical and mechanical properties. To understand induction, we have to start with the tissue itself. The human cervix at term is not a muscular sphincter. It's a connective tissue organ. Under a microscope, thick, highly organized collagen fibrils run parallel, bound tightly by cross-linking decorin molecules to keep the pregnancy inside. As term approaches, prostaglandins activate MMPs, enzymatically cleaving the decorin. Hyaluronic acid draws in water, forcing the fibrils to spread apart and swell. The macroscopic result of this molecular shift is what clinicians observe during an exam. The firm cervix softens, shortens into the lower uterine segment, rotates toward the vaginal axis, and begins to dilate. Physiological cervical ripening is an inflammatory, prostaglandin-driven dissolution of connective tissue. This establishes a clinical rule. Anything that mimics or triggers prostaglandin release will ripen the cervix. Oxytocin's mechanism of action operates on a separate biological pathway. It binds receptors in myometrial smooth muscle, triggering calcium release to drive actin-myosin crossbridge cycling. Oxytocin has no direct enzymatic effect on cervical collagen or matrix metalloproteinases. It drives contractile force, not structural remodeling. Forcing powerful myometrial contractions against a biochemically unripe, collagen-dense cervix creates massive physical resistance. The cervix cannot transmit the traction forces into dilatation. Applying oxytocin before sufficient matrix dissolution simply compresses the fetal environment, repeatedly reducing uteroplacental blood flow. This creates fetal distress and risks mechanical failure of the uterine wall, which is why tissue ripening must precede contraction. Because cervical ripening is a continuous biochemical process, clinicians require a method to quantify how far along the collagen dissolution has progressed. E. H. Bishop operationalized this scoring system in 1964. Looking at this matrix, the Bishop score isolates 5 physical probes used to evaluate the structural integrity of the cervix: consistency, position, effacement, dilatation, and station. Note the scoring weights. Dilatation is the net functional output of the entire matrix dissolving process, making it the most heavily weighted parameter. Position is highly subjective, maxing out at 2. The system uses a specific heuristic. A score of 1 represents the exact midpoint of the biological spectrum from completely unripe to completely ripe for that specific parameter. Take a prima gravida patient presenting with a mid-position, medium consistency cervix that is 2 centimeters dilated, 50% effaced, with the fetal head at a -3 station. These yield a score of 4. A score of 5 or less means the matrix is intact and requires deliberate ripening. A score of 9 or higher indicates the cascade is essentially complete, and the induction will mirror spontaneous labor. The Bishop score is a tactile readout of the extracellular matrix's tensile strength. There are non-pharmacological ways to trigger the ripening cascade. Membrane sweeping is an outpatient procedure that mechanically separates fetal membranes from the decidua, physically disrupting the tissue to release endogenous arachidonic acid locally. This relies on Ferguson's reflex, a physiological loop where mechanical distension of the lower uterine segment triggers localized prostaglandin release from the decidua and membranes. A transcervical Foley catheter exploits this reflex. Inflating the balloon with 30 milliliters of saline at the internal os applies sustained radial pressure. Extra amniotic saline infusion, or EASY, and hygroscopic dilators like laminaria use this same pathway, augmenting mechanical stretch to dissolve the collagen matrix over several hours. This mechanical approach is the standard of care for a uterus with a previous cesarean or myomectomy scar. Scar tissue lacks tensile strength. Pharmacological prostaglandins, like misoprostol, can trigger global, unsynchronized myometrial hypercontractility, known as tachysystole. Subjecting a compromised scar to repetitive pressure stress risks uterine rupture.
Mechanical methods isolate the biochemical remodeling to the cervix, keeping the myometrium quiescent. When pharmacological ripening is safe, synthetic prostaglandins are deployed. Misoprostol, a PGE1 analog, acts on EP2 and EP3 receptors to dissolve cervical stroma, but it also activates EP1 receptors to drive uterine contractions. The induction dose of 25 micrograms strikes the threshold needed for progressive matrix ripening while staying below the dose-response curve that triggers overwhelming tachysystole. Misoprostol has a plasma half-life of only 20 to 40 minutes, but its active tissue effects in the cervix persist for 4 hours. This requires a strict 4-hour dosing interval and washout period. Dinoprostol delivers endogenous PGE2. Servoprime gel requires a 6-hour interval and mandatory refrigeration. Alternatively, the Cervidil insert releases a continuous 0.3 milligrams per hour over 12 hours. The primary clinical advantage of the Cervidil insert is physical retrievability. If fetal distress occurs, the insert is removed, terminating drug delivery. The risk of tachysystole correlates with anatomy. Delivering medication into the vascular posterior vaginal fornix drives faster absorption into the myometrium than endocervical gel placement. Pharmacological ripening risks are proportional to the drug delivery rate and the anatomical proximity to the myometrium. Once the cervix has sufficiently ripened, oxytocin is deployed to drive actin-myosin cross-bridging. We can derive the maximum safe drip rate from the standard preparation. Dissolving 5 units of oxytocin into 500 milliliters of normal saline yields 10 milliunits per milliliter. With an IV set delivering 20 drops per milliliter, the concentration is exactly 0.5 milliunits per drop. Capping the flow at 52 drops per minute limits the patient to 26 milliunits per minute.
Beyond this point, the risk of tachysystole spikes with no proportional benefit. Oxytocin must never be dissolved in 5% dextrose. The molecule shares structural homology with antidiuretic hormone, or ADH, and mimics its effects at high volumes. Administering hypotonic fluid while simultaneously stimulating ADH receptors forces the kidneys to retain water, inducing dilutional hyponatremia and neurological crisis. If oxytocin is given as a rapid bolus, it causes direct vascular smooth muscle relaxation, triggering a drop in systemic blood pressure. Standard oxytocin protocols are calibrated to achieve maximum uterine response while staying below the thresholds for maternal renal and cardiovascular stress. The baseline rule of obstetrics is that induction is contraindicated whenever vaginal delivery is structurally unsafe. Dilating a cervix over a placenta previa or vasa previa mechanically shears the tissue, causing immediate fetal or maternal hemorrhage. In cases of a transverse lie, brow presentation, or cephalopelvic disproportion, induction forces drive a non-yielding wedge against the pelvis. At the tissue level, a classical vertical cesarean scar runs through the thick, contractile body of the uterus, elevating rupture risk. Similarly, manipulating a friable cervical tumor risks severe hemorrhage. Conditions like fetal distress or monoamniotic twins prohibit induction because the fetuses cannot endure the reduction in blood flow that occurs with each forced contraction. These contraindications are the inevitable physical consequences of applying mechanical force to a compromised anatomical container. Protocols for intrauterine fetal death must account for gestational age because it determines the specific balance of hormonal receptors in the myometrium. Myometrial sensitivity to prostaglandins is a sliding scale dictated by progesterone versus developing receptors. Between 22 and 28 weeks, progesterone dominates, requiring 600 to 800 micrograms of misoprostol. But past 28 weeks, sensitivity rises sharply. Administering those high doses to a highly sensitive term uterus would trigger violent hyperstimulation and likely uterine rupture. Cervical ripening is a predictable enzymatic process, and clinical protocols are the tools used to trigger that transition when the body hasn't done so spontaneously. The second stage of labor is a physics equation. Moving a rigid object through a nonlinear, fixed bony cylinder requires precise vector forces. When those forces fail, progress stops. This mechanical framework isolates three variables: the passenger, the fetal skull, the passage, the maternal pelvis, and the powers, driving descent. The primary power is myometrial contractions, measured in Montevideo units. Adequate labor requires a threshold of roughly 200 Montevideo units. But myometrial force alone cannot complete the second stage. The mother must supplement it with a secondary power, the Valsalva maneuver. By closing the glottis and contracting her diaphragm, she generates an extreme spike in intra-abdominal pressure that pushes the fetus downward. This voluntary pushing effort can vanish in a clinical setting. Epidural motor blocks blunt muscle control. Deep sedation removes coordination. Extreme maternal exhaustion simply depletes the required physical energy. Faster, more urgently. Without that Valsalva maneuver, perfect uterine contractions generating 200 Montevideo units are often insufficient to achieve full descent. When biological forces have reached their limit, resolving the architectural impasse requires an external mechanical replacement. We call this instrumental delivery. Applying external force to the human body requires understanding the strict boundaries of the passage. The maternal bony pelvis is a rigid, non-compressible structure. Its internal dimensions are absolute. This pelvic wireframe shows the four horizontal planes. First, the inlet, where the fetal head clears the 11-centimeter obstetrical conjugate. Further down is the mid-pelvis. Here, the interspinous diameter narrows to 10.5 centimeters. This tight bottleneck is the most common site for clinical arrest. That bottleneck changes based on skeletal morphology. About 30% of women have an android pelvis, characterized by a heart-shaped inlet and convergent sidewalls. This geometry narrows the lower corridor, frequently locking the head in transverse arrest. Because of these walls, the exit path isn't straight. Connecting the plane centers creates the curve of Caris. This axis forces the object downward, backward toward the sacrum, then sharply forward. The mechanical design of every obstetric instrument is engineered specifically to map to this exact curved vector. Ignoring this internal geometry and applying straight, linear traction against a curved corridor forces bone against bone, causing catastrophic tissue trauma to both the mother and the fetus. The passenger, the fetal skull, must execute a highly specific sequence of spatial adjustments to fit through the changing pelvic diameters. We call these the cardinal movements of labor. Brisk, precise pace. The sequence must occur in order: engagement into the inlet, continuous descent, precise flexion to present the smallest skull profile, internal rotation to clear the mid-pelvis, extension under the pubic arch, and finally external rotation to free the shoulders. If the head fails to execute internal rotation, the sagittal suture remains caught across the transverse diameter of the pelvis. The skull locks against the bony walls. The fetal skull has a structural adaptation to survive this compression. The cranial bones are unfused, separated by sutures. Under extreme pressure, these bony plates slide over one another in a process called molding, reducing the skull's effective diameter. This cross-section reveals a diagnostic trap. The rigid skull bone is arrested midway down the pelvis at station 0, but immense pressure creates caput succedaneum, severe, localized edema of the fetal scalp. The soft tissue bulges inches below the bone, reaching station +2. A practitioner performing a vaginal exam can feel this swollen tissue and mistake it for actual bony descent, assuming the head is low enough for a safe instrumental extraction, but the bone is still trapped high in the pelvis. Precise physical palpation to distinguish bone from edema is the only defense against anatomical miscalculations. Intervening in labor requires a strict clinical justification. The most immediate is fetal distress, detected as prolonged bradycardia or late decelerations. When placental oxygen transfer fails, a countdown begins. From the moment of decision, a skilled obstetrician can complete an instrumental delivery in 5 to 10 minutes. A Category 1 cesarean section, where the mother is moved, anesthetized, and surgically opened, takes a minimum of 15 to 25 minutes. In acute fetal distress, 15 minutes is a lifetime, but that time advantage relies on the fetal head already being deep in the birth canal. If the head remains high in the pelvis, a difficult instrumental extraction takes as long as a surgical one, but adds severe mechanical trauma. Maternal physiology dictates a different timeline. The Valsalva pushing maneuver triggers a massive 3-phase cardiovascular roller coaster. Bearing down halts venous return, dropping cardiac output and spiking heart rate. Releasing the breath sends a sudden rush of blood back into the heart. A normal heart absorbs this, but a mother with mitral stenosis, pulmonary hypertension, or a dilated cardiomyopathy cannot survive that sudden preload swing. The failing heart will flood the lungs, triggering acute pulmonary edema or immediate right heart failure. In these cardiac cases, the forceps functions as a cardioprotective device. Vacuum extraction requires the mother to push. Forceps do not. The physician applies the blades and exerts the exact force needed, neutralizing the physiological stress of the second stage. By taking over the work of delivery, the instrument protects the compromised mother from life-threatening hemodynamic swings. Because of the forces involved, introducing an instrument requires meeting an unbending anatomical checklist. The first absolute prerequisite is 10 centimeters of full cervical dilation. If a rim of cervical tissue remains in front of the descending head, the forceps blades trap it against the fetal skull. When downward traction is applied, that tissue is dragged with the metal, resulting in annular tears shearing into the uterine arteries. The second prerequisite is engagement. The widest transverse diameter of the fetal skull must have already crossed the pelvic inlet. Pulling from above this line forces the largest part of the head against an untested bony ring, causing pelvic impaction. The biomechanical safe zone for application begins at station +2.
By this point, the fetal head has successfully navigated past the ischial spines, the bottleneck in the mid-pelvis. The corridor is finally widening. The operator must also have absolute certainty of the fetal skull's position. This requires palpating the exact orientation of the anterior and posterior fontanelles and tracing the sagittal suture to map how the head is rotated. Guessing the position leads to applying one blade over the forehead and the other over the mastoid bone. The resulting asymmetrical pressure fractures the skull and drives traction in the wrong geometric direction. These prerequisites are biological laws. Violating a single one turns a life-saving procedure into a source of severe mechanical trauma. The vacuum extractor operates under a specific mechanical formula. Traction force equals the pressure differential multiplied by the cup's surface area. Using maximum safe negative pressure on a standard cup generates roughly 22 kilograms of traction force. To translate that suction into a physical grip, the pressure must be built up slowly over minutes. This gradual increase pulls the fetal scalp tissue into the cup, forming a dense plug of skin called a chignon. Apply the pressure too fast, and the cup will violently pop off during delivery. But the physics of vacuum suction create an absolute contraindication for preterm fetuses delivered before 34 weeks of gestation. Beneath the ventricles of a preterm fetal brain lies the subepidendal germinal matrix. It naturally regresses after 34 weeks. Unmineralized skull bones transmit mechanical shear forces from the vacuum cup straight through, ripping this fragile matrix apart and causing massive intraventricular hemorrhage. The vacuum's physics dictate strict biological limits based on fetal tissue development, regardless of how much space exists in the maternal pelvis. This photograph shows the mechanical anatomy of obstetric forceps. Notice the fenestrations or windows in the blades. These openings allow the fetal scalp to bulge slightly outward, distributing the compressive pressure across the broad temporal bones, rather than concentrating it at a single focal point. Standard forceps use a rigid English lock, holding the blades perfectly parallel. But if the fetal head is tilted sideways, a condition called asynclitism, parallel blades will compress the skull unevenly. Kellen's forceps utilize a sliding lock, allowing the blades to offset and safely grip a tilted head. Because of the pelvic curvature, the blades cannot be inserted straight in. The operator must perform a wide, sweeping arc with the handle, wandering the blade around the maternal anatomy until it points upward and forward. Traction must align with anatomy using the Pajot-Saxtorph maneuver. Pulling outward risks pubic impact. Instead, pulling handles outward while pushing shanks downward combines these forces mathematically. This creates a resultant vector that pushes downward and backward, perfectly tracing the curve of Caris. Successful forceps delivery is a calculation of vector mechanics. It relies on geometric alignment, not physical strength. Forceps operates through lateral compression. The vacuum operates through vertical suction. These divergent physical mechanisms predict distinct profiles of tissue trauma. On the maternal side, forceps cause significantly more morbidity. Inserting metal blades into the vagina expands the total spatial diameter, pushing against the perineum. This stretching increases the rate of 3rd and 4th degree tears, rupturing the anal sphincter muscles. The most profound maternal injury often takes decades to manifest. This diagram maps the pudendal nerve roots. The rigid metal blades and rapid traction stretch and compress these nerves, weakening the pelvic floor and leading to pelvic organ prolapse years later. For the fetus, forceps carry a specific neurological risk. If the rigid toe of the blade slips over the mastoid bone, it compresses the stylomastoid foramen, crushing the exiting facial nerve. This results in neonatal facial palsy, leaving the infant unable to close one eye or move half their mouth. Vacuum extraction carries lower maternal risk, but shifts the morbidity entirely to the fetus. The intense suction force can shear the emissary veins running through the skull. Because there are no sutures to contain the bleeding, blood pours into the open subgaleal space beneath the scalp. This graphic illustrates the lethal nature of a subgaleal hemorrhage. The subgaleal space can accommodate 260 milliliters of liquid. A term neonate's circulatory volume is only about 300 milliliters. A severe vacuum injury can drain a newborn's entire blood volume into its own scalp. Choosing an instrument means calculating which specific physiological trauma profile the mother and the baby are in the best condition to survive. To present these trauma profiles, clinical failure is defined by a strict limit, the 3-attempt rule. An operator is allowed exactly 3 tractions, perfectly synchronized with contractions. If the head does not descend, the procedure is stopped. When one instrument fails, applying a second, moving from a vacuum to forceps, is contraindicated. The initial suction has already compromised the tissue. Compressing that traumatized skull with metal blades causes a compounding of force, spiking the risk of intracranial hemorrhage. When an operator is uncertain if the mechanics will align, they perform a trial of instrumental delivery.
This photograph shows the setup. The attempt is made inside a fully scrubbed operating theater. If a single pull fails, the instrument is dropped, and the surgical team begins a cesarean section within 30 seconds. But we are facing a macro-level crisis. Global training in instrumental delivery is declining. As fewer physicians learn to calculate these pelvic vectors, default cesarean rates skyrocket. Every surgical cut across a uterus increases the rate of deadly placental morbidities in future pregnancies. The mechanical violence of these tools requires explicit, informed consent from the mother regarding the risks of hemorrhage and nerve damage. Implied consent is acceptable only in the presence of acute, documented fetal bradycardia, where every second dictates survival. Clinical excellence in this field rests on the discipline to recognize when an intervention has reached its safe limit, and to abandon the attempt before causing injury.
The fundamental safety of modern obstetric surgery relies entirely on understanding the underlying biomechanics of regional uterine physiology. During labor, the upper uterine segment, the corpus, actively contracts. It is thick, densely muscular, and generates the massive downward force required to expel the fetus. In direct contrast, the lower uterine segment passively dilates. It physically thins out to allow fetal descent, carrying entirely different mechanical properties. We are going to deconstruct how this single anatomical dichotomy dictates every clinical decision in obstetrics, from incision choices and uterine rupture risks, to VBAC viability and anesthetic protocols. The structural distinction between active and passive tissue dictates the mechanical integrity of the uterus. A miscalculation here permanently elevates maternal and fetal mortality risk for all of a patient's future pregnancies. This maps the anterior abdominal wall.
The Fannin steel incision sits above the pubic symphysis. Cutting parallel to the transverse fibers maximizes strength and minimizes pain. Placed higher is the strictly straight Joel-Cohen incision, whose clinical advantage is speed. Since the subcutaneous tissue is thinner at the Joel-Cohen site, surgeons rapidly achieve blunt fascial extension, making it superior in emergent hemorrhagic scenarios. All transverse incisions share a critical limitation. They provide excellent pelvic views, but severely restrict physical access to the upper abdomen. When complex upper abdominal pathology like a high uterine rupture is anticipated, a vertical midline incision is mandatory for adequate access. Regardless of skin incision, the underlying rectus abdominis muscle must be separated bluntly with fingers. Sharp transection severs neurovascular supplies, causing severe pain. Abdominal entry techniques are a calculated compromise. Surgeons balance the biomechanical strength of a transverse wound against the speed required for access. Beneath the abdominal wall, we see the difference between the active upper and passive lower segments. The standard lower segment cesarean section uses a transverse cut targeted through this thin lower region. Because the lower segment doesn't actively contract during healing, it experiences minimal tension, allowing for robust fibromuscular tissue formation. This table maps rupture risks to their uterine segments. The LSCS risk sits incredibly low, between 0.2 and 0.9%. Conversely, the vertical classical cesarean in the active upper corpus faces constant labor stress, elevating rupture risk to 9%. Uterine rupture causes fetal extrusion into the peritoneal cavity, severe hypoxic brain injury, and catastrophic maternal hemorrhage. To preempt spontaneous labor contractions on a classical scar, any subsequent repeat cesarean is strictly scheduled at 36 to 37 weeks. Surgeons force the classical approach for cervical carcinoma, dense adhesions, vasa previa, cases of extreme prematurity, and urgent perimortem rescue. The exact location where the scalpel incises dictates the viability boundary for all future pregnancies. Clinicians distinguish between the physical attempt, a trial of labor after cesarean, or TLAC, and the successful outcome, known as VBAC. Counseling requires balancing threats. A trial of labor carries the risk of uterine rupture. Conversely, repeat elective cesareans increase the longitudinal risk of placenta accreta spectrum with every surgery. This matrix contrasts policies for 2 prior lower segment cesareans. ACOG permits case-by-case VBAC attempts, accepting a 1.8% rupture risk to mitigate placenta accreta. Indian guidelines, recognizing variable operative infrastructure, strictly mandate a repeat cesarean. This line graph maps a uterine scar's collagen remodeling. It remains mechanically weak at 6 and 12 months. Conception prior to the 18-month maturity mark forces an immature scar to withstand labor, sharply elevating rupture probability. VBAC viability relies heavily on initial surgical technique, but it equally depends on granting the body the chronological time to rebuild fibromuscular integrity. Absolute contraindications to labor include prior classical incisions, T-shaped scar extensions, upper segment myomectomies, and active cephalopelvic disproportion. The most critical contraindication is infrastructural. A trial of labor is completely unsafe without 24/7 surgical and anesthetic availability to manage a rupture. However, past issues like fetal disproportion, twin gestations, or polyhydramnios are not absolute contraindications, as they don't alter the permanent maternal pelvic geometry. The single most powerful positive prognostic factor for a successful VBAC is a prior vaginal delivery. A previous vaginal birth provides definitive mechanical proof. It confirms cervical competence, effective uterine contractility, and baseline pelvic adequacy. Conversely, prior endometritis or pelvic sepsis disrupt normal collagen formation, leaving the patient with structurally deficient fibrotic scarring that predicts a higher failure rate. During a trial of labor, continuous CTG monitoring is non-negotiable. Prolonged fetal heart rate decelerations are often the absolute earliest herald of impending scar dehiscence. Managing a VBAC means treating the scarred uterus as a volatile environment, demanding continuous surveillance and a guaranteed operative safety net. This neurological map highlights labor pain sources. Uterine contractions transmit through T10 to L1 and cervical dilation at S2 to S4. For a cesarean, surgical anesthesia must climb to the T4 nipple line to block upper abdominal peritoneal packing. The choice of anesthetic block depends on maternal hemodynamics. Spinals offer rapid onset. Epidurals allow for gradual hemodynamic titration, making them the strict preference for maternal cardiac disease or severe preeclampsia. This biomechanical cross-section reveals a term patient lying flat. The gravid uterus crushes the inferior vena cava, triggering dangerous hypoperfusion. Protocols mandate a 15-degree left lateral tilt, physically displacing the weight to restore venous blood flow. For a patient with a uterine scar, mechanical cervical ripening interventions are permitted. Pharmacological prostaglandins are strictly avoided because they induce erratic, unpredictable contractility on the vulnerable scar. Internal pedalic version, manually reaching inside to rotate the fetus, is an absolute contraindication. The direct physical force carries a catastrophic rupture risk. Operative obstetrics controls immense mechanical forces. Precise anesthesia levels and gravity manipulation are as crucial to maternal survival as the scalpel itself. The lower uterine segment becomes the ideal surgical site precisely because it thins out and ceases active contraction during healing. Driving a transverse cut through this specific passive tissue allows for maximum fibromuscular integrity, dropping the longitudinal risk of rupture to fractions of a percent. Allowing a trial of labor on that scar is never solely a clinical judgment. It is a strict calculation of the surrounding infrastructural capacity to handle an emergency. Every guideline, from the specific depth of a fan and steel incision to the exact height of a T4 epidural block, is a direct mechanical response to the physiological demands of the gravid uterus. Obstetrics relies on a precise calculation of biomechanical consequences, where a single surgical choice echoes through the rest of a patient's reproductive life. The third stage of labor occupies a deceptively brief interval in the parturientan timeline. It begins the instant the fetus is delivered, and it concludes only when the placenta and its associated membranes have been completely expelled from the uterine cavity. Although physiologically the shortest stage, it commands disproportionate clinical attention. This brief window is the origin of postpartum hemorrhage, the leading cause of maternal mortality globally. To understand why this hemorrhage occurs, we must look at the physical architecture of the uterus. This diagram shows a cross-section of the gravid uterus immediately after fetal delivery. The placental bed, located within the decidualized endometrium, is now a raw, highly vascular wound spanning approximately 30 square centimeters. Zooming into the tissue level, we see the spiral arterioles that feed this area. During pregnancy, these vessels adapt by profoundly dilating to maintain uteroplacental perfusion. Because of this adaptation, they are relatively unresponsive to typical vasoconstrictive stimuli. They cannot simply close themselves off. Instead, occlusion relies entirely on myometrial contraction and retraction. As the uterine muscle fibers shorten after delivery, they mechanically compress these spiral arterioles, acting as the living ligatures of the uterus. If this mechanical contraction is inadequate, a state known as uterine atony, or if the placenta fails to separate cleanly and prevents the muscles from fully tightening, this mechanical hemostasis fails. Exsanguination rapidly follows. This physiological vulnerability is why active management of the third stage of labor, or AMTSL, is the global standard of care. By replacing a passive 30-minute biological risk window with a deliberately orchestrated 5 to 10-minute protocol, clinicians reduce the incidence of postpartum hemorrhage by 60 to 70%. This biomechanical model of the uterine wall illustrates the mechanics of placental separation. Notice how the myometrial fibers undergo retraction, which differs from ordinary muscle contraction. The fibers do not return to their original length after each cycle. Instead, they progressively shorten and thicken, driving a cumulative reduction in the total uterine volume. The placenta, a relatively inelastic structure, cannot shrink to match the rapidly decreasing surface area of the uterine wall. This discrepancy generates intense shearing forces at the decidual interface. The separation occurs strictly along an anatomically weak cleavage plane, the loose, sponge-like layer called the zona spongiosa of the decidua basalis. Because human placentas are hemochorial and deciduate, maternal blood sits in direct contact with the trophoblast without an endothelial barrier, and the decidua itself is shed during delivery. Consequently, separation will always involve bleeding from the open spiral arterioles. As separation proceeds, blood accumulates in the space between the separating placenta and the uterine wall, forming a retroplacental clot. This clot plays an active mechanical role. The accumulating blood exerts hydrostatic pressure, actively dissecting the plane of separation further to facilitate complete detachment. There are two distinct clinical patterns for this separation. The predominant pattern, seen in 80% of cases, is the Schultz mechanism. Separation begins at the center of the placenta and progresses outward. It emerges fetal surface first, presenting the shiny, glistening amnion to the birth attendant. Because the clot forms centrally and accumulates behind the intact margins, external bleeding is minimal during the separation process. This can be misleading. The apparent absence of visible bleeding does not rule out the possibility that severe internal hemorrhage is actively occurring. The other 20% follow the Duncan mechanism. Here, separation begins at one margin and slides across the surface. The placenta delivers sideways, with the maternal surface presenting first, and because the edge opens early, blood escapes and is visible externally almost immediately. Before any clinician attempt to remove the placenta, separation must be confirmed. The three reliable signs are feeling the placenta in the vagina, observing permanent lengthening of the cord, and a firm, globular, rising uterus. Historically, expectant management allowed this process to unfold naturally, relying solely on gravity and maternal bearing down efforts without uterotonics. But this extends the third stage up to 30 minutes and yields a postpartum hemorrhage incidence 3 to 4 times higher than active management. Waiting passively exposes a massive, highly vascular bed while biological separation slowly takes its course. The priority is to accelerate occlusion, and that process demands immediate pharmacological intervention. The first component of AMTSL is the administration of a uterotonic agent. This must occur within 1 minute of fetal birth. Depending on institutional protocol, many administer it exactly at the delivery of the anterior shoulder to preempt any delays in preparing the drug. This cellular matrix visualizes the pharmacology of our options. Oxytocin is the World Health Organization's first-line uterotonic. It is a synthetic nonapeptide administered typically at 10 international units. As seen on the left, it binds to myonatrial GQ protein-coupled receptors. This triggers a pulse of intracellular calcium, producing coordinated rhythmic uterine contractions interspersed with relaxation intervals. Rapid intravenous bolus administration of oxytocin is strictly prohibited. At pharmacological concentrations, a sudden spike in plasma oxytocin triggers the release of nitric oxide in vascular smooth muscle. This causes rapid peripheral vasodilation, precipitous hypotension, reflex tachycardia, and potentially cardiac arrest. It must be given intramuscularly or via slow IV infusion. Furthermore, oxytocin shares structural homology with antidiuretic hormone. If infused continuously in large volumes of a hypotonic solution, like 5% dextrose, it causes severe water retention, leading to dilutional hyponatremia and potentially fatal cerebral edema. Only electrolyte-containing solutions, like normal saline, should be used. Now, filling the right side of the screen is an alternative agent, methyl ergometrine, typically given as a 0.2 mg intramuscular dose. This is an ergot alkaloid that acts on alpha-adrenergic and serotonin receptors in the smooth muscle. Notice the difference in the contraction. Instead of rhythmic pulses, methyl ergometrine produces a sustained tetanic spasm. It forces the lower uterine segment and cervix into a prolonged, non-relaxing contraction. Because there are no relaxation intervals, uteroplacental perfusion is completely interrupted. This makes methyl ergometrine strictly contraindicated during active labor, as it would cause fetal hypoxia. Additionally, its potent alpha-adrenergic vasoconstriction causes a sharp rise in blood pressure, completely banning it in hypertensive disorders of pregnancy and prohibiting IV administration. Syntometrine is a pre-formulated fixed-dose combination of both drugs. It delivers the rapid onset of oxytocin with the prolonged action of methyl ergometrine. However, it carries the combined contraindications of both agents and requires strict refrigeration. To address environmental constraints, carbetocin was developed. By modifying the structure into an octapeptide, it resists enzymatic degradation, drastically extending its half-life to 40 minutes. This allows for a single, heat-stable prophylactic dose of 100 micrograms to cover the entire critical hemorrhage window without needing a continuous infusion.
In highly resource-constrained community settings, misoprostol is the drug of choice. It is a synthetic prostaglandin E1 analog, administered orally or sublingually at 600 micrograms. It requires no refrigeration, though clinicians accept the trade-off of transient systemic side effects, like shivering and pyrexia. Other drugs like carboprost, dinoprostone, and tranexamic acid are excluded from routine prophylactic AMTSL. They are reserved exclusively for the treatment of established hemorrhage, or in the case of dinoprostone, for cervical ripening. Uterotonics are not interchangeable. Their precise receptor kinetics dictate the indications and the contraindications, and ultimately how safely we can compress the uterine wound without triggering systemic cardiovascular collapse. The second component of AMTSL is delayed cord clamping. Rather than severing the umbilical connection immediately, the cord remains intact to allow the physiological transfer of blood from the placenta to the newborn. At the exact moment of birth, uterine contractions actively drive blood through the umbilical vein toward the infant. Simultaneously, as the infant's lungs expand, pulmonary vascular resistance plummets, creating a physiological suction effect. Over the first few minutes, this translocates an additional 80 to 100 milliliters of blood centrally into the neonate. This volume contains roughly 40 to 50 milligrams of elemental iron. When incorporated into the infant's stores, it significantly reduces the incidence of anemia in the first year of life and provides critical hemodynamic stability that prevents complications in preterm neonates. There are, however, absolute indications where early cord clamping is required. If the neonate requires active resuscitation, suffers from birth asphyxia, or has congenital heart disease where extra volume could cause congestive failure, the cord is clamped immediately. Active maternal hemorrhage also demands immediate clamping to expedite delivery of the placenta. The protocol requires careful attention for Rh-negative mothers. This decision tree outlines the specific pathways. If the mother's indirect Coombs test is negative, she is unsensitized. The left branch applies. Early clamping is required to limit feto-maternal transfusion and prevent sensitization. But if the indirect Coombs test is positive, sensitization has already occurred. Early clamping provides no protective benefit. Following the right branch, delayed clamping is actually preferred so the neonate receives the extra blood volume to help compensate for ongoing hemolytic anemia. For HIV-positive mothers, major health organizations explicitly recommend delayed cord clamping. Maternal viral suppression via antiretroviral therapy is the dominant determinant of transmission risk. The theoretical risk of additional viral exposure is negligible compared to the systemic benefits of the transfusion to the infant. Delayed clamping maximizes the neonate's starting blood volume and iron stores, while simultaneously giving the contracting uterus the necessary time to biologically shear the placenta from the decidua.
Once the uterotonic is administered and the cord is clamped, the clinician moves to step 3, controlled cord traction, utilizing the modified Brandt-Andrews maneuver to guide the placenta out of the birth canal. This lateral cross-section breaks down the vectors of the maneuver. The clinician's suprapubic hand exerts steady counterpressure in an upward and backward direction, stabilizing the uterus and preventing it from descending. Simultaneously, the other hand applies steady downward traction on the clamped cord, adjusting to an upward-outward pull as the placenta clears the perineum. This maneuver relies on absolute prerequisites. Placental separation must be confirmed, and the uterus must be actively contracting. Applying traction to a relaxed, unseparated uterus risks acute uterine inversion. The fundus telescopes downward through the cervix, triggering massive hemorrhage and neurogenic shock. This catastrophic risk is exactly why forcible fundal pressure, historically known as Crede's maneuver, is strictly obsolete. If the cord ruptures during traction, the separated placenta is stranded in the uterine cavity. The clinician must proceed to manual removal. Any intrauterine manipulation requires general anesthesia, specifically utilizing halogenated volatile agents to achieve the profound uterine relaxation necessary to safely insert the hand. During manual extraction, the operator must physically identify the anatomical cleavage plane at the zona spongiosa. The fingers are worked progressively across the interface, using a precise peeling motion to manually detach the placenta from the decidual wall. Once extracted, the placenta is immediately inspected for structural completeness. Retained accessory lobes, resulting from sexcenturiate or bilobate configurations, will prevent complete myometrial contraction and cause persistent, dangerous bleeding if left inside the cavity. If the operator cannot develop a cleavage plane at all, they are dealing with placenta accreta spectrum, where chorionic villi aggressively invade the myometrium. In this scenario, manual removal is strictly contraindicated. Tearing through deeply invaded tissue will cause catastrophic hemorrhage, often necessitating embolization or hysterectomy. Mechanical traction is only a guiding force. It relies entirely on the biological cleavage plane having already yielded. Forcing the placenta out prematurely turns a physiological event into a lethal surgical emergency. The fourth and final component of AMTSL is systematic intermittent assessment of uterine tone. Clinicians palpate the fundus every 15 minutes to detect early signs of uterine atony, clinically identifiable as a soft, boggy mass, rather than the expected firm, well-contracted muscle. It is necessary to correct an outdated practice here. Continuous forceful uterine massage is obsolete as a routine preventative measure. Current evidence confirms it provides no additional benefit for a uterus already contracting under uterotonics. Sustained massage is now strictly a therapeutic response if atony is actively diagnosed. If the placenta remains undelivered 30 minutes after birth, it is officially classified as a retained placenta. Management depends entirely on the mechanism. Is it atony, where the placenta is separated but unexpelled? Is it trapped behind a cervix that closed prematurely due to methylorgometrine? Or is it pathological adherence, where it hasn't separated at all? This postpartum period marks the start of the fourth stage of labor. It isn't driven by a specific anatomical milestone. Rather, it is a 1 to 2 hour surveillance construct, acknowledging the immediate postpartum window as the period of highest hemodynamic instability. During this window, voiding the bladder is critical. Because of their close proximity, a distended bladder pushes the uterus laterally, mechanically impairing its ability to contract. This displacement prevents the living ligatures from closing and predisposes the patient to hemorrhage. Another phenomenon frequently seen in this window is the physiological postpartum chill, intense, uncontrollable shivering despite a normal core temperature. This is a normal reaction to sudden hemodynamic shifts and heat redistribution following delivery. It requires only reassurance and a warm blanket. It is not a sign of hypovolemic or septic shock. AMTSL functions as a precise sequence of biomechanical and pharmacological interventions, specifically engineered to rapidly shut down the most dangerous vascular bed in human physiology. Clinical studies show that visual estimation of blood loss at delivery is consistently inaccurate. Providers routinely underestimate the volume by 30 to 50%. Because an actual loss of 400 milliliters visually registers as only 200, relying on visual cues alone leads to severe maternal hypovolemia being recognized only when the patient is already crashing. This chart compares the standard volume-based diagnostic thresholds for postpartum hemorrhage. Traditional teaching sets the limit at greater than 500 milliliters for a vaginal delivery and greater than 1,000 milliliters for a cesarean, accounting for deliberate surgical bleeding. To simplify clinical response, ACOG now uses a unified threshold of greater than 1,000 milliliters, regardless of delivery mode, which aligns with the World Health Organization's cutoff for severe PPH. Looking at this line graph, we track the consequence-based definitions of hemorrhage. These capture what raw volume numbers miss. Clinically, PPH is occurring anytime bleeding requires a blood transfusion, triggers signs of hypovolemia, like tachycardia, hypotension, pallor, and low urine output, or results in a 10% or greater fall in hematocrit from admission to postpartum. The timing of these symptoms divides the diagnosis mechanically. Primary PPH occurs within the first 24 hours of delivery. Secondary PPH strikes between 24 hours and 12 weeks postpartum, presenting an entirely different set of physiological failures. Rigidly following standard volume thresholds can directly cause maternal decompensation. A woman entering labor severely anemic possesses a reduced hemoglobin reserve. For her, a 400 milliliter loss, a volume easily tolerated by a healthy patient, pushes her into symptomatic shock. Her physiological threshold for clinical hemorrhage is vastly lower than the textbook number. To stop the bleeding, we have to isolate the anatomical source. During late pregnancy, the spiral arteries deliver an immense 500 to 800 milliliters of blood per minute directly to the intervillous space. When the placenta separates, those vessels are left open like cut pipes. The body's defense is located in the middle myometrial layer. Unlike standard smooth muscle, the fibers here form an interlacing crisscross arrangement. The maternal spiral arteries thread directly between these muscular meshes, rather than running alongside them. When the myometrium contracts vigorously after placental delivery, these fibers shorten in multiple directions simultaneously. This is the living ligature. It provides immense, multidirectional mechanical compression of the vessel walls, pinching off that massive arterial flow from all sides. This means postpartum hemostasis is driven by the physical architecture of the contracting uterus, rather than the standard biochemical coagulation pathways that seal wounds elsewhere in the body. We categorize these failures using the 4 T's diagnostic matrix. The most common cause of primary postpartum hemorrhage, by a vast margin, is tone, specifically uterine atony. Atony occurs when the living ligature fails to maintain a sustained contraction. The myometrial mesh relaxes, the physical compression vanishes, and the spiral arteries resume bleeding freely into the uterine cavity. Mechanical factors drive this failure. An overdistended uterus, caused by twins, polyhydramnios, or macrosomia, loses its elastic recoil. Prolonged labor exhausts the myometrial energy reserves. Even a full bladder acts as a physical displacement, blocking the uterus from closing inward. Pharmacological and pathological disruptors play a role too. Chorioamnionitis impairs contractility through inflammatory mediators. Tocolytics and halogenated general anesthetics actively relax the muscle, while fibroids and placenta previa disrupt the contractile architecture at the implantation site. Traumatic PPH is identified when a firm, well-contracted uterus continues to hemorrhage. If the uterus is tight, the living ligature is working, which means the bleeding originates structurally from the lower tract. These traumatic sources include perineal and vaginal lacerations, cervical tears, typically at the 3 and 9 o'clock positions where uterine artery branches run, and full-thickness uterine rupture. Instrumental deliveries and macrosomia also risk shearing paravaginal or retroconcealed hematomas. Isolating the physical character of the uterus dictates the immediate response. A boggy uterus demands chemical stimulation of the myometrium, while a firm uterus requires immediate surgical repair of the lacerated tissues. The third quadrant maps thrombin, or coagulopathy. Even a perfectly contracted uterus cannot achieve complete hemostasis if the intrinsic fibrin and platelet clotting cascade fails to cross-link and seal the microscopic vascular defects. Obstructed coagulopathy has specific triggers. Placental abruption releases thromboplastin from retroplacental clots. Amniotic fluid embolism and prolonged fetal demise trigger disseminated intravascular coagulation. Severe preeclampsia destroys platelet function, and rapid crystalloid fluid resuscitation actively dilutes whatever clotting factors remain. A global failure of the coagulation cascade manifests as systemic oozing. Beyond the uterine hemorrhage, blood will weep continuously from IV cannula insertion sites, the gums, and fresh needle punctures. The final T is tissue, retained products of conception. This is the primary driver of secondary PPH. Fragments like a second-teriot lobe or abnormally adherent placenta accreta remain anchored inside the uterus long after delivery. These fragments create a physical conflict. The retained tissue acts as a wedge, preventing full uterine involution and forcing the muscle into cyclical, ineffective partial contractions. Simultaneously, the fragment keeps its specific section of the placental bed highly vascularized and raw. The treatment is uterine evacuation, typically a postpartum DNC. But the postpartum uterus is soft, thin, and engorged with blood. Instrumentation carries a severe risk of perforating the wall or denuding the cavity, causing Asherman syndrome, where the healing walls fuse together in dense intrauterine adhesions.
Secondary PPH is almost always a structural problem. Retained placental tissue chronically overrides the living ligature until the obstruction is physically removed. To prevent these failures, clinicians use active management of the third stage of labor. By deploying prophylactic uterotonics like carbidocin, controlled cord traction, and immediate massage, providers artificially compress the vulnerable bleeding phase that exists between fetal delivery and placental separation. When hemorrhage is established, the pharmacological response begins with oxytocin. This nonapeptide, synthesized in the hypothalamus, binds directly to G-protein-coupled receptors. This initiates an IP3 cascade, flooding the cell with intracellular calcium to activate myosin light chain kinase and drive contraction. Oxytocin has strict administration rules. Its rapid 3 to 5 minute half-life requires continuous IV infusion for a sustained effect. A rapid IV bolus will cause severe vasodilation and fatal hypotension. Furthermore, infusing it in 5% dextrose triggers water intoxication because oxytocin shares a structural similarity with antidiuretic hormone. Next is methyl ergometrine. Derived from the ergot fungus, it acts on alpha-adrenergic and serotonin receptors. Instead of rhythmic pulsing, it causes a powerful, sustained tetanic contraction. It is dosed at 0.2 milligrams IM and must be stored in brown ampules to prevent rapid phototoxic degradation. Because it forces massive systemic vasoconstriction and shifts 500 milliliters of blood back into central circulation, methyl ergometrine is strictly forbidden in IV form and absolutely contraindicated in patients with hypertensive disorders, HELLP syndrome, or heart disease. It is also never used during the active management of the third stage because that tetanic clamp will trap the undelivered placenta behind the cervix. Misoprostol is a PGE1 analog. It is unique because it comes as a room-temperature stable tablet. Endorsed by the WHO at 800 micrograms sublingually for hemorrhage, it bypasses the need for cold storage or IV access. However, prostaglandins are highly pyrogenic, guaranteeing side effects of hyperthermia and violent shivering. Unlike other prostaglandins, misoprostol acts as a bronchodilator, making it safe for asthmatics, but it is strictly contraindicated in patients with a prior uterine scar because it causes rapid tachysystole that can rupture the old surgical line. Finally, carboprost, a synthetic analog of prostaglandin F2 alpha. This is the gold standard uterotonic agent, dosed at 250 micrograms IM. It powerfully stimulates intestinal smooth muscle, causing severe diarrhea. More importantly, it triggers intense bronchoconstriction. Carboprost is absolutely contraindicated in patients with asthma, pulmonary hypertension, or amniotic fluid embolism. Managing hemorrhage requires exact pharmacology. Administering uterotonics is not a generic checklist. It requires meticulously matching receptor pharmacodynamics against the patient's existing cardiopulmonary comorbidities. In practice, hemorrhage protocol operates on a strict multi-track rule. Clinicians must simultaneously resuscitate the patient's hemodynamics while aggressively escalating the diagnosis through these 8 concentric rings of intervention. Ring 1 is resuscitation. Insert 2 large-bore 14 or 16-gauge IVs to maximize flow physics. Immediately initiate 1,000 milliliters of crystalloids, cross-match blood, and place a catheter with a urometer to track end-organ perfusion. Ring 2 is diagnosis. Perform an active perabdominal massage. If it firms up, look for lower tract trauma. If it remains boggy, suspect atony. Before pushing drugs, do a vaginal exam to inspect the placenta for missing cotyledons, ruling out retained tissue. Ring 3 is medical management.
Initiate continuous bimanual massage. Administer 1 gram of IV tranexamic acid, strictly within the 3-hour efficacy window, and deploy your targeted uterotonics. If drugs fail, move to Ring 4, mechanical tamponade. Insert a Bakri balloon and fill it to its 500 milliliter maximum capacity. This imposes direct, outward hydrostatic internal pressure against the open venous sinuses of the placental bed. When biochemical signaling fails to contract the muscle, these medical and mechanical interventions work synergistically to artificially recreate the lost compressive force of the living ligature. Ring 5 is operative compression. If the balloon fails, surgeons place a B-Lynch suture. This requires bivalving the uterus to physically brace and compress the anterior and posterior walls together with heavy suture material. A Heyman suture achieves similar compression but avoids the uterine incision entirely. Ring 6 is stepwise devascularization. Surgeons bilaterally ligate the uterine arteries using O'Leary sutures, which carries a 75% success rate. If bleeding persists, they cut the collateral supply by ligating the anastomotic branches of the ovarian arteries. The non-surgical alternative at this stage is uterine artery embolization via interventional radiology. It preserves fertility but requires highly specialized equipment and stable hemodynamics. Ring 7 is internal iliac ligation. This is a highly demanding surgical procedure that targets the anterior division of the internal iliac artery. Successfully tying it off drops the pelvic pulse pressure by 85%, converting pulsatile arterial bleeding into a low-pressure venous flow that permits clotting. Ring 8 is the definitive, irreversible step, hysterectomy. Subtotal or supracervical hysterectomy is mandated here. It is significantly faster and completely avoids dissecting the cervico-vaginal junction, thereby protecting the ureters from accidental severing in the blood-filled surgical field. Removing the uterus eliminates the primary bleeding site, but the protocol doesn't end there. The patient requires immediate ICU admission. To definitively tamponade the residual systemic oozing caused by the resultant coagulopathy, surgeons pack the raw pelvic floor with parachute pressure packs until the intrinsic clotting factors can recover.
Immediately after a baby is delivered, the uterus empties and its muscular wall rapidly shrinks, causing a sudden, drastic reduction in its internal surface area. The placenta, however, is relatively inelastic. It cannot shrink at the same rate. This severe size mismatch forces the rigid placental mass to physically shear away from its attachment to the uterine wall. Once detached, uterine contractions squeeze the placenta off the underlying decidua bassalis, compressing it downward into the lower segment, where it can be expelled by gravity and bearing down efforts. Clinically, this process has a strict 30-minute threshold. If the placenta remains inside the patient at minute 31, it is defined as a retained placenta. Exceeding this 30-minute limit causes the risk of postpartum hemorrhage to rise steeply. Every minute the placenta occupies the placental tud is a minute the uterus cannot contract completely to clamp down and seal off the exposed spiral arteries. There are 2 mechanical causes for a retained placenta, and they dictate opposite management protocols. The first is type A, the trapped placenta. Here, the biological shearing mechanism was successful, but a physical obstruction prevents expulsion. Uterotonics given to reduce blood loss can contract the uterine body around the detached placenta, while the internal os paradoxically snaps shut, imprisoning it. Separation is confirmed by 4 signs: a gush of blood, rising uterine height, a firm suprapubic bulge, and umbilical cord lengthening. If these signs are present but the placenta remains trapped, the management logic requires clearing the mechanical path. Empty the bladder to remove spatial displacement. If the uterus is tightly contracted, administer a relaxant to open that internal os before proceeding with manual removal under anesthesia. Type B is the non-separated placenta. In this scenario, the attachment is physiologically normal, but the biological shearing process failed to complete. Because the placenta is still attached, you will observe a complete absence of those separation signs, and the uterus will feel soft and boggy. The management here is to stimulate the shearing process. Administer oxytocin combined with controlled cord traction. If traction fails, or if the umbilical cord snaps, you proceed directly to manual removal. Clinical signs of separation are the definitive pivot point. They dictate whether a physician must pharmacologically relax the uterus
or stimulate it to force detachment. When the placenta abnormally invades the uterine wall, we look at the placenta accreta spectrum, or PAS. Without the protective nidobux layer, invasive trophoblasts dig directly into the myometrium. In 75 to 80% of cases, superficial attachment is classified as placenta accreta. Deeper penetration is increta. Pushing entirely through the serosa into adjacent organs like the bladder is percreta. The pathological consequence of this unregulated invasion is the complete absence of a cleavage plane between the placenta and the uterus. The risk factors for PAS all trace back to prior damage to the endometrial-myometrial interface. A patient with multiple previous cesareans combined with placenta previa faces an exponential risk, as the placenta implants directly over scar tissue lacking proper decidualization. On ultrasound, this pathology typically presents with a heterogeneous, moth-eaten appearance. This irregular echo texture results from disrupted tissue architecture from abnormal vascular invasion. You will also see placental lacunae, large hypoechoic spaces showing turbulent, high-velocity flow on Doppler imaging. These are disordered, chaotic vascular channels created when trophoblasts invade it to myometrial blood supply. Additionally, the normal dark subplacental hypoechoic zone disappears entirely because the decidua is absent. If the bright white line between the bladder and the uterine serosa appears interrupted or thinned, the invasion has reached the percreta stage. The definitive management for PAS is a caesarean hysterectomy. The surgeon delivers the fetus via an incision placed far from the placenta, usually at the fundus, and leaves the placenta completely in situ. Attempting to manually remove a placenta that lacks a cleavage plane will tear directly into the enormously distended myometrial vasculature. Extracting the uterus completely intact with the placenta still attached inside is the only mechanical way to prevent fatal, uncontrollable hemorrhage. Uterine inversion occurs when the fundus collapses inward, turning the entire organ inside out. This is anatomically distinct from a uterine prolapse, where the organ descends but remains right side out, leaving the cervical os clearly visible.
The primary biomechanical cause is premature cord traction. Pulling the umbilical cord before separation from a relaxed fundus forces the top of the uterus to cave inward and drag down through its opening. The severity is classified by degrees, using the vaginal introitus as the primary anatomical reference point to track how far the inverted fundus has descended. Inversion triggers a unique biphasic shock profile. Phase 1 is neurogenic. The physical inversion stretches the parasympathetic nerve bundles running alongside the uterus, triggering immediate, massive vasodilation and bradycardia. Phase 2 is hemorrhagic. An inverted myometrium loses its structural alignment and cannot contract properly. This leads to uninhibited bleeding from the open placental bed, driving blood pressure down and causing subsequent tachycardia. On physical exam, you will find a pathognomic cup-like depression on the patient's abdomen where the fundus used to be, and a smooth globular mass inside the vagina with no identifiable cervical os. The critical first step in management is the immediate cessation of all oxytocin. You must prevent the cervical ring from tightly constricting around the inverted tissue before it can be manually repositioned. Manual reduction follows Johnson's method logic. The part that inverted first must go back last. Upward pressure is applied to the lower uterine segment first, pushing the outer cervical edges up through the vagina, saving mesenchymal fundus for the final push. If manual reduction fails, pharmacological relaxants like terbutaline can loosen the cervical ring. If that fails, surgical interventions like the Huntington or Haltane methods are required to manually uninvert or cut the constriction ring from the abdomen. Under no circumstances should the placenta be removed before successful uterine reduction. Because the inverted uterus lacks the required geometric alignment to contract and mechanically occlude its open sinuses, detaching the placenta before repositioning converts a mechanical crisis into a catastrophic, untreatable hemorrhage. Amniotic fluid embolism requires a distinct physical trigger, a structural breach in the maternal-fetal interface, occurring when endocervical veins tear or uterine venous sinuses open. This breach creates a pathway for amniotic fluid to enter the maternal circulation, carrying fetal squamous cells, tissue factor, prostaglandins, and foreign fetal antigens directly toward the lungs.
When this material hits the pulmonary vasculature, it triggers a sudden systemic collapse. Phase 1 is cardiorespiratory. The fetal debris and prostaglandins provoke intense pulmonary vasospasm. The pulmonary capillaries forcefully constrict, causing a massive backup of pressure that rapidly induces right ventricular failure and acute cor pulmonale. Concurrently, foreign antigens trigger a systemic immune reaction and distributive shock. Phase 2 is hematological. High concentrations of fetal tissue factor trigger DIC. Massive systemic clotting occurs simultaneously, instantly consuming the patient's entire supply of coagulation factors. The paradox of DIC is that once those clotting factors are depleted, the patient begins to bleed diffusely and uncontrollably from every open surface, most notably the massive, unsealed uterine vascular bed. There is no real-time confirmatory test for AFE. It is a strictly clinical diagnosis based on a rapid triad: sudden cardiovascular collapse, profound hypoxia, and consumptive hemorrhage from DIC. This makes AFE highly treacherous to identify. Because the primary lesions are pulmonary and immunological, an obstetrician examining the pelvis will likely find a perfectly normal contracted uterus, while the patient undergoes fatal cardiorespiratory collapse. This diagnostic matrix shows core criteria for identifying postpartum shock. For primary postpartum hemorrhage, shock is proportionate to the heavy bleeding. For uterine inversion, initial cardiovascular collapse is radically disproportionate, presenting with an absent fundus. Amniotic fluid embolism is defined by sudden, severe respiratory distress. Because the necessary venous pathways are only open during labor or immediately postpartum, AFE occurs within 30 minutes of delivery. If cardiovascular collapse happens hours later, AFE can largely be ruled out, as the entry points in the uterus have long since contracted and closed. Applying standard hemorrhage treatments, like administering uterotonics or pulling on the cord, will exacerbate a trapped placenta and prove fatal in cases of an unreduced inversion or an invasive placenta accreta. Mastering obstetric emergencies requires moving entirely beyond memorized symptom checklists. It demands a real-time, absolute understanding of the underlying biomechanics and pathophysiology causing the collapse. To understand a postpartum hematoma, we have to look at the fluid mechanics of a contained hemorrhage. When intense intrapartum shearing forces disrupt blood vessels, the blood doesn't always drain externally. Instead, it is forced under high pressure into tightly bounded geometric planes and closed anatomical spaces. This typically happens in one of two ways. Traumatic instrumental deliveries with forceps apply compressive forces that stretch tissues far beyond their elastic limits. Alternatively, precipitate labor, a delivery lasting less from 3 hours, forces the fetal head rapidly through the pelvis. This eliminates the time required for tissue accommodation, instantly tearing vessels before they can stretch. Looking at a pelvic vascular model, we can trace the internal pudendal artery from the anterior division of the internal iliac artery, down through the sciatic foramina and into the pudendal canal. Disruption along this pathway produces a vulvar hematoma. Because this arterial network is embedded within the ischiorectal fossa, the escaping blood meets rigid walls of bone and fascia. The resulting rise in compartment pressure creates a tense, intensely painful mass with bluish discoloration visible through the thinned skin. Vaginal hematomas, by contrast, involve the vaginal artery. The vaginal walls have considerable submucosal laxity to allow for distension during childbirth. But this compliance means a massive volume of blood can pool into the paravaginal tissue planes before any swelling is visible on examination. As this paravaginal blood volume expands medially, it directly compresses the adjacent urethra or bladder neck. This structural compression causes sudden urinary retention. Because the anatomy dictates that these hematomas are physically contained, the visible bleeding heavily underestimates the actual volume of hemorrhage. Unrelenting pelvic pain and an inability to void are the true early warning signs of an expanding hematoma. The most dangerous variant is the broad ligament hematoma. This is a retroperitoneal hemorrhage originating from disrupted branches of the uterine artery deep within the parametrial tissue. It is caused by 3 specific mechanical failures: a tear that extends upward from the cervix, a tear extending upward from the vaginal wall, or colporexis, a near circumferential separation of the cervix from the vagina that shears the parametrial vasculature. The loose areolar connective tissue inside the broad ligament offers zero mechanical resistance to fluid expansion. A patient can bleed massively into this intraperitoneal space without a single drop of blood escaping externally. This establishes an unambiguous clinical rule. If a postpartum patient develops tachycardia, hypotension, and shock that is disproportionate to visible blood loss, a broad ligament hematoma must be immediately excluded. Management relies entirely on the stability of the mass. Small, stable hematomas under 5 centimeters are managed conservatively. Ice packs induce local vasoconstriction, and over a period of weeks, macrophage-mediated resorption naturally clears the organized clot. However, if the hematoma is larger than 5 centimeters, rapidly expanding or causing hemodynamic instability, surgical management is mandatory. The cavity is opened, the clot evacuated, the bleeding vessel ligated, and the remaining dead space is tightly obliterated using mattress sutures. For large retroperitoneal broad ligament bleeds that cannot be safely exposed via vaginal surgery, interventional radiology is used to embolize the uterine artery. In the most severe cases, an exploratory laparotomy with internal iliac artery ligation is the definitive life-saving option. The decision to observe or operate comes down to a simple physiological race: whether the specific fascial compartment can successfully tamponade the bleeding on its own before the patient's cardiovascular system collapses. During a vaginal delivery, peak intrapartum strain can overwhelm the elastic limits of the pelvic floor, causing sequential mechanical failure of progressively deeper tissue planes. We classify these perineal tears by anatomical depth. A first-degree tear disrupts only the superficial skin and vaginal epithelium. A second-degree tear extends deeper into the perineal body musculature, specifically the bulbospongiosus and transverse perineal muscles, but leaves the anal sphincter intact. Third-degree tears breach the sphincter complex and are subclassified by the depth of external anal sphincter involvement. A 3A tear disrupts less than 50% of the external sphincter. A 3B tear disrupts more than 50%. A 3C tear completely divides the external anal sphincter, stopping just short of the internal anal sphincter. A fourth-degree tear is a complete structural failure. The injury extends straight through both sphincters and breaches the rectal mucosa, creating an open communication between the perineum and the rectal lumen. Both sphincter muscles are required for continence. The smooth muscle of the internal sphincter provides 70 to 80% of tonic resting pressure, while the striated external sphincter provides voluntary squeeze. If either layer is left compromised, the patient faces lifelong fecal incontinence. The grading system exists to prevent exactly that. It is an immediate triage tool, dictating whether a tear can be sutured at the bedside under local anesthesia, or if it demands regional anesthesia and a senior consultant in an operating theater. Preventing severe tears requires altering how mechanical load is distributed across the perineum. Antenatal perineal massage works by applying deliberate mechanical stress over weeks, which incrementally stretches collagen fibers and increases the tissue's extensibility. Similarly, applying warm compresses to the perineum during crowning raises the tissue temperature. Heat increases the viscoelastic compliance of collagen-rich structures, allowing the perineal body to stretch further before hitting its mechanical failure threshold. At the moment of delivery, guarding the perineum with a hand distributes the localized distension force over a wider surface area. At the same time, manually maintaining fetal head flexion ensures that the absolute smallest presenting diameter, the 9.5 centimeter sub-occipital bregmatic, is what actually traverses the perineal ring. This matters because the relationship between fetal head diameter and perineal strain is not linear. Allowing the head to extend prematurely increases the presenting diameter by just 1 or 2 centimeters, but causes the circumferential tension on the perineum to multiply dramatically. Because controlled distension is the goal, the WHO firmly recommends against applying fundal pressure to accelerate delivery and rejects the practice of routine episiotomies. Both of those practices forcefully bypass the tissue's natural resistance. Effective prevention relies entirely on increasing the viscoelastic limits of the tissue and slowing the delivery of the fetal head to allow for microaccommodation. An episiotomy is not a preventative measure. It is a highly selective surgical incision reserved for moments when the perineum itself becomes a clinical obstacle to a safe delivery, such as shoulder dystocia, a rigid perineum, or the requirement of forceps. The geometry of the incision determines its risk profile. A midline episiotomy cuts directly along the central raphe. It bleeds less and is easier to repair. But if rapid delivery forces that incision to extend, the vector points directly into the anal sphincter, risking iatrogenic 3rd or 4th degree tears. To neutralize this risk, most contemporary practice utilizes a mediolateral episiotomy. The cut is directed 45 to 60 degrees laterally. As unexpected tension forces the incision to extend, the energy tracks safely into the medial thigh musculature, completely avoiding the sphincter complex. This angle is a calculated trade-off. A mediolateral cut crosses more vascular tissue, requires a much more complex layered repair, and yields higher rates of postoperative pain. Obstetricians accept the increased bleeding and structural complexity of the lateral cut because its geometric vector definitively protects the patient's continence mechanism. Structural tear does occur. The escalation protocol is immediate. 3rd and 4th degree tears must be repaired by a senior consultant in an operating theater under regional or general anesthesia. The timing of the repair is dictated by the 24-hour rule. Primary repair must be executed within 24 hours of delivery, a window where tissue planes are clearly defined, and bacterial colonization is low enough to permit closure. If a tear is recognized past the 24-hour mark, the tissue is highly edematous and heavily colonized by bacteria. Attempting primary closure guarantees infection and wound breakdown. The correct protocol is to delay definitive repair for 3 to 12 weeks to allow complete resolution of acute inflammation. When surgery proceeds, the reconstruction sequence is strictly deep to superficial. In a 4th degree tear, the deepest layer, the rectal mucosa, is closed first. Fine absorbable sutures are placed in the submucosa to achieve a watertight seal, instantly stopping fecal contamination of the surgical field. Step 2 requires independent identification of the internal anal sphincter, a distinct glistening band of smooth muscle, which is approximated with fine absorbable sutures in an end-to-end fashion. Next, the striated bundles of the external anal sphincter are grasped with forceps. These ends are joined in either an end-to-end or overlapping anastomosis using a heavy, long-lasting, permanent or synthetic suture. The knot must hold firm apposition without strangulating the dynamic muscle fibers, ensuring adequate blood supply. Only once this deep foundation is fully secure does the surgeon move superficially, closing the vaginal mucosa, the perineal body musculature, and finally the skin. Attempting to close superficial skin over an unrepaired deep defect leaves empty dead space. This allows ongoing internal hemorrhage and guarantees the functional collapse of the pelvic floor. The physical material holding this reconstruction together dictates how it will heal. Traditional chromic catgut has largely been replaced by synthetic absorbable sutures like polyglactin 910. Synthetic threads provoke far less inflammatory tissue reaction and reliably hold their mechanical strength through the critical first 21 days of wound healing. The exact configuration of the suture is just as critical as the material. The perineum undergoes constant dynamic loading from walking, sitting, and pelvic muscle activity. A standard simple interrupted suture concentrates all that tension at 2 tiny entry points. Over time, this creates a cheese wire effect, cutting through the tissue and causing the wound edges to invert. To prevent this, surgeons utilize the mattress suture. This configuration requires 2 passes. The first pass is wide and deep, crossing beneath the full depth of the wound to mechanically draw the deeper fascial planes together. This obliterates any hemorrhagic dead space. The needle is reversed for the second pass, which runs superficially just beneath the skin surface, locking the loop and uniformly distributing the closing tension across a much wider structural footprint. This dual-pass geometry naturally forces wound edge eversion, a slight outward turning of the tissue. Eversion maximizes the contact area between the opposing dermal layers, allowing the closure to withstand intense downward shear stress. The mattress suture is an exercise in biomimetic engineering. It simultaneously neutralizes external dynamic loads from above while sealing off hemorrhagic cavities from below. Resolving complex pelvic trauma requires exact anatomical knowledge. The surgeon must decode the hidden biomechanical forces applied during delivery and meticulously rebuild the structural integrity of the pelvic floor, layer by layer. During the third stage of labor, the uterus violently contracts to expel the placenta, immediately clamping down into a firm, compressed structure below the umbilitus. This initiates the puerperium, a period defined by an immediate drop in systemic hormones and the beginning of massive tissue regression. The postpartum period is an active, highly controlled state of multi-system physiologic reversal. Tracing the mechanics of this reversal provides a framework for identifying the anatomical origins of postpartum complications. Analyzing this process requires a systemic approach. We begin in the pelvis, observing myometrial involution and infection vulnerabilities. We then track the reactivation of the neuroendocrine axis, the decay of clotting parameters, and finally, mechanical trauma to the obstetric neuromuscular system. Life-threatening postpartum pathology is rarely a random event. It is the clinical result of these specific reversal mechanisms failing or being exploited by pathogens. The immediate mechanical priority of the third stage of labor is simultaneous expulsion and hemostasis. Powerful uterine contractions expel the placenta, while physically clamping the severed blood vessels that fed it. If the uterine muscle remains soft, a condition known as atony, those unclamped vessels bleed freely into the uterine cavity. Uterine atony is the leading cause of postpartum hemorrhage. The tissue's physical firmness is a life-saving reflex. Despite this initial contraction, dramatic size reduction does not occur in the first 24 hours. The tissue remains saturated with residual edema, and the hormonal shifts that trigger regression require time to reach cellular thresholds. Once regression accelerates, it relies on a cellular mechanism called autolysis. During pregnancy, the uterus grows through both hypertrophy and hyperplasia. Autolysis reverses the hypertrophy. It shrinks the size of individual muscle fibers using protease enzymes to digest excess intracellular protein. The breakdown products from millions of regressing muscle fibers are absorbed into the bloodstream and filtered by the kidneys. This cellular digestion results in elevated nitrogen levels in postpartum urine. This timeline tracks the physical descent and weight reduction of the involuting uterus over a 4-week period. Immediately after delivery, the fundus sits just below the umbilicus, weighing approximately 1,000 grams. From day 2 onward, autolysis drives a predictable regression rate. The fundus descends at approximately 1 finger breadth, or 1.25 centimeters per day, eventually returning to its baseline weight of roughly 100 grams. This rate varies by parity. Multiparous women possess a larger baseline uterus from repeated cycles of growth and incomplete regression, causing their involution to proceed more slowly than primiparous women. While the intact basal layer of the endometrium regenerates rapidly under estrogen influence, the site of placental detachment behaves differently. The deep trophoblastic invasion required for placental anchoring leaves behind a denuded wound that relies on slower ingrowth from the surrounding tissue margins to heal. This healing disparity establishes the pathogenesis of postpartum endometritis. The open placental bed serves as the primary anatomical target for polymicrobial bacteria, including anaerobes, group B Streptococcus, and E. coli, ascending from the lower genital tract. Cesarean section introduces a highest risk for this infection. The procedure bypasses the cervix and introduces bacteria directly into the uterine cavity, while devitalized tissue at the surgical incision creates an ideal culture medium. The clinical triad of endometritis, fever, subinvolution, and foul lochia is the direct result of this bacterial colonization. The systemic inflammatory response actively disrupts autolysis, preventing the inflamed uterus from properly contracting. Simultaneously, the hematologic system remains in a hypercoagulable state. Elevated levels of clotting factors persist from pregnancy, while natural anticoagulants like protein S remain suppressed, maintaining a high risk for thrombosis. When endometritis is severe, ascending bacteria migrate beyond the uterine cavity and invade the walls of the deep pelvic veins. This vascular invasion, combined with systemic hypercoagulability, triggers the localized formation of a dense fibrin clot around the bacterial clusters. This creates septic pelvic thrombophlebitis. The organized fibrin clot acts as a physical shield. Intravenous antibiotics circulate in the bloodstream but cannot penetrate the dense thrombus to reach the trapped bacteria. Because the pathogens are physically sheltered, patients will continue to spike high fevers 48 to 72 hours after beginning broad-spectrum antibiotic therapy for endometritis. The clinical solution is the empiric administration of heparin. Heparin does not kill bacteria. Instead, it prevents further clot propagation, arresting the growth of the shield. With the clot stabilized, the body's endogenous fibrinolytic enzymes begin to dissolve the existing thrombus. As the physical barrier breaks down, the bacterial mitis is finally exposed to the circulating antibiotics. The fever resolves, and the diagnosis is confirmed by the patient's clinical response. Treatment duration depends on radiographic evidence. If suspected clinically without imaging confirmation, heparin continues until the patient is afebrile for an additional 48 hours. If the thrombus is confirmed radiographically, therapeutic anticoagulation continues for 6 weeks. Septic pelvic thrombophlebitis illustrates how an anatomical infection hijacks maternal hypercoagulability, a normal physiological failsafe, to construct a drug-resistant sanctuary within the deep veins. This graph illustrates the immediate endocrine consequence of expelling the placenta, a sudden drop in maternal estrogen and progesterone levels. During pregnancy, these hormones suppress the hypothalamus. Once the placenta is delivered, this negative feedback is lifted. The hypothalamus resumes rhythmic pulses of GnRH, which drive the pituitary to release FSH and LH, reactivating the ovaries. Breastfeeding can delay this reactivation through lactational amenorrhea. The suckling reflex stimulates prolactin release from the anterior pituitary, and prolactin directly suppresses GnRH pulsatility at the hypothalamus. However, this suppression is dose and frequency dependent. As an infant begins sleeping longer or taking supplemental feeds, the suckling frequency decreases, prolactin levels dip, and ovulation can return. Because ovulation precedes menstruation, a woman can release an egg and conceive before her first postpartum period. Relying solely on lactation as contraception carries a 4% annual failure rate. The clinical rule of 3 governs the timing of contraception. For non-breastfeeding women, ovulation can return as early as 28 days. Initiating contraception at 3 weeks provides a buffer before that earliest possible ovulation window opens. For fully breastfeeding women, contraception is initiated at 3 months. This aligns with the typical introduction of supplementary feeds and the corresponding drop in prolactin levels. The choice of contraceptive agent is governed by the patient's physiological state. Estrogen-containing oral contraceptives are avoided early postpartum because exogenous estrogen suppresses milk production and upregulates the synthesis of clotting factors. Introducing exogenous estrogen into a hypercoagulable patient creates a risk for deep vein thrombosis and pulmonary embolism. Combined oral contraceptives remain contraindicated until at least 21 days postpartum. The postpartum transition routinely produces physiologic mimics, normal systemic responses that resemble infectious pathology. For example, the release of cortisol and catecholamines during labor triggers demargination. These stress hormones cause white blood cells, normally adhered to the interior walls of blood vessels, to detach and surge into active circulation. Combined with the mechanical trauma of delivery, this can elevate a white blood cell count to 30,000 without infection. Clinicians must correlate this finding with the absence of fever and uterine tenderness to rule out endometritis. Similarly, around postpartum day 3, milk production causes localized stasis. This triggers a bilateral inflammatory response and a brief low-grade fever. It must be differentiated from mastitis, which presents as a severe unilateral infection. Beyond systemic mimics, the mechanical forces of labor can exert trauma on the obstetric neuromuscular system, compressing peripheral nerves. 2 primary sites of vulnerability result in postpartum foot drop. The common peroneal nerve wraps around the fibular head, exposing it to compression when legs are positioned in stirrups. Higher up, the fetal head can compress the lumbosacral trunk against the inner rim of the pelvis. Injury at either of these anatomical points impairs dorsiflexion, causing a compensatory steppage gait to prevent tripping. Most of these injuries are neuropraxias. The nerve tissue is structurally intact but temporarily non-functional due to the compressive force, typically recovering over several weeks. This master timeline tracks the 3 simultaneous transitions defining the 6-week postpartum window: the mechanical autolysis of the uterus, the reactivation of the endocrine axis, and the decline of systemic hypercoagulability. Clinical mastery during the puerperium requires identifying the underlying biological mechanisms behind superficial symptoms. Subinvolution is recognized as failed cellular autolysis, persistent fever as a protected thrombotic nidus, and elevated white counts as a transient stress response. Anchoring clinical logic in these physiological mechanisms makes the systemic disruptions of the postpartum period predictable and manageable.
Operating inside the female reproductive tract requires navigating a highly constrained, dynamic environment. To access the deep pelvic spaces, a surgeon must bypass the muscular vaginal walls, safely navigate the narrow cervical canal, and account for the extreme vascular and physiological changes introduced by pregnancy. Because of these strict anatomical boundaries, standard surgical tools often fail here. Every speculum, dilator, and curette used in obstetrics and gynecology represents a specific, engineered solution to a distinct anatomical problem. We can organize this dense armamentarium of steel into 5 operational categories: gaining exposure, holding tissue, dilating the canal, evacuating contents, and achieving hemostasis. These microstructural differences serve as the primary safeguard against surgical morbidity. A few millimeters of curvature or a specific tooth pattern can be the only thing preventing a massive hemorrhage or a pierced uterine wall. To gain exposure, we first have to bypass the vaginal walls. The Sims double-bladed speculum achieves this using asymmetrical blade widths. There is a prominent groove in the blade that retracts the posterior wall while channeling vaginal discharge away from the operative field. The instrument is non-self-retaining, meaning it cannot hold its own position and requires an assistant. However, it holds a critical safety application. In cases of premature rupture of membranes, where standard digital exams are strictly contraindicated, a sterile Sims speculum can be inserted safely. If amniotic fluid leaks past the external os when the patient coughs, rupture is confirmed. The instrument's creator, James Marion Sims, is recognized in a trio of historical eponyms known as the Sims Triad. Alongside the speculum, he pioneered a specific surgical method for repairing vesico-vaginal fistulas and established a distinct clinical posture. In the Sims position, the patient lies on their left side with the right limbs fully extended and the left limbs fully flexed. Gravity naturally pulls the uterus forward and separates the vaginal walls, completely eliminating the need for an anterior wall retractor. When an assistant isn't available, we use Cusco's bivalve speculum. A built-in screw mechanism locks the blades open, making it self-retaining and freeing the surgeon's hands for outpatient procedures like pap smears or IUD insertions. The trade-off is a severely restricted working space that completely rules out major vaginal surgeries. For maximum surgical exposure, Avard's speculum relies on a heavy lead weight and a blade angle of less than 90 degrees. Gravity anchors it firmly against the posterior wall. Because this places extreme tension on the vaginal tissues, it is reserved for use under general or regional anesthesia to prevent severe pain. When moving deeper into the pelvis, abdominal and pelvic retractors are classified by their shape and target. Landon's L-shaped retractor protects the bladder during vaginal surgeries. Doyen's broad, curved blade does the same during abdominal approaches. The flat Morris retractor holds back the abdominal wall, and the question mark-shaped Devers retractor pulls deep organs safely out of the operative field. Selecting the right exposure instrument is a calculated equation. The surgeon must balance the necessary operative space against the patient's anesthesia status and the physical presence of an assistant. Once we have exposure, we have to grip the tissue. Almost every gripping forceps in this field features a ratchet lock to maintain sustained pressure. One rare exception is Chittle's forceps, which relies on a lock-free, curved tip explicitly to transfer sterilized instruments out of a boiler without contaminating the batch. For a firm, non-pregnant cervix, we use the Wilcellum forceps. Its multiple rat teeth securely bite into the anterior lip. However, for a nulliparous woman with a tightly closed os, this would cause severe lacerations. Instead, we switch to the tenaculum's single atraumatic tooth. It is easy to confuse the Wilcellum with the Alice tissue forceps, as both have teeth. But where the Wilcellum is long and concave for reaching the deep pelvis, the Alice has short, straight blades that curve inward at the tip,
optimizing it for gripping dense, tough layers like the rectus sheath or the vaginal vault. There is an absolute contraindication for these toothed instruments. Never apply them to a pregnant or immediately postpartum cervix. Pregnancy triggers massive hypervascularity and profound tissue softening. A single tooth will tear through the flesh and cause massive bleeding. To manage the pregnant cervix safely, we default to sponge-holding forceps. Their smooth, non-toothed, ring-shaped ends provide enough friction to hold the tissue securely without piercing it, preventing catastrophic cervical hemorrhage. We measure uterine depth with the uterine sound. Its shaft has calibrated markings to confirm a normal 6 to 8 centimeter length, while a blunt olive tip prevents perforation. It differs entirely from a bladder sound, which lacks calibrations and features a gentle, gradual curve. If a uterine sound does happen to perforate the uterine wall, the protocol is strict. Stop the procedure, observe the patient, and monitor vital signs. Because the instrument's profile is so narrow, the puncture is usually benign and rarely requires emergency laparotomy. Once the depth is known, we can expand the cervical canal using Hagar's dilators. Their exclusive anatomical target is the internal os. They do not travel to the fundus, and they cannot measure uterine depth. We dilate according to strict parity limits, up to size 12 for non-pregnant women and up to size 16 for multigravida patients. If a size 8 Hagar's dilator passes through the internal os of a non-pregnant woman without any mechanical resistance, it clinically confirms a diagnosis of cervical incompetence. Dilating the internal os is acutely painful and can trigger vasovagal shock. We mitigate this with a paracervical block using lidocaine, injecting at the 4 and 8 o'clock or 2 and 10 o'clock positions.
We completely avoid 3 and 9 o'clock because striking the descending cervical arteries located there risks massive intravascular hemorrhage. Mistaking a dilator's mechanical purpose for a sound's measurement function is a dangerous error. Forcing a rigid dilator past the internal os to check the depth will inevitably drive it straight through the uterine wall. When we need to remove tissue from the cavity, we use a uterine curette, which features 2 distinct functional ends. The blunt end is reserved for the soft, friable tissue of a pregnant uterus, such as clearing a missed abortion. The sharp end is deployed for fibrotic, non-pregnant pathology, like evaluating abnormal uterine bleeding. For dedicated cancer screenings, we use Novak's endometrial biopsy curette. It has a toothed distal opening that scrapes and traps tissue, alongside a proximal stylet to flush the sample out. Because it is highly targeted, it allows for anesthesia-free screenings directly in the outpatient clinic. For section evacuation, we rely on the flexible plastic Carman's cannula. The clinical rule of thumb here is a direct mathematical match. The cannula's diameter in millimeters should exactly equal the patient's gestational age in weeks. The cannula attaches to a vacuum source. The manual vacuum aspiration, or MVA syringe, uses 2 pinch valves to generate 660 millimeters of mercury of pressure, holding a 60 milliliter capacity for pregnancies up to 12 weeks. You can distinguish it from a menstrual regulation syringe, which only has 1 valve, a 50 milliliter capacity, and a strict upper limit of 6 weeks. If a pregnancy has progressed past 12 weeks, the fetal tissue is too large for suction. This requires the Hayward-Smith ovum forceps. It deliberately lacks a ratchet lock so the surgeon can continuously feel the grip pressure, ensuring they don't crush the uterine wall. The operator must always rotate the forceps prior to withdrawal to guarantee no maternal tissue is caught in the spoon-shaped jaws. Selecting an evacuation instrument is an exact equation. The surgeon must actively balance the gestational age and expected tissue volume against the structural integrity of the surrounding uterine muscle. Heavy crushing clamps achieve hemostasis by crushing vascular pedicles. Kosher's forceps and Mangot's clamp look identical, but are defined by blade patterns. Kosher's features continuous transverse serrations, whereas Mangot's employs a distinct longitudinal groove on one blade and a matching bar on the other. During an abdominal hysterectomy, these clamps are applied in a strict anatomical sequence to secure the blood supply. First the round ligament and tube, then the uterine artery, followed by the cardinal ligament, and finally the uterosacral ligament. If we need to handle delicate tubular structures without crushing them, we switch to Babcock's forceps. Its distal tip has no teeth and maintains a distinct gap when closed,
creating an atraumatic ring that perfectly encircles a fallopian tube or a ureter without restricting its blood flow. Cutting tissues require similar specialization. Heavy Mayo scissors cut tough aponeurosis. Long, pointed Metzenbaum scissors handle delicate peritoneal dissection. And the unique, sharply angled blades of episiotomy scissors are engineered specifically to navigate the perineum, though the World Health Organization strongly advises against their routine use. For localized hemostasis during a myomectomy, we apply Bonnie's myoma clamp across the isthmus. It features a unique double set of finger grips. The proximal pair locks the clamp to compress the uterine artery, while the distal pair allows the surgeon to easily release that pressure. This release must occur exactly every 15 minutes to prevent irreversible ischemic necrosis of the surrounding tissue. Historically, fetal heart sounds were monitored with the cone-shaped Pinard fetoscope. Its inventor, Adolphe Pinard, lent his name to a specific breech delivery maneuver, and Pinard's living ligature, the physiological mechanism where crisscrossing myometrial muscle fibers naturally compress blood vessels, stopping postpartum bleeding. When assessing tubal patency, we inject radio-opaque dye using an HSG cannula. The Leach-Wilkinson cannula uses a funnel shape to accommodate a multiparous cervix, while Rubin's cannula fits the narrow nulliparous Haas. Pre-procedure analgesia is mandatory. Without it, the pain of the injection triggers a physiological corneal spasm, creating a false bilateral block on the resulting X-ray. Surgical success in these advanced interventions hinges on mitigating physiological reflexes, whether you are blocking pain to prevent a tubal spasm or timing a clamp release to prevent tissue death. Clinical mastery is proven by instantly diagnosing an instrument's purpose from a single microstructural feature. Rule 1 is the lock test. If an instrument lacks a ratchet lock, it is one of two things: Chittle's forceps for transferring sterile equipment, or ovum forceps for atraumatically evacuating tissue. Rule 2 is the gap and teeth test. If the forceps have teeth and a gap between the blades, look at the curve. A long, concave blade means it's a Westellum for the cervix. A short, straight blade that curves inward means it's an Alice for tough fascial tissue. When evaluating gestational limits for evacuation tools, refer to the 2020 MTP amendment in India. It extended the upper limit for termination to 24 weeks, requiring one doctor's opinion up to 20 weeks and two doctors between 20 and 24 weeks. And the most critical safety boundary to remember: cervical dilators stop at the internal os. Only uterine sounds safely navigate to the fundus. Every instrument in the OB/GYN toolkit serves as a physical, steel extension of pelvic anatomy. These designs reflect the specific physiological limits of the patient, ensuring that every millimeter of steel has a dedicated clinical purpose.